and you have treatment issues lah. Okay. Okay, for next, kita go for assessment and diagnosis. Mainly we go by biopsychosocial and diagnostic criteria yang kita guna. So for biopsychosocial assessment is essential in diagnosis of schizophrenia. Selalunya actually kita dekat psychiatry ni tak adalah guna apa ni bini or skit ni macam as if benda tu as a diagnosis. Mainly kita akan rely on history taking. So assessment of people with possible schizophrenia have to consist of thorough history taking, physical examination, MSE, which is mental state examination, and also investigation lah where indicated. So this ada apa ni assessment yang kita gunakan especially in BPRS or PANS. Kalau siapa-siapa pernah tengok, selalunya digunakan untuk assess severity of the patient lah in terms of dia punya function or dia punya symptoms wise. Selalunya untuk diagnose schizophrenia, we need a thorough history and also mental state examination. So for criteria of diagnostic classification, this is what we use based on the history and based on this criteria, kita akan tengok whether it fits ke tak untuk diagnosis of schizophrenia. So yang terbaru adalah kita guna DSM-5, Diagnostic and Statistical Manual of Mental Disorders. Mainly kat hospital guna yang ni lah. Although kalau kita ikutnya ICD-10 tu lebih digunakan dalam kita buat case apa ni untuk report dekat hospital kan. They use ICD-10 actually. So somehow kadang-kadang tu you kena apa ni convert dia ada coding dia tu. So you kena convert the coding. And saya pun tak berapa menghafal lagi ni DSM-5 and then sekarang nak keluar DSM-5 TR pula. Sebab masa zaman saya belajar tu saya guna DSM-4 TR. So tiba-tiba dia dah jadi DSM-5, belum nak ingat sangat pun dia dah keluar, dia nak keluar DSM-5 TR pula. Okay, kita tengok apa beza schizophrenia by DSM-5 dengan schizophrenia by ICD-10. Kalau ikut dia punya DSM-5, ada at least kena ada 2 lah daripada symptoms yang telah dinikan. Simptom dia biasalah hallucination, delusion, disorganized speech, disorganized behavior or catatonic behavior, and also the negative symptoms. So kalau cukup dua symptoms ni yang present selama at least sebulan, tapi kena continuous disturbance, maksudnya kena ada disturbance lah, mungkin sekejap dia okey, sekejap dia tak okey, ataupun dia ada residual symptoms yang continuous untuk 6 bulan, kita boleh plus dengan ada dysfunction in social or occupational. So kalau tak ada yang ni, kata ada dengar suara lah, ada delusi lah, tapi masih boleh bekerja, bersosial dengan orang macam biasa, kemungkinan kita tak boleh nak diagnose schizophrenia lah. Dia kalau ada mental illness, you have to have this criteria lah, kena ada dysfunction in social or occupation, ada symptoms, cukup dia punya duration, dan kita boleh diagnose schizophrenia. Compared to ICD-10, it is actually easier to diagnose in ICD-10 sebab dia ni at least sebulan je. Okay, so kalau you use ICD-10, lagi ramailah orang guna akan didiagnose as schizophrenia. Tapi selalunya DSM-5 tu kita guna as dalam untuk research lah, senang untuk buat research, senang to use DSM-5. Okay, symptoms dia lebih kurang sama. Dekat ICD-10 dia ada include apa ni first rank symptom as well. Untuk orang yang tak tahu persiang simptom tu, mungkin boleh check kot. Okay. So, take note yang saya cakap tadi, disease severity is assessed based on presenting psychopathology and risk assessment to self and to others, and psychopathology may be assessed use of severity or the severity using PANS or BPRS lah. So for symptoms mainly by history taking. Okay. Okay. So next after patient dah apa ni fit criteria for schizophrenia kan. So we look for treatment. What are the treatment available for a patient with schizophrenia? Okay. Modalities of treatment can consist of this lah. First is pharmacological intervention, physical intervention, psychosocial intervention. Service level intervention ni mainly to special things lah. Nanti kita tengok Okay, for patient with schizophrenia who present early or first time at primary care, should be provided with this following lah: assessment and early treatment, early referral to specialist care, initial treatment, collaboration with hospital-based psychiatric service. And this dalam CPG tu dia letak lagi registration of cases at health clinics. Tapi saya rasa setakat ni memang kita dah tak ada notify lah. Setakat ni macam dah stop. Saya rasa mungkin yang ni daripada CPG 2009 lah. And then kalau ikutnya, that's a guideline for mental health service in primary care. Kat sini ada tulis garis panduan perkhidmatan rawatan sosial pesakit mental di klinik kesihatan 2009. And ada satu lagi yang lagi lama ni, tahun 2000. Pemulihan psikososial bagi pesakit mental. Saya tak pasti sebab saya tak pernah tengok. Kalau orang daripada mana-mana KK kesihatan yang pernah tengok ke boleh share kot. Sama ada diorang pernah tengok ke ataupun diorang pun tak pernah dengar benda ni. Okay. For pharmacological intervention, the main pharmacological intervention for schizophrenia is obviously antipsychotic lah. Antipsychotic. So first antipsychotic found secara tak sengaja is actually chlorpromazine. Saya tak ingat ubat ni actually sebenarnya nak digunakan untuk apa. As antihistamin ke apa, saya tak pasti, tak ingat. Tapi secara tak sengaja didapati boleh mengubati skizofrenia pada tahun 1952. So antipsychotic ni dia acts by ada positive symptoms of on positive symptom of schizophrenia lah. Tadi ada saya lupa nak cakap, tadi ada positive symptoms and negative symptoms kan. Okay, so positive symptom tu mainly yang hallucination, delusion. So yang negative symptom yang semua yang tak nak cakap, evolution, benda-benda macam tu lah. So yang negative symptom tu yang tu. So antipsychotic mainly dia act on positive symptom of schizophrenia by blocking D2 dopamine receptor. So dia block D2 dopamine receptor ni, then dia akan ada improvement in positive symptoms. So antipsychotic boleh diklasifikasikan kepada dua. The first generation antipsychotic and also the second generation antipsychotic. Mainly sekarang kebanyakannya kita guna second generation antipsychotic because dia ada less side effect in term of movement disorder lah. First generation antipsychotic banyak problem in movement disorders yang ada tadah dyskinesia semua tu lah. Okay, so for a treatment of acute schizophrenia, meaning that's the acute phase of schizophrenia, recommended optimal oral dose of antipsychotic is 2 or 3 times minimum effective dose, and the side effect should be closely monitored lah. In relapse prevention, standard dose should be used. So kalau untuk dia ada acute presentation of psychosis, ada relapse, so you have to use a higher dose of antipsychotic compared to orang yang on maintenance. So antipsychotic also should be used at least 6 to 8 weeks before kita try switch to other antipsychotic. Sebelum kita nak tahu patient tu sesuai ke tak, improving ke tak, with antipsychotic ni, we have to use at least 6 to 8 weeks lah before switching to other. Okay, this is choice of antipsychotic. Saya tak pasti semua orang familiar ke tak dengan antipsychotic. Okay, first generation saya cakap tadi yang chlorpromazine kan. So dia ada benda lain lagi lah, flupentixol, fluphenazine, haloperidol. Saya rasa haloperidol ni glamour kot. So kalau tak ada orang KK tak tahu haloperidol juga, saya tak pastilah macam mana. Fluphenazine, sapiride, trifluperazine, chlorpentixol. Yang flupentixol dengan fluphenazine ni kita sebenarnya banyak guna untuk depo. Flupentixol is clopixol, fluphenazine is fluanzol. So this is the first generation antipsychotic. Kalau dekat KK, I think haloperidol mostly ada kot ni. Ke tak ada? For second generation antipsychotic, yang ni banyak lah. We have a lot of second generation antipsychotic. Yang paling bawah ni yang macam yang lama-lama yang keluar awal-awal dulu. Risperidone, olanzapine, quetiapine. Saya pun tak familiar with kalau ikut ni dia ada dekat Malaysia ni, tapi saya pun tak familiar with brexpiprazole ni. I think is quite baru. And cariprazine ni saya tak sure, saya pun tak pernah dengar. Tapi all others tu are available lah. Available dekat General Hospital. Cuma kita jarang guna ziprasidon. Setakat ni saya rasa kita tak ada guna ziprasidon. Kalau dekat HTA lah. Brexpiprazole ni kita tak ada. Cariprazine ni memang kita tak ada lah. KK mostly akan ada risperidone. Sebab dia consider a bilis ubat. Yang lain tu ALIS. Okay, so take note yang dalam peta kuning ni, AP is the mainstay of pharmacological treatment for schizophrenia lah. So kalau apa ni, macam saya cakap tadi, SGA selalunya lower in risk of EPS compared to first generation lah. Dia kurang the movement punya disorder tu. Tapi SGA ada different side effect lah, mostly metabolic syndrome. So patient yang gain weight, ada dyslipidemia and also glucose intolerance, kita kena check profile dia macam mana lah. And kena check, sebenarnya kena check at least 6 monthly macam tu. Okay. So for your use of medication in acute exacerbation of schizophrenia, we can use rapid tranquilization lah. It used to calm patient, not to induce sleep. So kita boleh assess accurately by healthcare providers. Tapi kalau untuk patient yang ada tiba-tiba agresif ke apa kan, kalau dia not known to have schizophrenia or other mental illness, you kena be careful juga untuk give antipsychotic. Sebab kadang-kadang patient yang naif tak pernah on antipsychotic, tiba-tiba you bagi antipsychotic, dia boleh develop side effect lah yang kita tak nak, especially NMS, neuroleptic malignant syndrome. So you kena be careful. Kalau patient yang datang dengan aggression ke, mengamuk ke apa ke, tapi known to have schizophrenia, probably you can use haloperidol. Tapi kalau tak known to have that, mungkin you kena fikir of using other thing macam benzodiazepine. Tapi ada setengah patient walaupun bagi antipsychotic, dia tak jalan, tak terjejas langsung. Tak ngantuk langsung, tak tidur langsung, tak boleh nak ni langsung. So selalunya kita akan combine antipsychotic dengan benzodiazepine. And usually kita akan bagi parenteral lah. Parenteral. Jarang kita bagi haloperidol. Actually kalau dulu ada orang bagi IV haloperidol, tapi dulu ada circular saying that we cannot give haloperidol by IV punya intravenous ni, sebab dia boleh cause heart punya condition. Dia boleh trigger heart condition, so you should be careful. Usually we give IM haloperidol lah compared to IV haloperidol. Okay. So selalunya macam saya cakap tadi, kita boleh combine. Kita boleh bagi IM halo plus IV diazepam, tapi ada setengah-setengah orang guna IM midazolam juga. Okay. So we also use depot or long-acting injectable antipsychotic in achieving remission for certain patients. Sebab kebanyakannya patient schizophrenia ni ada masalah dengan to comply with the treatment. And then memang kita known to have that problem lah. And then banyak masalah jugalah untuk difikirkan untuk bagi patient supaya adhere to ubat kan. Even patient yang ada medical condition pun, DM hypertension pun tak makan ubat betul-betul kan, selalu je tak makan ubat. So patient yang ada schizophrenia lagi tak nak makan ubat because they think they are not sakit anymore. Lepas makan ubat sihat, dia not sick anymore, so dia tak nak makan ubat. So kalau kita tengok 50 to 70% people with schizophrenia ada masalah treatment non-adherent lah, termasuk dengan failure to enter treatment program, susah nak datang untuk treatment, defaulting outpatient clinic appointment, and also ambil ubat tapi makan tak betul, makan sekejap makan sekejap tak makan bila tak okey je, benda-benda macam tu. Memang banyak, lebih pada 50%. So kalau ikut kita tengok from study meta-analysis, it shows that depo ni ada higher remission rate lah compared to oral antipsychotic. Cuma ada setengah-setengah IM depo boleh cause EPS punya symptoms and also prolactin related adverse effects lah, especially in first generation long acting antipsychotic macam saya cakap tadi, clopidogrel or fluonazole. So apa yang available untuk depo long acting antipsychotic, inilah kita ada few. Fluphenazine, decanoate, which is fluonazole, fluphenazole, kita panggil clopidogrel, nama label dia. Kalau sebut nama generik ni kadang orang tak ingat. Zuclopentixol, dekat HTA tak ada. Setakat ni memang saya tak pernah guna zuclopentixol as depo injection. Risperidone microspheres ni I think this is Consta. This is Consta. Pelik lah pula dia guna microspheres. Ha? Clopixol. Oh, ya, saya tersalah ni. Zuclopentisol, this is clopixol. This is modicate. One of this is modicate. This is fluanzol, this is modicate. Fluphenazine is fluanzol, flupentisol is terbalik. Fluphenazine is fluphenazine is modicate, flupentisol is fluanzol. Sorry. Saya tersalah. Saya pun confused juga ni. So yang terbaru, yang second generation is this lah. Risperidone Consta, paliperidone palmitate, which is ya Allah, top block tak lah. Sustena and aripiprazole. This is Maintena, coming. Kita katanya dah ada tapi kita tak inject lagi patient kita kot rasanya. Okay, this is the newer, this is the older punya ubat. Okay, so for antipsychotic in relapse prevention from Cochrane, it is better untuk prevent relapse in schizophrenia lah. Kalau compare to patient yang tak ambil ubat dengan patient yang ambil ubat, it is better untuk prevent relapse. So kita nampak they have a reduce hospitalization, lessen aggressive behavior and also improve quality of life. Cuma diingatkan kadang-kadang patient walaupun comply, they do have relapse. Bukan maksudnya bila tak makan ubat, bila makan ubat tu tak boleh relapse langsung. They do relapse, cuma relapse tu mungkin less severe or kurang compare to kalau tak makan ubat. Kalau mungkin dia relapse sekali setahun, probably kalau dia makan ubat dia relapse lagi lama daripada tu. Sebab kadang-kadang family macam bising kan, makan ubat pun sakit juga. So it's not that bila you makan ubat definitely you tak ada relapse. No, it's just they control the symptoms lah. And then you have more quality of life. So kalau those yang ada ambil intermittent treatment in relapse prevention, kadang ambil, kadang tak ambil, memang dia tak galakkan lah, kena avoid because dia takkan berkesan as you ambil as a maintenance therapy. So kalau yang ambil intermittent treatment tu, they noted that there is higher relapse, higher hospitalization rate, and walaupun you ambil sekali-sekala, tak ada difference in having tardive dyskinesia. Okay, treatment for, we know that antipsychotic can cause a side effect, especially the first generation antipsychotic in EPS. This is mainly the first generation selalunya causing extrapyramidal symptom. The rest, sedation and weight gain selalunya associated dengan second generation antipsychotic, the newer one. Okay, you can look at this table lah. I won't go through detail satu-satu. You boleh tengok from the table. Dia ada dalam, it's a draft kan, so you boleh tengok lah. Mana yang satu yang causing weight gain, mana satu yang boleh causing prolactin elevation, hypotension. So you kena tengok patient ada comorbidities lah. Kalau patient ada diabetes, you bagi ubat yang causing higher side effect sort of weight gain. Apa lagi? Ada lagi kat bawah nanti. So kena avoided lah, macam contoh olanzapine, patient tu ada diabetic tak control and then you give olanzapine. You know olanzapine can cause metabolic syndrome, so you kena avoid lah kalau boleh. Okay. This is other side effects yang boleh tengok, mainly the movement punya side effect, constipation. This is selalunya the first generation punya antipsychotic. Okay. So see the diabetes mellitus, kalau ikut dia ada, this is a choice nak tukar apalah management dia. Okay. Okay, one of the tadi saya sebut yang table kat atas tadi, yang all the side effects yang boleh ada, and then ada this one side effect yang rare lah. Rare tapi I've seen few patient who have NMS, ada yang tak survive. Sebab NMS ni is a rare medical emergency. Be reminded, NMS is medical emergency, so it should be treated as a medical emergency, because it is life-threatening caused by antipsychotic. Selalunya characterized by fever, rigidity, tremor, sympathetic nervous system, dysregulation, and also creatinine kinase elevation lah. So kena got immediate diagnosis, and treatments are essential. Selalunya the patient have to be referred to medical team because probably they need to stand by on ICU backups or even dialysis. So this kena ingat, this is all, NMS is a medical emergency. Neuroleptic malignant syndrome. Kalau those yang tak tahu what is NMS. So for physical intervention, we have medical pharmacological intervention, then we have physical intervention. So physical intervention in psychiatric treatment mainly is ECT, electroconvulsive therapy. Selalunya kalau orang sini, orang kampung panggil current otak. Because I don't know what better words to put ECT ni. Selalunya kalau layman faham lah kalau kita kata current otak tu. It means you give control electrical punya wave so that it can induce seizure for patient. From study, there's a rapid improvement and reduction of symptoms with ECT selalunya. Kalau patient yang ada limited response to antipsychotic, selalunya patient dalam ward kalau datang with acute presentation of psychosis, kadang-kadang tu even with antipsychotic started pun patient tak respond much, causing aggression, risk to others. So to have a rapid improvement, sometimes we do have to do ECT. So it's also stated that combination of ECT with antipsychotic may be beneficial in treatment-resistant schizophrenia. Sometimes we do have to give both lah, antipsychotic and also ECT. I remember there's one patient yang ada treatment resistant schizophrenia memang selalu masuk ward. Patient ni sangat impulsif, memang fuse yang yang kena just kena baling barang, kena macam-macam lah. Patient ni sangat agresif, and then we do give maintain an ECT actually. Kita maintain the ECT two weekly ke 1 weekly ke with antipsychotic. Tapi alhamdulillah patient ni dah okey lepas masuk nursing home. Saya tak tahulah macam mana dekat nursing home tu buat, tapi alhamdulillah patient ni okey. Okay, there's another physical treatment called transcranial magnetic stimulation. Basically dekat kalau neuro ada kot, saya tak pasti neuro dekat HTA ni ada ke tak, TMS. Dia kalau from study it says that ada effect on positive symptoms on PANS tadi lah, severity of the symptoms tu ada dia ada effect on positive symptoms of schizophrenia, and it's also improve global state of CGI skill. Cuma benda ni digunakan as adjunct therapy. We don't have this. Setahu saya dekat Permai ada TMS, and then they do use this to be given as an adjunct therapy lah. I remember that patient yang saya cakap tadi, Permai ada pernah buat jugalah TMS untuk that patient, tapi tak berkesan. So there's another transcranial direct current stimulation. This one I don't really know about this, but from meta-analysis they found that there's no effect on this lah. So yang ada kesan for improve symptoms of schizophrenia is usually ECT. Dekat HTAA it's ECT. So far kita ada dekat HTAA je machine untuk buat ECT tu lah. So kalau ada district, selalunya kalau patient warranted untuk buat ECT, diorang akan hantar ke HTAA untuk buat. So ECT may be considered in schizophrenia untuk achieve rapid and short-term improvement of severe symptoms after kita dah try for antipsychotic and tak effect, tak berkesan lah. And also in treatment-resistant schizophrenia. Tapi ECT ni bukan digunakan untuk schizophrenia, patient schizophrenia saja. ECT pun boleh digunakan untuk yang ada strong suicidal intention. Also tu ada tu ada indication lah. Tak semestinya untuk schizophrenia je. So we go for psychosocial intervention. Saya ada masa sampai pukul 10:30. Sejam lagi. Okay. Saya takut saya mengambil masa orang, taklah. Okay. So selain pada physical, we have psychosocial intervention. These are the things that we use for psychosocial intervention. There are a lot of things yang kita boleh buat lah. Tapi saya akan explain yang ada ni je. Yang mesti kita nampak dia punya effect lah. Okay. So first we go for psychoeducation. From study as well, they found that psychoeducation improve understanding of mental illness, and then also teach patient or family members to recognize early warning signs of relapse and also understanding of psychiatric service work lah. So psychoeducation program ni selalunya include ada orang minta dah ni ke? Ada orang request untuk ada. Okay. Psychoeducation programs that includes key information about diagnosis symptoms. Okay, kita akan ajar patient and family members untuk recognize apa symptoms schizophrenia. So apa yang perlu di observe. Macam mana nak kalau awal-awal nak ada relapse tu, what are the signs and symptoms yang patient akan alami, supaya diorang lebih aware dengan earlier signs lah, bukan dah teruk baru nak bawa ke hospital. So just symptoms, just like macam selalunya kalau untuk patient schizophrenia ni, dia boleh start dengan poor sleep je, susah nak tidur ataupun tiba-tiba jadi diam ke apa ke. So benda tu pun dah boleh jadi indication of early signs of relapse ke. Okay, it is and then psychoeducation juga kita akan bagi tahu family members macam mana nak deal kalau patient noted ada to have early signs, macam mana nak buat, bila perlu bawa ke hospital, bila perlu seek medical punya condition, medical punya treatment. So they noted also psychoeducation was a better standard care in coping with family burden. So kalau kita psychoeducate family members on apa itu schizophrenia, then family can be more understanding to the disease itself lah. Okay, selain pada psychoeducation, ada psychosocial intervention is supported employment. Okay, what is supported employment? Supported employment ni is a program dekat psychiatry yang we help patient in searching for job. Selalunya kita akan assess dulu the patient yang suitable, yang ada keinginan untuk bekerja. Kita akan assess and then we see the interest, sama ada dia nak kerja ke tak, and we try to cari kerja yang bersesuaian lah. So sebolehnya kita akan cuba letakkan pesakit di pasaran kerja yang normal lah, bersama pesakit, bersama community. Okay, and then kita akan pantau and kita akan visit pesakit tu, and sebolehnya kita akan dapatkan kerjasama daripada employer lah untuk kita buat pemantauan. Sebab kadang-kadang selalunya employer takut nak ambil pesakit yang ada skizofrenia kan, takut mengamuk lah, apalah, stigma lah, benda-benda macam tu. So kadang-kadang employer tak faham, so So kita punya kerja adalah bagi pemahaman, bagi that employer rasa safe untuk ambil pesakit yang ada masalah psychiatry untuk bekerja. So kalau anything happen, they have tempat untuk apa ni, reach. Kalau patient tu ada masalah ke, ada early signs of relapse ke, employer tu ada tempat untuk dituju. Compare to you bagi patient tu kerja and then you tak monitor langsung. So in apa ni, in HTAA we have supported employment unit yang diketuai oleh mainly OT lah, occupational therapy, and then recently we have started a restart program. It is a collaboration between psychiatry and also Perkeso, where we liaise with Perkeso lah. So any patient yang ada mental illness akan dirujuk ke restart. And then kita akan cuba cari kerja untuk patient tu bersama-sama dengan Perkeso. So it's easier because Perkeso ada a lot of experience in cari pekerja untuk pekerjaan kan. So they also have a lot of they also have a lot of bank job macam tu lah. They last with many people, so yang tu lagi easier compared to us doing it alone. And so we have started currently, I think saya tak ingat dah ada berapa patient kita under restart program. We have been doing it for I think early this year lah. Kan saya pernah tak ingat. So another psychosocial therapy is cognitive remediation therapy. It is a behavioral treatment intervention aims to improve cognitive process. Cognitive process tu selalunya melibatkan memory, attention, executive function, metacognition and also social cognition. Sebab selalunya we can see that patient with schizophrenia have a lot of cognitive decline. So cognitive remediation therapy can be used untuk improve this thing lah. Tapi from meta-analysis, it demonstrate that a moderate effect lah on CRT. So bukan semua juga orang yang boleh buat benda ni. So it has to have a certain individual yang boleh buat untuk patient. So that's why the recommendation is may be considered for patient with cognitive difficulties, because it needs a patient, a person with some skill to do this. So all other yang after this is mainly benda yang selalu kita buat lah. Maybe social skill training, contohnya untuk apa ni, improve social functioning, improve mental state, and also prevent relapse lah. Although kalau ikut paper ni dia very poor quality lah. Tapi social skill training ni macam kat patient dekat ward pun kadang kita buat benda tu jugalah, social skill. Sebab kadang-kadang diorang memang lack in social skill lah. Kadang nak kena pilih baju lah apalah, itu pun boleh dijadikan as a social skill punya juga. Okay, others is CBT. Okay, CBT is a cognitive behavior therapy. So far, lalunya digunakan untuk orang yang ada cognitive errors lah. Ada cognitive errors, selalunya kita boleh guna cognitive behavior therapy. Tapi for CBT in patient with schizophrenia is a bit challenging lah. So kalau apa ni, in schizophrenia dia aim untuk problem solving and then modify dysfunctional thinking and behavior. I know that it's a bit difficult untuk buat CBT, especially patient with schizophrenia. Even kalau kita nak buat CBT in patient with anxiety disorders pun susah. CBT in panic disorder pun sometimes kalau orang yang tak cognitively psychological minded macam tu, kadang memang a bit challenging. So I faham that the CBT in patient with schizophrenia can be a bit more challenging than other patient. Okay. And supportive psychotherapy. Ini biasalah, memang selalu kita buat lah ni. Ini the usual plan selalunya. Plan dekat klinik lah, supportive psychotherapy, counselling. This can be done to anyone lah, and then actually can be given by anyone. Cuma mungkin tak biasa, so you don't know how to do it. Okay, ada terapi yang ni anyone can do. Actually, there's not much evidence based on the study. They cannot say that it has much impact on improving patient punya symptoms, but this is all can be done by anyone, even though a person yang tak ada mental illness pun, as a stress reliever. Okay, life skill training, exercise therapy, dance therapy is actually good to ask patient to do exercise therapy, because it boosts your neurotransmitters and also endorphin. So even though patient tak ada schizophrenia pun, to anyone pun, you can actually prescribe exercise therapy to your patient. Okay, music therapy, religious and spiritual activities. Because religious and spiritual activities ni is a known factors yang boleh jadi kita kata protective factors lah untuk patient from buat benda-benda yang lagi is a protective factor lah, macam contoh untuk suicide ke apa ke, benda-benda macam tu. So religious and spiritual activities ni sometimes perlu untuk certain orang. Okay, so next we go with service level intervention. If you have any question, boleh post code. Nanti saya akan address. Okay? If you have anything about any question about treatment. So service level intervention, mainly we'll see few benda yang kita kena tengok. Satu is crisis and emergency service. Okay, sebab patient with schizophrenia boleh ada acute symptoms kan, acute symptoms, ada relapse, and then this crisis and emergency mental health service provides intensive care in the community for people with acute psychiatric symptoms. So thus avoiding the need for hospitalization. from Cochrane, they showed that crisis and emergency service can reduce readmission, reduce days of acute care post-crisis, lessen family burden, family satisfaction is also higher. So there's a significant higher patient satisfaction as well lah. Tapi so far dekat kita, dekat apa ni, crisis and emergency service ni, mainly yang banyak dekat Permai. Dekat Permai they have this acute care, kita panggil acute care lah, acute care service where there are on-call people who go to other to into the community 24 hours kalau ada reports that patient in crisis ke, patient ada symptoms ke. So they do have that. Kita tak ada that luxury untuk to do such service because it needs sumber manusia yang lebih untuk orang on call, untuk kenderaan as well, untuk keluar pergi to houses. Okay, mainly dekat Permai. So apart from that acute care, we have this assertive community treatment where we provide continuous care for people with serious mental illness in community, especially those who have difficulty engaging with mental health service. So selalunya this one from study that they noted that the higher adherence to medication, so patient pun ada receive psychotherapeutic treatment conducted by the ACTT. Okay, there's a significant reduction of inpatient treatment. So there's also clinical improvement based on tadilah BPRS, JAF semua tu. So selalunya kebanyakan daripada patient yang ada skizofrenia ni ada masalah nak datang ke hospital. Jauh lah, tak ada orang lah nak bawa. And then ada sometimes yang even don't have family members ke untuk bawa pesakit ke klinik atau ke klinik untuk rawatan. So we do have a team yang pergi buat continuous care dekat rumah lah. Untuk depo injection, untuk review patient punya symptoms. Kalau patient tu in the early stage of relapse, sometimes we do go and see patient more regularly lah. So maknanya lagi tengok patient. Ideally sepatutnya kita boleh pergi lebih daripada sekali sehari. Tapi kita tak boleh, tak mampu untuk buat macam tu lah. Saya pernah buat attachment dekat Alustar dulu.
Kalau misalnya
years before lah. They do have a team yang pergi at least 2 kali sehari for patient yang tak berapa stabil, and they do give injection at home. Tapi that one needs to be monitored. So that's why they need more people to do it, and more financial punya nilai in terms of kenderaan. So kalau kita boleh work through dengan KK yang berdekatan, yang tu lagi bagus. Sebab sometimes patient is a bit far from the facility, so susah untuk kita pergi berulang kerap. So we do need to liaise with other other facilities. So we have to see that key element of ACT, selalunya dia ada a team, a multidisciplinary approach involving psychiatrist plus the team. A team tu selalunya involve of medical officer, all the paramedics, as a case manager, and we do include OT, and sometimes we bring social welfare officer as well to see patient at home. Okay. Okay. Intensive case management. Actually semua ni kita consider as community psychiatry lah. The ACT, the crisis intervention, intensive case management. Tak ada betul-betul model yang spesifik untuk kita ikut. It has to be based on that tempat accessibility. Maksudnya berapa banyak staff yang dia ada kenderaan ke tak untuk keluar, berapa kerap. So it has to be tailored to that place untuk kita buat community psychiatry lah. Okay, this one as well from it is community-based service intervention, mainly lebih kurang macam saya cakap tadi lah. Di community-based psychiatry, cuma dia ada yang acute, ada yang kita boleh consider as maintenance punya treatment, pergi monthly visit untuk injection. So it's all fall into community-based psychiatry service, and then from study you can see there's a better score lah in terms of general function in PANS, and also ada symptoms of schizophrenia. Okay. Day hospitalization and day treatment. Yang ni kalau ikut from Cochrane systematic review ni, found that people with schizophrenia allocated to daycare hospital care had less admission to hospital lah beyond 1 year compared to those receiving outpatient care. Day treatment or day hospital ni I think dia involve yang dulu punya model yang PSR tu, where patient with schizophrenia can go and actually rest there. Kalau dia nak tidur, dia nak duduk kat situ untuk berehat, we let them do that. Tapi so far saya tak sure which hospital yang ada buat this as well, because most of PSR dekat Malaysia ni has been changed to Mentari, which is a unit that unit from the hospital itself. We do buat treatment as well as screening there lah. So most of in fact yang dekat Kuantan ni we have Mentari Balok, which originated from PSR. PSR tu sebelum tu under KK. PSR under KK, tapi bila macam tak berkembang sangat, so somehow that place has been turned into Mentari. So in residential service, we see that the study people with serious mental illness under residential service ada significant increase of numbers they spend in independent or congregate residential living, case management, medication management. There's also significant decline in mean numbers of they spend homeless per year lah. So residential service ni pun kita tak ada. So far yang ada is the institution lah yang ada. Dekat Permai ada, dekat HBUK Tanjung pun ada, where patient tu boleh duduk kat situ. Duduk tapi keluar bekerja, balik duduk kat situ semula. And I think there's one national nursing home for psychiatric patient kot, tapi yang tu is in Sungai Buloh, tapi I don't know dia punya accessibility tu, mainly untuk patient kat sana. I think they don't take patient from other states. So this one we don't have, but macam from the study lah, dia boleh reduce the numbers spend as homeless lah, because patient psychiatry, especially yang those who have schizophrenia, banyak yang jadi vagabond, homeless. So another thing that we can see is early intervention in psychosis. So early intervention in psychosis ni lebih kurang macam yang awal-awal tadi, yang early detection tu lah. So kena ada dose yang tengok dia dulu yang awal-awal, especially dekat primary care lah, KK ke mana ke, kena recognize the first episode of psychosis tu. And then kena ada staff yang build up trust and confidence. Kena ada this good information of psychosis and treatment option. Kalau perlu refer awal-awal. So kalau perlu untuk ubat, refer untuk ubat, untuk start treatment. Or kalau ada choice of psychological intervention kat situ, probably boleh refer as well. So all that yang tadi tu, kalau lagi early lagi bagus. You cannot wait like macam period of 2 years of psychosis baru you nak treat, sebab the prognosis will be less good kalau lagi lama patient ada untreated psychosis tu. Lagi lama, lagi the prognosis is poor. Sebab saya pernah tengok patient dekat Muazzam, I'm visiting Muazzam, ada yang ada untreated psychosis for 10 years baru datang. Sebab katanya tak tahu, anak muda lagi, baru umur 20 lebih. So bila kita tengok tu dia dah jadi chronic schizophrenia dah. So it's sangat unfortunate for that young lady or man lah kan. Kalau they get earlier intervention, then probably they can recover and boleh function as other people. So kalau from that CPG, traditional and complementary medicine tu, dia ada sebut few lah, saya tak nak letak kat sini. Dia ada acupuncture, ada apa lagi, ginkgo biloba kalau ikutnya lah, the taking of ginkgo biloba. Sebab from study there's no there's insufficient evidence to recommend, so saya tak letak lah. You can go and see the CPG, but there's a few yang they mentioned. One of it is acupuncture. Saya dah tak sempat. Okay, this is algorithm that you can follow untuk the diagnosis of schizophrenia. It can be used as a guideline lah. So lagi easier kan to see compare to nota panjang-panjang tu. So this is once kita diagnose patient with schizophrenia, we can see mana satu patient in what category. Acute phase ke stable phase. So apa yang perlu buat? Kalau dekat KK or ada district hospital, you can see kalau patient datang dengan acute phase, apa yang perlu? Perlu bagi rapid stabilization ke tak? Dan use this. Kalau yes, use this. Kalau stable kalau stable, apa yang boleh buat? Sama ada ubat dia okey ke tak? You can use this as a guideline. Okay. So this is also the algorithm for dia bagi dua kan. Satu dia is a primary or secondary care. So the initial phase, actually yang duduk kat primary boleh start pun sebenarnya. You can diagnose and you can start. Tak perlu tunggu. If you confidence that patient has all the psychotic symptoms masuk dalam kriteria DSM-4, DSM-5 or ICD-10, so you boleh start ubat without tunggu nak refer to psychiatry. You boleh start dulu and then you boleh refer. So kalau untuk psychiatry service ni kita tengok kalau ada risk apa-apa, so better refer fast lah, or you are not sure with the diagnosis, then you refer cepat. And then kita tengok daripada dekat psychiatry ni pun, it's actually kalau kita rasa from psychiatric punya service, kalau kita rasa patient tu is stable enough, tak perlu untuk continue psychiatric service pun, kita boleh refer balik tu primary or secondary care. So patient boleh dapat continuation of treatment tu dekat the nearest place yang dia boleh dapat. Sebab kesian kan patient paksa datang jauh-jauh, contoh daripada Chini ke Paluhinai ke, paksa datang HTA atau Muazzam, kena travel lebih daripada 1 hour just to continue the ubat, padahal patient stable. So actually it's better kalau patient boleh pergi to the nearest hospital or klinik kesihatan. So mungkin kita boleh start discharge patient kita yang stable tu kot to the nearest place. Okay. What are the challenges in managing patient with schizophrenia? Okay. One obvious is treatment resistant schizophrenia lah. So patient yang schizophrenia ni yang selalunya my school of thoughts dulu lah. Patient schizophrenia ni kita boleh bagi kepada 3, 1/3. Okay, 1/3 bila kena okay, stable, boleh balik kerja macam biasa, tak ada symptoms pun, nampak macam orang normal. 1/3 lagi still boleh function tapi still ada some residual symptoms yang tak mengganggu lah. They live with it. Still ada delusion, still ada hallucination, but they can control and they can live with the residual symptoms. And then 1/3 tu yang turn into chronic atau ada this treatment resistant schizophrenia. So kalau betul-betul ada definition of treatment resistant schizophrenia, then there's a few criteria that they use lah, tapi tak ada yang betul-betul ni, sebab dia ada few. Dia ada Kane punya Kane punya definition of treatment resistant schizophrenia. There ada guideline yang orang use, tapi selalunya kita define treatment resistant schizophrenia tu bila patient shows no response or partial suboptimal response to trial of 2 different antipsychotic for at least 6 weeks, which each medication tu with adequate dosage of medication. Okay, ada some definition kata with the use of 2 different classes of antipsychotic. Contoh, 2 different classes. Contoh senang. You use first generation antipsychotic, tak jalan. Lepas tu you tukar to second generation antipsychotic, tak jalan juga. Then after educate, those tu boleh di-consider as patient having treatment resistant schizophrenia. Tapi selalunya kita ambil masa jugalah to diagnose patient with treatment resistant schizophrenia. So there are predictors untuk patient to have treatment resistant schizophrenia lah. Selalunya kita tengok kalau patient tu ada poor premorbid functioning. So sebelum sakit tu dah memang tak function sangat dah pun. Macam tak macam orang yang high function ke apa ke. So dia awal-awal tu dia dah memang tak berapa function juga. Sadly to say, male gender yang ni tak boleh ubah lah. Tak, benda yang tak boleh ubah, unmodifiable. Male gender, those yang onset of schizophrenia tu is at younger age, lagi young, lagi apa ni, lagi higher risk untuk dapat treatment resistant. Those yang ada neurobiological factors, those yang ada lower educational level, single marital status, maksudnya masa dia sakit tu dia single. Bukan bila dia sakit tu dia single, lepas tu pergi orang kamu cakap bagi kahwin baru dia baik. Tak. Bila sakit tu dia single. So it's a predictors for a poor prognosis. Patient yang ada negative symptoms, patient yang ada comorbid dengan substance use, patient yang tak adhere to medication, and then those yang tak respond to initiation of treatment lah, especially kalau 2 weeks tu kita initiate treatment tapi tak ada respon. And then yang saya sebut tadi, duration of untreated psychosis. Lagi lama the psychosis is without any treatment, lagi poorer the prognosis lah. So from Cochrane, treatment for treatment resistant schizophrenia, satu je lah kita mainly clozapine lah. Clozapine is the main antipsychotic used for treatment resistant schizophrenia. So selalunya kita takkan start clozapine in the early phase of the disease. Kita akan reserve clozapine last kalau we found that patient tak responds to other antipsychotics. Sebab you have to sebab clozapine pun is not that kita kata easy, dia tak adalah susah nak start. Cuma you have to take few consideration to start. You have to have monitoring of total Y for at least 18 weeks, benda-benda macam tu lah. So somehow clozapine kita akan reserve untuk dos yang ada treatment resistant. Okay. So sometimes even with clozapine pun patient tak respond well juga. So for those yang ada treatment resistant schizophrenia, sometimes lepas kita start clozapine tu tak ada much respond juga. So with that kita boleh augment dengan benda lain lah. Tapi before augment with other medication, you have to look back at the case. Probably it's a different diagnosis or the or other diagnostic isu, ada benda-benda lain yang kita mungkin terlepas pandang. So you have to review back the diagnosis, and then you kena make sure yang the antipsychotic yang given before this, patient tu sebenarnya adhere ke tak. Probably kita diagnose as treatment resistant schizophrenia, tapi sebenarnya ubat antipsychotic yang kita start sebelum ni dia tak makan sangat pun sebenarnya. So benda tu pun boleh jadi the case lah. Okay, so kena review the engagement with psychosocial intervention as well, and then with other things lah, including substance use disorder. Because this will exacerbate patient who have psychotic, who have schizophrenia. So from Cochrane systematic review, there are few medication can be used. Saya tak letak semua dia, I just put few. You can augment clozapine with aripiprazole or even with haloperidol. Tapi kalau ikut kat sini, there's no significant difference. Cuma dia ada less side effects je. Clozapine, aripiprazole dengan clozapine haloperidol, side effects is less in aripiprazole and clozapine. Understandable lah kan, sebab clozapine haloperidol is the first generation. Clozapine amisulpiride, clozapine quetiapine, noted that better CGI score in clozapine with amisulpiride. Okay, so recommendation of augmentation to clozapine, it varies lah between 8 to 10 weeks. So to do this, you have to weigh lah the risks and benefits lah of augmentation ni, and then you have to monitor side effects because there will be potential drug-drug interaction, and then you kena ada regular review of medication. The primary or district tak akan much encounter about this lah. Selalunya dekat psychiatric service lah. The tertiary team yang akan selalunya try to this. So kalau district or mana KK encounter patient yang ada problem with ubat macam ni, they should be refer it lah. And macam saya cakap tadi, ECT can be combined with antipsychotic untuk patient with treatment-resistant schizophrenia. It may be beneficial. So cuma kita boleh combine tapi bukan semualah. Saya letak sini kat sikit-sikit CBT. Sebab from that CPG tu dia ada mention about CBT, tapi dia tak ada much effect on it, on the symptoms lah. So saya tak elaborate lah. So nak ambil lah ni, sikit lagi. So treatment ni special population, ada few yang kita tengok. Ni actually taklah special sangat pun sebenarnya. Ni kalau patient schizophrenia ada comorbid substance use or tobacco use disorder lah. Sebab we see that patient with schizophrenia memang ada higher rates of substance use disorder lah. In fact, ramai patient kita yang masuk ward pun ada this problem lah. Susah kita nak jumpa patient yang mainly ada schizophrenia without any involvement of substance. So from study memang ada higher prevalence of substance use, including tobacco use lah, nicotine dependence, cannabis, alcohol, stimulants and illicit drug. Okay. Saya rasa sekarang ni kalau di tahun bila 2018, saya rasa kalau currently rasanya stimulants ni pun lagi higher percentage kot. So we know that patient with substance use disorder carries poorer prognosis lah. So the management pun akan jadi lagi complex. So this one kena refer to psychiatrist. Okay. So from evidence of treatment, from that CPG, it is said that ada limited by scarcity of relevant high quality studies lah. So dia tak ada this study yang apa ni betul-betul apa ni significant untuk suggest what are the comprehensive treatment yang boleh bagi untuk patient with comorbid substance. Sebab kalau kita tengok dia punya ni pun tak berapa ni. Dia punya study punya level pun tak berapa ni. So for tobacco use, memang noted patient with schizophrenia ni memang ada higher prevalence of nicotine dependence. Dia boleh increase up to 38%, 38.1%. Ini dekat Malaysia. Higher than overall prevalence of smoking any tobacco product among Malaysian adults. So kalau adults biasa is 21%, kalau patient yang ada schizophrenia, the percentage is higher. So the recommendation is to refer patient schizophrenia with comorbid substance ni to psychiatrist for further management. And then we can actually refer patient schizophrenia with smoking problem in smoking cessation punya program lah. I do refer few dekat Hospital Mak Azam because they have a smoking cessation clinic dekat Mak Azam. So sometimes I do refer my patient yang ada problem with heavy smoking ni to them. To help in reducing the smoking punya pattern. So this is the more special punya population lah, pregnancy and breastfeeding. So berapa minit lagi? 10 minit lagi. Okay, insyaAllah habis. So the principle of treatment for pregnant women with schizophrenia, so kita based on risk benefit analysis lah. To optimize outcome for both mothers and babies. Tapi apa-apa pun kita akan tengok mother dululah. Sebab because we have to have a healthy mother to bring a child kan. So kalau mother tak sihat, there's no way that baby akan boleh sihat. So kita boleh tengok banyak relapse berlaku dalam postpartum. Highest in 0 to 9 days following childbirth. So dalam minggu awal tu is the highest punya duration untuk patient yang ada schizophrenia relapse. Followed by 10 to 90 days after childbirth. Okay, so tengah dalam confinement tu memang sangat vulnerable lah, especially 1 minggu pertama. And then also noted that increased admission during pregnancy, increase juga kalau patient child's father tu ada mental disorder. Kalau mak sakit, ayah pun sakit memang lagi higher risk lah of course. Parents with schizophrenia, so memang anak tu memang higher risk of ada schizophrenia jugalah. Okay, so by ideally women with schizophrenia in reproductive age should receive pre-pregnancy care. Pre-pregnancy care tu actually kena ada pre-pregnancy counselling lah sebenarnya. They should be given counselling prior to conceiving lah, because they are on treatment kan. So ideally they have to have this pre-pregnancy care. Sebab untuk macam mana nak optimize. Sebab kita kena discuss on banyak benda lah. On pregnancy, probably on contraception, dia punya risk and benefits of continue antipsychotic, kalau tak makan ubat. So generally kita akan try to manage patient with schizophrenia ni, woman with schizophrenia, pregnant one, with lowest effective dose using a single antipsychotic lah. So kalau boleh kita turunkan antipsychotic to the lowest effective dose, kita akan buat. Kalau dia higher dose, dia stable, and then kita boleh turunkan to lowest dose yang efektif untuk patient tu, kita akan try to do that. And then kita selalunya, sometimes we do advise patient untuk stop kalau dia pregnant and kalau dia stable. Tapi kalau kita consider the risk of relapse tu very high, memang it is impossible to stop medication, we will try to use the lowest effective dose. So change of treatment is not advisable when pregnant woman is stable on specific antipsychotic because we don't know the effect, and then probably they will likely to experience relapse of schizophrenia lah. Okay. So untuk breastfeeding mother, memang all antipsychotic to date noted that of course they can cross placenta and also present in amniotic fluids and excreted in breast milk. So the possibility of withdrawal symptoms boleh occur lah to the newborn. But then this thing has to be discussed with the mother, whether mother decide untuk breastfeeding or not. So kalau mother decide not to do breastfeed, so kita boleh suruh bagi formula milk lah. Kalau patient decide to continue breastfeeding, then mungkin boleh buat some arrangement. This kena discuss. It's not a black and white punya decision. Okay. So the case is suicide. Overall, higher prevalence of suicide in patient with schizophrenia. Kalau tengoknya the completed punya ni is higher lah in patient with schizophrenia. Completed suicide is higher compared to those yang suicide without any mental illness. So suicide in schizophrenia is higher. Higher in young adults, and then selalunya coming from urban poor neighborhood. Suicide will be discussed more tomorrow, so I think benda ni akan ada juga, akan didiscusskan lah. So you can see that recommendation, clozapine also can be considered as treatment for patient with schizophrenia yang ada persistent suicidal risk. Bukan untuk treatment resistant saja. Okay. So social issues. This one is definitely an issue for patient with schizophrenia. Sebab selalunya because of stigma, because of poor education status, because of the poor functioning as well. We see that most patients with schizophrenia ada masalah in interpersonal relationship status, employment status, effect of stigma, and also neurocognitive skill and functioning lah, and effectiveness of intervention. So we can see that banyak patient with schizophrenia, especially yang tak treated well, yang ada poor control of symptoms, akan ada a drift of the social status tu, from very functioning one tu mungkin tak functioning langsung, or even to jadi homeless and vagabond. So sebolehnya we want to avoid this lah. So that's why the early intervention is needed with patient who present with psychotic symptoms. Okay, that's all from me. Kalau ada any question, feel free to ask lah, or I can answer later kot. Time dah habis tak? Ada.
Terima kasih kepada Dr. Azhar di atas ceramah yang telah disampaikan. Harapkan ilmu yang telah disampaikan oleh Dr. Azhar dapat memberi manfaat kepada kita semua lah. Kita menerima soalan dalam program ini. Kita jawab lah. If a breastfeeding mother decides to continue breastfeeding while on antiseptic, should we refer the child of the mother to PICS, and how will we educate mother to recognize withdrawal symptoms of the child?
Soalan daripada
Nodiana.
Okey. Selalunya kalau patient yang after delivery, kita akan discuss on the treatment lah. Treatment whether they want to continue or not. Tapi kalau patient, depending on the mother juga. Kalau mother tak stable, definitely kita akan advise untuk continue lah ubat. Kalau patient stable, then you see, kalau memang dia tak boleh, sebab dia ada kriteria whether patient boleh stop ubat ke tak kan. So kalau patient perlu makan ubat walaupun dia stable and they want to breastfeed, selalunya saya akan suruh dia dia punya ubat tu, taking of medication tu, timing dia tu, probably kena arrange on that. I selalu advise kalau they want to be on treatment tapi takut ada side effects to the baby, saya akan suruh sama ada dia pump dulu the breast milk, simpan or sebelum makan ubat, or they can makan ubat dulu tapi dia kena jarakkan the breastfeeding time lah. And then selalunya kita tak refer patient baby or the patient to PICS lah, unless you nampak obvious patient baby tu sedated, tak bangun, tak respond, then you should be alert lah. Tapi selalunya saya tak pernah pula dapat such kind of concern daripada mothers lah. Tapi yang selalunya I will advise to adjust the timing of the medication taken tu. Sama ada breastfeed dulu baru makan ubat, or makan ubat and then you have to wait for a certain hours before you boleh breastfeed balik. Menjawab soalan ke? Ibu nak tahu.
Sudah disconnect. Sudah disconnect. Tak ada. Ada.
Assalamualaikum. Dengar tak? Assalamualaikum. Okay, good. So tadi sebenarnya saya explain ada sedikit tambahan information in regards to usage of antipsychotic in pregnancy as well as breastfeeding mother. So in general, all antipsychotics it can be excreted into kita punya breast milk. However, there are certain numbers or indexes of the concentration of antipsychotic yang boleh excreted tu adalah sebenarnya sangat rendah. So at any point of the time, kalau patient on breastfeed, dia okay je. Maksudnya patient breastfeeding tapi at the same time using antipsychotic, antipsychotic ke antidepressant ke semuanya basically around the same. Jadi dia adalah safe untuk breastfeeding mother. Dia tak perlu any dose adjustment and it doesn't need for any time punya adjustment. Itu adalah guideline terbaru lah untuk breastfeeding mother. However, there are medication in psychiatry which is kita sebut contraindicated for breastfeeding such as lithium. So lithium, kalau patient tu on lithium, lithium used as mood stabilizer for bipolar mood disorder punya management. So kalau patient on lithium, kita tak nasihatkan dia untuk breastfeed lah. Because lithium ini dia boleh di-excretekan di dalam breast milk and it has a very narrow therapeutic punya range in which dia ada risiko untuk buat baby tu dapat side effect as well as toxicity. Untuk antipsychotic for now yang kita tahu basically dia excreted tapi dalam concentration yang sangat rendah. Perlu atau tak refer kepada PIDS, our usual practice kita tak refer lah, unless memang kita nampak ada side effect yang sangat ketara. Contohnya baby jadi tak minum ke, baby jadi sedated ke, ataupun baby jadi jarang lah, kita tak pernah jumpa lah sebenarnya. So basically kita tak pernah refer lah baby of a mother on antipsychotic to PIDS. Gitu ya. Thank you.
Terima kasih kepada Dr. Nur Azida dan Dr. Umi di atas jawapan yang yang telah dihuraikanlah untuk menjawab soalan daripada peserta kita sebentar tadi. Sebagai tanda penghargaan kepada penceramah kita, saya menjemput Dr. Hajah Umi Kalsum binti Muhammad Idris untuk menyampaikan cenderamata kepada Dr. Nur Azida sebagai tanda penghargaan lah. Dengan segala hormatnya dipersilakan. Alright, terima kasih kepada Dr. Umi kerana menyampaikan cenderamata kepada Dr. Azida. Seterusnya kita tiba masa untuk kita berehat sebentar selama 15 minit untuk memberi laluan kepada minum pagi dan pengurusan dirilah kepada para peserta khusus. Khusus akan bersambung semula pada 11 pagi untuk slot seterusnya. Okay, Assalamualaikum dan selamat pagi. Kita bertemu kembali. Diharapkan para peserta dah minum dan dah buat pengurusan diri masing-masing lah. Sebab kita akan mulakan slot ceramah seterusnya. Sebelum tu saya akan ada housekeeping announcement juga yang akan dilakukan. Para peserta diminta untuk mengisilah kehadiran khusus pada hari ini dengan mengimbas QR code yang telah disertakan dalam ruangan chat. Ada 2 QR code di situ, satu untuk MyCPD dan satu untuk MMA registration lah untuk doctors, dan juga untuk Google Form untuk kehadiran khusus pada hari pertama ini lah. Sekali lagi, sekiranya para peserta mempunyai sebarang soalan semasa sesi ceramah, boleh terus ajukan dalam ruangan chat kepada host atau co-host. Dengar ke? Tak dengar. Okay. Alright, so kita akan teruskan tentatif khusus pada hari ini dengan ceramah seterusnya yang bertajuk Refresher CPG Management of Bipolar Disorder in Adult, yang akan disampaikan oleh Dr. T. Chun Kiat, Pakar Psikiatri Hospital Tengku Ampan Azan Kuantan. Sebelum tu saya bacakan sedikitlah background ringkas Dr. T. Dr. T. Chun Kiat, beliau telah graduate medical officer pada tahun 2013, dan beliau telah graduate program master under Universiti Kebangsaan Malaysia pada 2018 dan terus berkhidmat di Hospital Tengku Ampan Auzan sejak tahun 2019. So tanpa melengahkan masa, saya menjemput Dr. T. Chun Kiat untuk menyampaikan ceramah beliau. Dipersilakan.
Hello. Selamat pagi semua. Boleh dengar tak? Boleh dengar. Halo, halo. Boleh dengar ke? sound test. Okay, good morning everyone. Hope everybody dah dapat refreshment tadi. So now back to the refresher yang seterusnya ialah refresher for CPG management of bipolar disorders in adults. So basically my presentation mainly will be based on the CPG that was produced in 2014. Um, it is the first sort of the first edition, and the review of this CPG is actually due. So the outline of my presentations, initially I'll be talking about introduction first, followed by epidemiology and risk factors, and how we are going to make a diagnosis of a bipolar disorder. What are the differential diagnoses, the comorbidities which are commonly associated with those suffering from bipolar disorder, and also how to suspect a sort of bipolarity in patients who first presentations are in the depressive episode. Subsequently, I will talk a bit about what are the general principles of treatment as well as plan of management, treatment of pharmacological treatment as well as non-pharmacological treatment. What are the strategies for us to improve the compliance of the patient? Also, I'll talk a bit about suicidality with regards to bipolarity, comorbid substance misuse, as well as special populations, mainly on the pregnant ladies as well as the elderly population. So a bit about the introduction of bipolar disorder. So the management, as we know, of bipolar disorder is actually very challenging, partly also because the understanding of this illness is ever evolving. A lot of times, patients who suffer from bipolar disorder, they might present it very differently, right? They might present in a depressive episode, which is exactly like a major depressive symptoms which fulfill the criteria of MDD, or they might present with in either a manic state, a hypomanic state, or a mixed state. And sometimes they do suffer from a lot of other psychiatric comorbidities as well. So these are actually the challenges that a clinician will face when dealing with somebody who's suffering from a bipolar disorder, right? And what we know is that bipolar disorder is actually it's a major mental illness with a chronic cause of illness, and thus it actually has a big burden on the utilization of the mental health services. Sometimes when patients they seek treatment, usually there's a delay, maybe because throughout their lifetime they had never had a major manic or depressive episode. Maybe previously they only presented with a hypomanic episode, which does not really cause so much deterioration in functioning, right? So in view of this complex illness manifestation, and during that time, prior to the production of this CPG, patients who have bipolar disorders, they are actually managed in different ways. And thus, there's they created this CPG so that we sort of able to apply latest evidence-based medicine in managing patients suffering from bipolar disorder. Okay, the epidemiology and risk factors. So the lifetime, understand that bipolar, generally we have two types of bipolar. One is the bipolar 1 disorder, the other one is the bipolar 2 disorder. So the lifetime prevalence for bipolar 1 is about 0.6%, whereas it's about 0.4% for those suffering from bipolar 2. And the mean age of onset of illness is usually in around 18 to 20 years old. And actually, this illness affects women slightly more as compared to men. In terms of the risk of bipolar disorder, it is actually inversely related to age, educational level, and employment. It means that if you have a higher educational level or you have an employment status, it sort of reduces the risk of somebody getting a bipolar disorder. Similar to most of the mental illnesses, there is a very strong genetic predisposition or heritability that is demonstrated in those suffering from bipolar disorder as well. So, twin studies showed that the concordance rate for bipolar 1 disorder was significantly higher in identical twins as compared to non-identical twins. So coming to the diagnosis of bipolar, so as with all psychiatric illnesses, generally diagnosis of a mental illness is a clinical diagnosis, meaning that we can diagnose based on symptoms and signs that we elicited, and also at the same time maybe doing some investigations to rule out organicity. Then generally we can actually diagnose a mental illness. So same for bipolar disorder, usually what we usually use in Malaysia would be a DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, whereby there are certain criteria. If a person fulfills them, then we can say that they are suffering from bipolar. So this basically is sort of a graph depicting a mood, right? So basically, normal people do feel sad and happy at times, right? Our mood is never, in humans, our mood is never a flat line. Things that make us happy, we feel a bit better. When we're sad, certain things happen, we will be sad, right? For a person to be diagnosed as bipolar 1 disorder, basically they need to have at least a 1 minute episode, which later on I will go through all the symptoms. Right, and for a patient who is diagnosed to have a bipolar 2 disorder, they need at least a 1 hypomanic episode as well as 1 depressive episode, either currently or in the past. So this is what I've mentioned earlier. So to diagnose bipolar 1, we need at least 1 manic episode. To diagnose bipolar 2, we need at least 1 hypomanic episode plus 1 depressive episode. Right. So how do we define a person is having a manic episode? So based on this DSM-5 criteria, where a person sort of have a distinct period whereby he has persistently elevated mood or irritable mood. Elevated means the person will tell you that, oh, I'm feeling so good, doctor. I've never felt so great in my life, or I feel on top of the world. I'm so elated, euphoric. Or sometimes patients with bipolar, they might have irritable mood. And this usually is associated with increase in goal-directed activities or energy lasting for at least 1 week. So these symptoms usually present most of the day and nearly every day, right? If the person must fulfill these core criteria first before we go down to check whether or not there are other associated symptoms as well. Okay, so during this period of mood disturbance and increased energy or activity, whereby if patients have 3 or more of the symptoms below, 4, if the patient has irritable mood, then we sort of can say the patient um, have a manic episode, provided they also fulfill other criteria. So a person who's manic will feel that they have inflated self-esteem. So they might feel that, oh, they are smarter than others, they are maybe more good looking than others, they are richer than others. They have this, uh, increase in self confidence. Okay. Uh, Subsequently, the next symptom would be they would have reduced need for sleep, meaning that they might sleep for only a few hours, 2 to 3 hours, which is different from their usual sleeping patterns. But after waking up after 3, 4 hours, they actually still feel energetic and feel rested, right? It's a bit different from insomnia, whereby a person wants to sleep, feel tired if they don't sleep, but not getting that sleep, right? So we need to be clear in patients who are anemic, they will have reduced need for sleep, right, and not insomnia. So they may be more talkative than usual, or they have this pressure to keep talking. There will be flight of ideas, whereby sometimes when we talk to the patient, we can see that when they speak, the content will be sort of like flight, jumping from topic to topic, but there is actually a small connection between the ideas. It's a bit different from whereby in patients suffering from schizophrenia, there is total disconnection in between thoughts, which is what we call as the looseness of association. So patients suffering from bipolarity, there is some connection between ideas. Or subjectively, when they tell you, doctor, there's so many thoughts running through my mind. Like, there's also just too many, and I can't control them. So they might sometimes might tell you this as a symptom. Sometimes during interview, you might see that patients are more distractible than usual. They sort of can't focus on conversations, and sometimes they do self-report as well. Other than that, there might be increase in goal-directed activities, whereby they might have a lot of plans to, do things, planning to maybe further their studies, planning to do business, so many thoughts running at the same time. And sometimes there is also associated with psychomotor agitation, whereby they might be very restless, pacing around, walking about with actually no, their activities are basically purposeless and not goal directed, right? And during this time, when a person is learning, they might also involve in activities that are risky, or such as they have buying sprees, they make foolish business investment, or they have sexual indiscretions as well. Okay. Okay. So the mood disturbance usually, this is how we differentiate between a manic episode and a hypomanic episode, whereby all these symptoms cause marked impairment in a person's functioning, whereby they sort of, they cannot work, it causes them problems in terms of like social relationship, and it might be severe enough to necessitate hospitalization, or if they are psychotic features. So these are the three things that can help us to differentiate between a manic from a hypomanic episode, and also of course the duration of the symptoms. Hypomanic symptoms, you need at least 4 days, but for manic symptoms you need at least 1 week, right? And also we need to sort of rule out that the condition that or the symptoms that patient is suffering from is not because of a substance or because of another medical condition. So, coming to hypomanic episode, basically it's the same criteria. It's just that the duration of the symptoms, you need at least 4 days as compared to manic episode, which you need 7 days, right? And what is important here is that we need to know that during this hypomanic episode, if you look at criterion C, it mentions that there is bukan masa. Tak dengar. Hello? Okay. So, if you look at criterion C, the episode is actually associated with unequivocal change, meaning that there is actually a definite change in functioning, but not necessarily deterioration in functioning, because sometimes when patients are in a hypomanic state, they might actually be more functional, or they have more ideas, and there are a lot of things that they actually are able to sort of accomplish, right? But this change in behavior, it's unusual or uncharacteristic of the individual when the patient is not symptomatic, right? And usually the episode of hypomania is not too bad to cause impairment in their functioning. Does not necessitate hospitalization as well, and usually they do not have any psychotic symptoms. If they do have psychotic symptoms, then by definition, the person is actually in a manic episode rather than a hypomanic episode. Okay, so as we know, bipolar, we have two poles. One is the manic pole, which is whereby the mood is high. They also have episodes where they are depressed. So the criteria to diagnose the major depressive episode is actually the same criteria used to diagnose MDD. So what we require is basically 5 symptoms, which lasts for minimum of 2 weeks, whereby one of the symptoms has to be either a depressed mood or loss of interest or pleasure. So the low mood or the depressed mood that somebody is suffering from. Hello? Hold on. Naikkan. Kalau tak letak. Try.
Sorry, can you all hear me better now without the headphone? Okay. I'll try to go on. If you guys cannot really hear, I'll try to again increase my voice. Okay, so the depressed mood that a person who's suffering from MDE, quality of the low mood actually, it's sadness actually is experienced throughout the day, meaning that most of the time in the day, the person will feel sad. This usually will be present nearly every day, right? And for a minimum of 2 weeks. And during the same time, a depressed person might also have reduced interest or pleasure in all or almost all activities. Means that he doesn't have one motivation to do things that he liked before, or even he does it, he doesn't feel the pleasure, right? And also they might have changes in their appetite and weight as well. So sometimes we only think that a person who's depressed, they might have sometimes they do have an increase and they might also with gain, right? In terms of it, a depressed person might have insomnia or also hypersomnia, means that they sleep, that they cannot sleep, or they sleep more than, right? Sometimes also they might end with agitation, means being very restless, on the edge, unable to sort of be calm, right? Or psychomotor retardation, whereby they are sort of, slow in terms of like their activities. Maybe they talk less, they move slowly, they don't have any motivation to do anything. So as observed by people, use that the person it's not really doing the usual, right? And also a person who is depressed, they might feel fatigue, means feeling very tired, lost of energy, and they might feel worthless or have excessive or inappropriate. Also, they have poor concentration, and also they cannot make. And if those who have thoughts about suicidal thoughts, or they have specific plan or have suicidal attempts before, actually those indicate that their depression is probably more serious or more severe in that sense, right? Again, these symptoms usually will cause impairment in functioning, and we need to rule out the causes such as effects of substances, or also due to another medical condition. Okay, so I've covered all the three mood episodes. So an episode is defined as a distinct period of services fulfilling the above criteria. So if you want to say that this person has a new episode, basically has to be in remission or symptom-free for at least 2 months. So meaning that if a person who is depressed, he remission in 1 month, subsequently on the second month, right? Indeed, basically well for 1 month. Second month, he starts again to have symptoms. So that technically is still considered as one episode, right? But if let's say a person who is depressed was well for 1 month, and during the start of the second month develop a manic episode. That's opposite. That is what we call as a mood switch to the pole. So that can be considered as having a two different episode, right? So I've already mentioned before how to differentiate between mania from hypomania. Yeah, if there's deterioration in functioning, if the severity requires hospitalization, or if experiencing psychotic features during the technically considered manic episode. There is one particular specifier known as the rapid cycling. It is whereby there are presence of at least 4 mood episodes in the last 12 months, either in the manic, hypomanic, or major depressive. So what happens is that those suffering from the rapid cycling, it is a more difficult, and in terms of management, it might be challenging. Okay. So coming to screening tools, as I've mentioned, sometimes the diagnosis of bipolar disorders again might be difficult, or it many years because of presentation. A lot of times, because the presentation of the person, they present first with depression. So most often than not, we would diagnose a person with a unipolar depression, right? And sometimes always a good practice whenever we diagnose somebody to have depression, we always screen for a manic symptom as well, right? In terms of screening tools that we use, one of them which is included in the CPG is the mood disorder questionnaire, BQ. Basically, this is a self-report instrument whereby you give it to the person, to the patient, and they will sort of report it themselves. In 5 minutes to complete. Remember that this is screening tool and a diagnostic tool. So generally, all the symptoms that are present in this form, this questionnaire basically is more or less similar with the symptoms that we have covered earlier, the DSM criteria for, right? Okay, the person that you screen positive, then you should proceed with coming to a clinical diagnosis, right? So the CPG says that there is an inadequate evidence to recommend the usage of specific screening tools at primary care, but they said that a simple self-administered tool such as MDQ can actually be used to help primary care doctors in the event they suspect that there is bipolarity in persons who are diagnosed with depression. So those with positive screen, they say should be referred to for the evaluation. So coming along to differential diagnosis, when we sort of diagnose somebody before we diagnose somebody as having bipolar disorder, we should have a few differential diagnosis that we should consider, right? If a person comes during a depressive episode, what we should sort of rule out would be whether or not this depressive disorder is due to another medical condition, whether it's caused by a substance, whether this is just a major depressive disorder, whether or not it's adjustment disorder with depressed mode, or is it anxiety disorder, or is it schizophrenia or schizoaffective disorder, where somebody presents in a manic or manic phase, should sort of consider whether this is caused by substance, certain substances such as stimulants might cause patients to have similar symptoms. And also whether or not we need to rule out that bipolar or the symptoms that the person is having is related or due to another medical condition, for example, a brain injury, right? Need to rule out whether or not it's schizophrenia, schizoaffective disorder, or the person is suffering from a personality disorder, borderline personality disorder. In terms of comorbidity, we know is that bipolar disorder often occurs with psychiatric illnesses. One of the commonest comorbidities person bipolar can have is anxiety disorder. The prevalence of comorbid anxiety disorder is as high as 51.2%, very, very high. Certain studies also found that comorbid PTSD is also higher in those with bipolar 1 than those with bipolar 2. So in a study among postpartum women, they found that a significant portion of them had comorbid OCD. In terms of bipolarity in depressive illness, it means that person comes to you in a depressive case, certain things that which suggest or that this person might have a bipolar would be if the person have at least 2 mood episodes in the past, if a person have a family history of mania, if the occurrence of psychiatric symptoms was before the age of 30 years old. Currently, the person is depressed, but this episode lasts less than 1 month, or if when we prescribe antidepressants, stability, okay, or currently the patient in mixed state whereby he has both depressive as well as manic symptoms. All these factors are the risk factors, and we should consider a diagnosis possibility of bipolar disorder when coming across depressed people with the following risk factors that I've mentioned above. Okay, so the general principles and management. So basically, what is important is that we should have a collaboration between patients, family members, as well as the healthcare professionals. The aim is not just to boost remission, but also actually towards recovery, whereby the person is able to go back to full health, live meaningful and also satisfactory factory life, right? So it is important also during the course of management of a patient, confidentiality is maintained as well. So what we know is that those suffering from bipolar disorder, it's really a chronic lifelong illness, and medication is one of the mainstays of treatment. So type of treatment will vary during different phases of the illness. During the acute phase, whether it's in the acute phase, whether or when the person is in the maintenance phase. So generally in Malaysia, at the primary care level, the focus is for screening. So once we screen and we suspect somebody is suffering from bipolar, we refer appropriately. Then in terms of the secondary level, the psychiatrist and psychiatric team will confirm the diagnosis and will initiate appropriate medication, pharmacological, and also non-pharmacological treatment. Actually, once the patient is on the maintenance phase, then we actually can sort of like have a step down and back to the primary care team. So next would be this is the algorithm for when we are managing person with bipolar. First, we have to come to the correct diagnosis first. Subsequently, we need to assess how severe, and then we need to decide whether or not we need to admit in the ward, or this patient can be seen at our psychiatric clinic or outpatient, or if we have a strong community psychiatric team, we can actually refer patients to be managed under either acute home care or assertive home care as well. Okay, so the principles of management in bipolar disorder should incorporate the following. We should assess the severity and initiate early treatment. We should not just focus on pharmacological interventions, but also non-pharmacological, such as psychosocial interventions. We should also bear in mind that patients might have problems with compliance, and also addressing whether or not there is any potential risk the patient to himself or to other people's, and monitoring the parameters, certain parameters, not just the investigations as well for patients on medication, and also managing special populations. Right. So the care of patients suffering from bipolar disorder should be integrated and collaborated between different levels of service providers, as well as also the patient and the caregiver, right? In terms of admission criteria, the criteria for admission of people suffering from bipolar is based on the Malaysian Mental Health 2001, as well as the mental health regulation, whereby if we feel that there is a risk of patient harming himself with it, or others, or whereby if we feel based on our clinical judgment that this patient is not suitable to be treated at home, we will admit him or her to the psychiatrist. Well, referral criteria, yes, if, for example, you have difficulties in the sort of whether it's diagnosing or managing person suffering from bipolar disorder, you can refer to the psychiatrist team, or you can discuss with or consult with the psychiatrist at the nearest hospital, right? So for a newly diagnosed or undiagnosed individuals with bipolar disorder, if you feel that you are not very sure in your assessment of the risk of the patient, you can refer to us. Or if you're not very sure about, the diagnosis and also how to manage initially, so refer to us, right? Also, people with confirmed diagnosis of bipolar if, let's say, there's sudden deterioration or in their functioning or sudden worsening of their symptom, whereby there's an increased risk of harm, whereby the person is not compliant to treatment, or if their response is inadequate to the medication that's prescribed, and or if they are ambivalent, or they're thinking about wanting to stop medication, or when there is concomitant substance use, or when the presentation of this mood episodes is very, very complex, or if you feel that patient will benefit from psychoeducation or other psychosocial interventions. So because of these criteria, you can actually also or discuss with them. In pharmacological treatment, it is divided to the acute phase as well as the maintenance phase. So the selection of medications are based on a few factors. First of it, we want to see whether patients are taking other medications for other conditions. You need to know whether there's any drug-drug interactions. We want to also review back patients' past medication history and also past medication response as well, so that will guide us to sort of know what is the best choice of medication for the patient. And also it will take into account whether or not certain side effects that are considered as not tolerable to the patients, and also patient's preference. We also want to know whether or not they have other psychiatric comorbidities as well as medical conditions. So treatment of the acute phase in terms of pharmacologically, basically it's what we usually use are the mood stabilizers as well as the antipsychotics. So lithium is actually considered as the gold standard, but recent data based on CPG shows that actually psychotics are also very, very effective. In fact, sometimes more superior to mood stabilizers during the acute phase. I think partly is also because when patients is in a manic episode, especially the acute phase, we want medications which are sort of good, which have sedative effect, and also medications which can control or reduce agitation. So antipsychotic generally would be a good choice for acute agitation as well, right? But in terms of whether or not there's superiority of different types of antipsychotics against each other, generally more or less they are equally efficacious, right? So the choice of drugs when we use is actually based on the decision between benefit, risk versus benefit, right? Some of the medications that are shown not to be effective in acute mania is your lamotrigine, topiramate, as well as your gabapentin. Other than that, lithium, valproate, and carbamazepine are actually equally efficacious in acute mania, right? So generally, this like I mentioned earlier, for acute mania, we can use mood stabilizers as well as your antipsychotics. So generally, we use atypical antipsychotics such as risperidone, olanzapine, asenapine, iperidone, aripiprazole. For the typical antipsychotic, haloperidol are shown to be effective. So this can be used during acute mania, right? Additionally, patients who are in the acute manic phase might be very agitated, like mentioned above previously. So benzodiazepines actually be used during this stage. Algorithm for the treatment algorithm for those who have acute mania. So you can see that in step 1, monotherapy or immunotherapy, depending on the clinical condition of the person. right? So you can actually start monotherapy with stabilizers, or you can start monotherapy with we can combine, right? Subsequently, if there's no response, you give 2 weeks, there's no response, or patients cannot tolerate the side effect, then you would want to, whereby if initially during step 1, you start off the patient monotherapy with a mood stabilizer, say for example, Epilim, then subsequently in step 2, you decide to add an antipsychotic, maybe okay, you think okay, let's add risperidone, or you want to off your Epilim and switch to risperidone. Again, you can add. So subsequently, if let's say in your step 1, you started off with your antipsychotic. So again, you can either add on a mood stabilizer, or you switch to a mood stabilizer as well, right? If you started off with combination therapy, the person again is not responding or cannot tolerate side effects, you can either replace one or both of the agents, right? Similarly, if let's say no response, you can proceed with step 3. Step 3 basically is going back to step 1, but trying other types of medication that you have not tried in step 1 and step 2. Okay, so if you can look at the sides of the this algorithm, whereby psychosocial intervention, later on I will briefly about, you can actually incorporate it into part of the treatment of patients suffering from in the academic state. Because sometimes we want the patient to sort of a bit settled down first before we can initiate any form of psychotherapy, right? If you look on the left-hand side of the algorithm, there is what is written as plus minus ECT, meaning ECT can be considered at any point of time when a person is manic, if the manic symptoms are very, very severe, if the patient has very high suicidal risk, if the patient presents with catatonia, or he or she responds to medication or are intolerant, cannot able to tolerate the side effects. Okay. Okay. So coming on to the acute stage of depression. So according to CanMed, among the mood stabilizers, it is found that lithium and lamotrigine is actually effective in the treatment of bipolar depression, and also several antipsychotics also very efficacious in the treatment of this condition, as quetiapine monotherapy or quetiapine combination of quetiapine with other mood stabilizers, and also the olanzapine fluoxetine combination as well. So what we need to understand is antidepressants, when you give suffering from a bipolar mood disorder, there's a possibility of what we call as a manic switch, right? So antidepressants shouldn't be given on its own, but usually given adjunctively with other treatment. So if you want, the patient is depressed, you want to give an SSRI or antidepressants, combine it with either a mood stabilizer or an antipsychotic. That would be, so doing so not significantly increase or decrease the risk of affective switch. Certain antidepressants such as TCA causes more mood switching as compared to some other antidepressants, whereas bupropion is associated with reduced risk compared to the others. Okay, those who have a history of rapid cycling, venlafaxine, prescribing venlafaxine is associated with mood switches as well. The algorithm for treatment in acute depression. So don't worry if you cannot remember. The reason of, this is the reason of the CPG is to be able to always refer back if you are in doubt, right? So no need to memorize, always refer back to this algorithm. When in terms of treatment of acute depression, again, we can have treat patients with either monotherapy or also combination therapy. So monotherapy, which is lithium and cocaine, or if the person we feel that he requires a combination therapy, we can give patient operate lithium or valproate with SSRI, combining olanzapine with SSRI, giving olanzapine fluoxetine combination. Again, if let's say the patient does not respond within 2 weeks, after 2 weeks, or there are intolerable side effects, then subsequently we go to step 2. Again, you can try monotherapy with epilim, or you can combine SSRI, or lithium or valproate with SSRI, or lamotrigine plus lithium or valproate. Again, let's say no response, then you go subsequently for the third line treatment. Again, when the psychosocial interventions should then be introduced to patient once they are a bit better, and also ACT can or should be considered if again the symptoms of depression is very severe. It's not eating, not drinking, if the patient is catatonic, if the patient is highly suicidal, or that there is poor response, or when they cannot tolerate them. Okay, so the SSRI, if you want to sort of give the patients, you can give the usual SSRIs, but except paroxetine. Okay. So this is the table. You all can refer later on. It's in the CPG, so I'm not going through again. So the recommendation of the CPG is that the following medications, which is lithium, certain antipsychotics such as quetiapine, or what we call as the OFC, olanzapine fluoxetine combination, can be used as monotherapy in acute bipolar depressions, right? And antidepressants, you can use it for short term and also treatment, not alone in acute bipolar depression. And they also mentioned, antidepressants should not be used as monotherapy in acute bipolar. So rapid cycling is actually a specifier in those suffering from bipolar disorder. It's defined by presence of 4 mood episodes in the last 12 months. Be either a manic episode, a hypomanic episode, or a major depressive. So studies have shown that those with rapid cycling, they have lower rates of symptomatic remission. They have more recurrence, especially depression. They require more hospitalization, and also they have higher rates of attempted suicide as well. So lithium and anticonvulsants found to have comparable efficacy. Aripiprazole, olanzapine, and quetiapine, they are efficacious against placebo, whereas olanzapine and quetiapine, they have similar efficacy compared to anticonvulsants during an acute episode. So, one of the study is STEP BD, which is the Systematic Treatment Enhancement Program for Bipolar Disorder, found that those who has rapid cycling, where antidepressants will continue, they had actually 3 times more depressive episode than those without. So, the recommendation of the CPG is that antidepressants should be avoided in those suffering from rapid cycling bipolar disorder. So in terms of mixed episode, so basically mixed episode, it's whereby a person has both manic as well as depressive symptoms simultaneously or at the same time. So again, mixed states is one of one of the challenging type of bipolar. What we know is that the management basically it's the same, which is using your antipsychotics, mainly your antipsychotics, as well as your mood stabilizers. Okay, coming on to the maintenance phase. So maintenance phase, it's whereby the patient is sort of free from symptoms, and this is the time whereby they need to continue to medications as well as psychosocial intervention to maintain them in this state, in periods of wellness, right? Again, there's no consensus on the duration, but prophylaxis in terms of medication is actually warranted because we know that bipolar disorder is a recurrent and lifelong illness. Actually, not from the CPG per se, but it a good table. It sort of give us a summary of the common medications used during the maintenance phase in bipolar. So whenever we decide to give or to prescribe medications to somebody, to a patient, we need to always think of whether this medication is effective or not, and whether or not it's whether or not patients can tolerate this medication or not. So generally, if we look in terms of efficacy, most of the medications here listed more or less have similar efficacy. However, if you look at one which is actually longer than the rest, is actually lithium. That's why it's considered as sort of the gold standard for patients suffering from bipolar disorder, right? And so basically, how to look at this is you want medications which is very, very tolerable and very efficacious as well. So coming on to the recommendations of medications used in treatment of the maintenance phase, you can go with hormonotherapies, mood stabilizers such as your lithium, your epilim, lamotrigine. They are all a good first-line medication for maintenance phase. But in terms of your antipsychotics such as your olanzapine, quetiapine, risperidone, long-acting injectables, and aripiprazole are also very, very effective in terms of maintaining and maintaining patients well, right? If your first line doesn't work, then you might consider having second line and third line medication. Okay, coming on to a bit about the different types of common medication that we prescribe. So we sort of need to know what are the usual doses and also what are the common side effects so that we can anticipate one, and also when we do a schedule with the patient understands what are the side effects, and they can make an informed decision of whether or not what type of medications that lithium, as I mentioned earlier, remains one of the gold standard. However, because of the narrow therapeutic, meaning that if beyond certain levels, it can cause toxicity in a person. Thus, we should be able to, number one, identify what are the things and symptoms of right? And also, we should be able to regularly monitor the TTM level of patients in lithium. Acute mania dosage ranges from 600 up to a maximum of 1,800 milligrams per day in two divided doses. And in maintenance dose, they will require less. Okay, so what we aim to achieve for those patients would be a M level of 0.6 to 1.2 milliequivalents per liter, right? Of course, if a person who is acutely well in the manic state, they might need higher, maybe 0.8 to up to about 1.2 milliequivalents of a liter of lithium in the stable phase. That range is on the lower end, probably somewhere between 0.6 to 0.8. So common side effects of lithium would be they will have polyuria, polydipsia. They might complain of having metallic taste in the mouth. It's associated with weight gain. Also associated with hypothyroidism, hyperparathyroidism, MS, diabetes insipidus. Okay, so a few signs and symptoms that you might need to consider in patients where you suspect lithium toxicity would be if the patients present with nausea, vomiting, they might start feel confused, maybe in terms of their gait as ataxia gait, hyperreflexia, and so on and so forth. So there are certain things that we need to, and one more is that their tremors might be called tremors. Okay, so the next medication that commonly used we use is the epinephrine, whereby the common side effects would be GI upset, sedation, weight gain, tremor, thrombocytopenia, as well as raised liver enzymes. So in terms of acute mania, the dose can be anywhere from 600 up to maximum of 2,500 milligrams per day. And patients on epinephrine also we should regularly do a TPM. Okay. Carbamazepine and lamotrigine are the two other mood stabilizers that we use commonly. However, what we really need to watch out for is the potential of it to cause Stevens-Johnson syndrome, which is a rare but a severe form of cutaneous hypersensitivity. So this is something that we really need to watch out for, right? And if you want to start, there is usually we need to titrate it slowly. Okay. In terms of antipsychotics, quetiapine, very effective medication for acute depression, mania, and also during the maintenance phase, right? Common side effects of a lot of these antipsychotics, atypical especially, are sedation, weight gain, metabolic side effects such as hyperglycemia, dyslipidemia, and also extrapyramidal symptoms, right? So we need to be able to know and also counsel the patient on this medication. Okay. So in terms of SSRIs, if you want to give as an adjunct during the acute depressive phase, generally SSRI common effects would be GI upset, nausea, vomiting, dyspepsia. They might have complained about some sexual dysfunction as well, right? And some of the SSRIs might cause somnolence. However, in certain people might also actually cause it. So again, it differs from patient to patient. So what are the parameters that we need to monitor regularly? So based on the CPG, as we know, there's just now I've mentioned about the different side effects of the medications that we commonly use. So we also need to ensure frequent monitoring, such as patients' weight circumference, their weight. You should regularly check for their fasting blood sugar level, their lipid levels in the blood, their blood pressure, and also we need to do ECG during first time, and if let's say at initiation, as well as during the if indicated, right? Some other blood investigation that we should monitor would be like we see certain medications like epilin and carbamazepine can cause thrombocytopenia. We also should regularly monitor thyroid function as medications such as lithium and cause hypothyroid in certain cases as well. Renal function should be monitored also in those cases on lithium. Okay. Serum calcium levels also should be monitored as well for patients on lithium because there's potential of lithium to cause hypocalcemia. So the recommendations by the CPG is that lithium monotherapy should be used as a first-line treatment in bipolar disorder. Lithium monitoring should be carried out at least every 6 months. So we should get TDM for lithium every 6 months, or actually whenever you change the dose of the lithium, whenever you increase the dose. So if you want to discontinue, it is advised to gradually taper off rather than abruptly stop, so as to minimize the risk of relapse. And in terms of both mood stabilizers and also antipsychotic, we can be used either as a monotherapy or combination therapy during the maintenance phase of bipolar disorder. So what is important is that we discuss with the patient regarding the risk and activity, and also so that the patient make an informed. So half of my presentation, maybe we take a 2-minute break first, and then we will continue after this short break. Okay, everybody dah ambil a break. Okay, minta maaf kita tak sediakan tiket. So, okay, we will proceed with our second half of my presentation. Okay, so just now I've covered pharmacological treatment non-pharmacological treatment is also actually very, very important. First off is our ECT. If you remember the algorithm just now, basically whether it's acute depression or acute mania, ECT can be used at any time if it's needed, right? But what is said in the CPG is that the evidence on the efficacy of ECT is limited. But what we know, but what we understand that is actually a very safe and effective treatment modality in the those suffering from bipolar disorder. Okay, but the evidence for in terms of the benefit of maintenance ECT, this is limited. So they are unable to sort of give a very concrete sort of recommendation. But if clinically we feel that it's necessary, then we might consider maintenance ECT, right? In terms of other psychosocial intervention, very, very important because it studies have shown that those who sort of are involved in certain types of psychotherapies, they actually have better outcomes and quality of life compared to those not on this intervention. So one of the commonest therapy that we offer to patients is CBT. Basically, CBT is an intervention whereby it is based on the principle that our thoughts, our feelings are and behavior, they are sort of interrelated. Most of the times, how we feel and how we react is secondary to how we think. So the aim of CBT is actually to help patients to identify their unhelpful thoughts. A lot of times they might have cognitive errors, they might have negative automatic thoughts, which is sort of causing or worsening their symptoms. So what we do is we try to help them to identify, challenge, and replace these thoughts with helpful thoughts. So CBT is known to be effective as patients who have less than 12 episodes. What CBT does is it reduces the recurrent rates of major mood episodes, and also it helps improve depression, anxiety, mania, and hopelessness in people who were mildly depressed or mildly manic. Coming to the next form of therapy, it's the IPSRT, which stands for Interpersonal Social Rhythm Therapy. So what IPSRT does is that it teaches patients how to have what we call as a circadian rhythm to regulate their sleep-wake patterns, to have a routine at work, meal times, exercise times, and incorporate also other daily routines as well, right? The benefits and of this are key, whereby patients remission longer, they have better relationship functioning, have satisfaction, and they are more likely to remain well clinically and have significantly higher year-end recovery rates as well. They also have better social functioning and also reduces relapse prevention rates. Form of therapy is the group psychoeducation or therapy. So what essentially this is actually patients are actually provided with information so that they can understand their illness and its management so as to increase patient satisfaction as well as compliance to medication. So this is mainly focusing on improving the patient's own awareness of their illness and also teach them how to sort of identify early warning signs, early prodromal symptoms. For patients in the psychoeducation group, as compared to controls, they have less recurrences. They spend less time ill, and there's also a reduced number of hospitalizations as compared to controls. Subsequently, the next form of intervention is the family-oriented interventions. This covers areas such as communication, problem-solving skills, and psychoeducation in order to manage patient's stress in the home environment. So in terms of evidence, a Cochrane systematic review found very limited role of family-oriented interventions, but that family-focused therapy was superior to family crisis management in preventing a relapse, but not in improving medication compliance and dropout rate. In terms of early warning signal, what this essentially is to train the patient to identify and also manage early warning signs of recurrences. So this is the main aim is so that patient able to detect early, intervention is started early, and this would sort of reduce the severity of the manic and depressive symptoms. So those on this early warning signal, they significantly have a prolonged time to first recurrence of any mood episodes, and also improves patient's functioning, reduces hospitalization rate. The recommendation of the CPG is psychosocial interventions should be incorporated into patient's care in addition to pharmacological treatment, and families should be involved in the management of bipolar disorder. So coming on to the risk factors as well as strategies to implement non-adherence. So as we know that bipolar is sort of like a lifelong illness, so most of the time they need to be on medications for a prolonged period of time. So it is actually common for patients not to be compliant to their medications. So it is always important for us to look at what are the risk factors, what are the factors that leads to compliance. Okay, whether or not that they have difficulties with the medication routines. If say for example, patients on combination therapies and they're on BD dosing, whether or not as clinicians we can simplify medications to OD dosing, or just simplifying it to maybe monotherapy if that's possible. Also, we need to explore whether or not patients have a negative attitude towards drugs in general. Means that they sort of people who don't believe in medication. So we need to explore is there attitude towards that. The patient is depressed during the last acute episode might increase the risk of him or her being non-compliant to medication. If there is presence of subsyndromal symptoms, if there is comorbid OCDs, if patients who has substance abuse problem, or those who are younger age, or is because of they're non-compliant because of effects. A lot of our medications can cause sedation, and to some of the patients, they actually experience sedation even during the daytime, right? And this may hamper them from working, and this might be one of the causes of them not taking their medications and cause weight gain. And some of the patients, and actually all of us, we sort of don't really like any medications that increase right? Okay. In terms of bipolarity and suicide, we know that the repeated suicide is much higher in those suffering from bipolar than the general population. It is as high as 10 to 30 times than the general population. And among all the psychiatric disorders, mood disorders has the highest risk of suicide. What are the risk factors associated with suicide in bipolar? In terms of social demographic factors, be male, younger age, unemployed or disabled. In terms of symptomatology, if the patient experiences suicidal thoughts or they have rapid presence of presence, a patient is in the depressive phase of the illness, if they present with hopelessness, or if they are in a mixed state. Clinical factors, characteristics associated with the early onset of mood disorders, history of suicidal attempts in the past, multiple hospitalizations, early sexual abuse, stressful life events, lack of confidence, family history of suicide. In terms of comorbidity, those who have comorbidity with anxiety disorder, early personality disorder, comorbid substance misuse are also associated with higher risk, and treatment duration of less than 5 years. So in terms of what we can do, intervention to sort of reduce suicide rates, what we know is that two systematic reviews found that by giving FRT, which I mentioned earlier, and also ICM, intensive case management, actually reduces suicide rates in acute phase of treatment up to 3-fold and up to 17.5-fold reduction during the maintenance phase from baseline. So if we know how to do the IPSRT, maybe something that we can consider to offer our patients. Right? In terms of pharmacology, lithium is actually very, very effective in preventing suicide. And antidepressants is still controversial because there's no evidence to confirm the benefit of antidepressant monotherapy which helps with protection against suicidality. However, evidence does show that antidepressants in combination with either mood stabilizers or atypical antipsychotics may reduce suicidality in bipolar disorder. So combination, you can consider combining antidepressants with mood stabilizers or atypical antipsychotics. So what in general, the non-pharmacological strategies to prevent suicide is that one of it is to train the primary care physicians in detection of vulnerable patients, restriction of available tools to complete suicide, and also education for family and friends of people with bipolar disorder. So the recommendation of CPG is to prevent suicide in bipolar disorder, healthcare providers should be able to identify the risk factors, and lithium should be considered as the treatment of choice. In terms of comorbid substance use, people suffering from bipolar, studies have shown that up to 60 to 70% of them fulfill the criteria for a lifetime history of substance abuse or dependence. So as compared to the general population, the risk of lifetime illicit use of substances is about 3 times more. And usually it affects men more than women, right? So the recommendation from the CPG is that all people with bipolar disorder should be assessed for comorbid substance use. Okay, lastly, the last part of my presentation will be covering bipolar illness in special populations, mainly women of childbearing age as well as in the elderly population. So every woman of reproductive age need to know the risk and benefit of medication, including the risk of mood disorder in pregnancy and postpartum. What we know is that pregnancy is actually a high risk period for the recurrence or relapse of mood episode, more so during the postpartum period. So if we stop medication or patients want to stop medication, is the risk of them relapsing during this period of time. So in a lot of cases, women especially with bipolar disorder, prior to being diagnosed with bipolar disorder, they actually have higher rates of menstrual disturbances, right? And because of this pre-existing menstrual abnormalities, again, they're at risk of reproductive dysfunction. And our medications that we use to treat bipolar may also cause no changes as well, right? Another thing that we need to watch out for is the effects of contraception. So certain medications that we prescribe to the patient, such as carbamazepine and topiramate, we might render patients who are on OC pills for contraception ineffective. This is because they induce certain enzymes in the liver, which increases the metabolism of these OCPs. Thus, patients may be on OCPs and the potentially of contraceptive failure being able to get pregnant is much higher. So if, on the other hand, those adjustment also may be needed because certain OCP might interact with the medications that we give, meaning they might metabolize certain medications such as lamotrigine. So for lamotrigine to be effective in the treatment of patients with bipolar, we might have to adjust the dose to higher dosage, right? So considering that there might be interaction between our medication and oral hormonal contraceptive. So one possible option would be to consider IUCD. Right? Recommendation 11 by the CPG is that yes, we should discuss with the gynecologist on contraception feel that there is drug-drug interaction. Coming to preconception counseling, so like I mentioned before, women of reproductive age, they should be counseled that pregnancy is sort of like a period of high risk for mood. Okay, if we discontinue mood stabilizers, the risk is much higher, right? And if we discontinue medication abruptly rather than gradually, the risk of recurrence is also much higher. Okay, a few factors which is associated with risk of recurrence of bipolar 1 during postpartum such as younger age and on history of episodes during previous pregnancies, complications during labor. So therefore, relapse prevention and management strategy, including contraceptive option for bipolar, should be counseled to both patients and their partners before pregnancy. The treatment considerations. So most important thing is, again, we need to do a risk benefit analysis. If a person, a lady with bipolar is planning to get pregnant, we need to explain to them, discuss with them risk of taking medication versus not taking medication to both the mother and the fetus, and discuss with them and also their spouse about the best approach. So what we need to do is, like I mentioned earlier, to understand the risk and benefit. So if let's say medications are needed during pregnancy, CPG says that advisable to wait after the first trimester due to teratogenic risk. However, I think this should be case by case basis, because we should always look back at the patient's past psychiatric history, how bad were their previous relapses, and to decide whether or not they need to continue the medication. If we think that medications is indicated, we have to generally try as much as possible to give monotherapy, lowest effective dose, and also medications which are not known to be teratogenic for the fetus. Okay, so in terms of lactation as well, breastfeeding basically, the maintenance of optimal maternal mental health again is the primary goal in treating women who choose to breastfeed. So the mothers should be educated about the possible side effects and advised to discontinue breastfeeding if their infants develop any side effects while taking the medication. So what is important, especially for those suffering from mood disorders, sleep is actually very, very important for them. So, but during pregnancy, postpartum period, and breastfeeding, patients' sleep might be affected as well. So again, we need to sort of balance the benefit of breastfeeding and weighing it against the potential risk of relapse secondary to sleep deprivation. Okay, so just touch a bit about this. Medications that we use in pregnancy, there is a safety rating by the US FDA. So the rating goes from A, B, C, D up to X. A means that controlled study shows that a particular medication has no failed to demonstrate a risk to the fetus. Means generally it's safe. B is also generally considered as safe, where there's no evidence of risk in humans. Most of our medications fall in category C and D. D is basically we cannot rule out the risk. Basically, there's lack of adequate or well-controlled human studies. Animal studies are either lacking or they have shown that there's risk to the fetus, right? And subsequently, the category D means that there are positive evidence of risk, means that human studies shown that the medication if you give to pregnant mothers, there is a positive risk of teratogenicity as well. If it's under category X, means that it is contraindicated during pregnancy and should never be given. In terms of lactation risk categories, medications also have can be categorized based on this, right? To see whether or not they are safe to be, whether or not patients taking certain medications are safe to breastfeed or not. Right? So L1 is the safest, L2 safe, L3 is moderately safe, L4 is possibly hazardous, and L5 is contraindicated. Okay. So this is a summary of the common medications that we use to patients with bipolar. So if we look at the pregnancy risk categories, lithium is category D, means that potentially is teratogenic. So what it can potentially cause is what we call as the Epstein's abnormality, where it's a congenital tricuspid valve abnormality. Okay, carbamazepine is D, epilin is D as well, because it has the potential to cause neurotube effects. Notrigine is C. In terms of atypical antipsychotics, most of the ratings are pregnancy category C, except for clozapine, which is right. In terms of SSRI, most are category C as well, except for paroxetine. In terms of safety for mothers to breastfeed, lithium is L4, means that is possible hazardous. epilim is also L4. The rest of it is between L2 to L3, which is sort of considered as safe. So individually, this is like I've mentioned before. Most of the SSRIs are in the FDA pregnancy risk. Okay. MSD due to the risk of Epstein anomalies. Corporate is D as well because of risk of neurotype effects, which can occur as high as 1 to 2%, which is actually 10 to 20 times higher than in rural population. Most of our atypical antipsychotics are safe, not safe, that there is no definite risk. Risk cannot be ruled out. Okay. And in terms of benzodiazepines, they are under category D because certain studies have indicated that there's an increase in oral clefts. Okay, so this is the flow chart of how to manage a patient who is planning either to conceive or already pregnant. So basically, what we need to do is you need to always discuss with the patient partner. Look back at the patient past psychiatric history, past medication history, and then you decide whether or not this patient sort of needs the medication or not, right? And if it's really indicated, then again use monotherapy, use the lowest effective dose, use safer alternatives, which is your antipsychotics, right? And always refer to the ONG team to follow up or for a detailed plan. So next recommends to consider. So if a pregnant lady there's no response to medication, severe mania, NICE recommends to consider ECT. Women with bipolar disorder, they should who wants to breastfeed should be informed regarding the possible side effects of medication to their infants and to seek immediate medical opinion should they occur. So the recommendation is that women with bipolar of reproductive age plan for pregnancy and are taking psychotropic medication be counseled regarding the risks and benefits of using such medication. Abrupt discontinuation of the mood stabilizers in pregnancy and postpartum should be avoided. So if you want to stop, we should taper gradually. Mood stabilizers should be used with caution in bipolar with pregnancy in view of teratogenic risk. So the safer alternatives if you want to use would be our atypical antipsychotics. Okay, so coming on, lastly is the special populations on elderly. So psychoeducation and psychotherapeutic support as well as medications, they are very important components in the treatment of bipolar in the elderly. Elderly people, they are increased risk, they're more sensitive to side effects. They might have more comorbid medical illness, more medication. More medication means that there's potentially more drug-drug interaction as well, right? So in terms of pharmacological considerations for elderly, although there are no specific guidelines, we'll try to maintain with monotherapy. So lithium, epilim, carbamazepine, and lamotrigine, either alone or in combination with atypical antipsychotics or antidepressants, they are beneficial for this group of patients. Okay, so in terms of studies, both lamotrigine and lithium, they are effective, efficacious in the maintenance therapy. However, if elderly patients, they are on lithium, they might have a higher risk of lithium toxicity. They are on certain diuretics such as loop diuretics or ACE inhibitors. And the target serum lithium level for the elderly, the range of it will be lower, somewhere between 0.4 and 0.7. Also, they require a lower dosage of lithium than younger patients. So caution should be taken while prescribing medications in the elderly with bipolar disorder due to reduced metabolism and susceptibility to side effects. The role of ECT in the elderly population. So ECT can be the treatment of choice for the elderly if they are refractory to the pharmacological management. They have severe symptoms which requires a rapid response. ECT is basically a very, very safe modality of treatment whereby the mortality rate associated with ECT in elderly is 0.01%. It is effective and safe in depressed elderly patients who respond poorly to medication. But of course, what we worry is that the cognitive deficits after ECT might be present in this group. Okay, so the recommendation of the CPG is that medications for elderly with bipolar disorder will be prescribed at the lowest effective dose, and you might want to consider ECT if they respond poorly to medication, and you have to use it with caution due to the cognitive deficits. Okay, with that, I thank you.
Tengok. Okay, terima kasih kepada Dr. Hati Chun Kiat di atas ceramah yang telah disampaikan. Sebelum tu kita tengok dalam ruangan chat ni ada soalan untuk daripada audience. Soalan pertama, is there possibility patient with bipolar medication such as mood stabilizer to reduce the dose or withhold treatment?
Is there possibility patient bipolar medication? Is there possible patient bipolar such as mood stabilizer or Hello, hi. Thank you for the question. Yes, I think we can always consider lowering the dose of the medication if patient has very few episodes in the past, and every time when they have an episode, it's not severe. What is important is by doing that, we need to always psychoeducate the patient regarding the early warning signs so that they sort of realize and they can immediately come to seek treatment in the event they have these early signs and symptoms. We should also psychoeducate them about potential of relapse and recurrence because we know bipolar is a lifelong illness as well. If there are certain things which can reduce, mitigate from getting a mood episode would be them having a routine in their life, managing stress well, having good coping skills. So if those areas are enhanced, then medication reduction is also a possibility as well. Thank you.
Alright, terima kasih kepada Dr. Ryan di atas jawapan yang terhadap soalan yang diajukan. Soalan kedua daripada peserta ialah untuk Dr. Azidah lah, untuk presentation ataupun ceramah skizofrenia sebelum ini. patient with having psychotic symptoms and like to wander around for years. There is no proper assessment done and not seeking treatment and not causing problem to community. Did we need to treat this patient? Is there any indication for therapy for this patient?
Okay, thank you Anwar. Dengar ke tak?
Dengar doktor.
Dengar, okay. Soalan yang tertunda. Okay. Saya repeat balik dia punya question. Patient wandering for years. Lepas tu apa lagi? Soalan poinnya?
Schizophrenia, wandering for years, not
Non-case ke belum diagnose? Tak dengar Anwar.
Patient having psychotic symptoms, however, no proper
Assessment done lah. So
Done.
not diagnosed to have any
mental illness.
mental illness lah. Okay.
Yeah.
Sebab soalan tu dia tak clear betul-betul. Psychotic symptoms tu meaning apa? And then wandering can be part of patient schizophrenia punya patient tendency lah. Ada we have nak kata a lot of cases tu, tapi ada cases patient kita yang memang likes to wander lah. Dekat Kuantan ni pun ada few yang likes to wander. Okay, whether to treat or not, still we have to bring patient for assessment sebab we have to see whether the psychotic symptoms tu fall into schizophrenia or not, because patient have so many reason to wander kan. They can be schizophrenia, they can be gelandangan, they can be having dementia probably. So still we have to bring those yang wander tu for assessment and treat accordingly. Kena ada some involvement daripada jabatan lain lah kot. Kalau ada family member, kalau perlu involve police, probably police or jabatan kebajikan masyarakat. Macam tu. So jangan simply assume that patient yang wandering tu, orang yang wandering tu is having mental illness. Still you need to bring patient for assessment and treat accordingly. Okay, adakah menjawab soalan? Tapi psychiatric punya ni tak pergi ambil lah dia orang untuk masuk ward. Tu tak boleh lah. It's beyond our role lah tu. Okay, terima kasih kalau menjawab soalan.
Okay, terima kasih Dr. Azida. So kita bagaimana dengan Dr. Azrina? Adakah ia menjawab soalan yang diajukan untuk dua-dua soalan ni? Okay. So seterusnya bagi menghargai penceramah kita Dr. T. Chung Kiat di atas kesudian menyampaikan ceramah di atas tajuk CPG on Refresher Bipolar Mood Disorder in Adult. Saya menjemput Dr. Hajah Umi Kalsum untuk menyampaikan sedikit cendera mata kepada Dr. T. Chung Kiat. Okay. So setelah selesai penyampaian cenderamata kepada penceramah kita Dr. T. Chung Kiat, majlis akan berhenti rehat sekali lagi bagi memberi laluan kepada makan tengah hari dan pengurusan diri bagi setiap peserta lah. Slot berikutnya akan bermula pada jam 2 petang. Maknanya para peserta diminta hadir ke ruangan khusus lebih awal lah untuk memastikan kelancaran khusus. So dengan itu kita akan berjumpa sebentar lagi dalam pukul 2 petang. Slot seterusnya akan akan bersama dengan penceramah kita daripada Hosyas, iaitu Dr. Firdaus Abdul Ghani. Assalamualaikum warahmatullahi wabarakatuh dan selamat tengah hari. Assalamualaikum warahmatullahi wabarakatuh dan selamat tengah hari. Selamat datang sekali lagi kepada semua peserta-peserta khusus kita pada hari ini, iaitu khusus CPG Refresher Course on Severe Mental Illness and Suicide Risk Management in the Hospital. So slide seterusnya, kita akan teruskan khusus kita pada hari ini dengan slot ceramah seterusnya yang akan disampaikan oleh Dr. Firdaus Abdul Ghani yang bertajuk Refresher CPG Management on Major Depressive Disorder. Beliau merupakan pakar psikiatri daripada Hoshas. Sebelum kita mulakan slot ceramah seterusnya, izinkan saya membacakan sedikit latar belakang mengenai Dr. Firdaus. Beliau sekarang ini berkhidmat di Hospital Sultan Haji Ahmad Shah Temerloh, Pahang. Beliau merupakan ketua jabatan di Jabatan Psikiatri dan Kesihatan Mental Hoshas. Beliau telah menamatkan degree dalam perubatan di Universiti Melaya pada tahun 2001 dan telah menamatkan juga master dalam psikiatri di Universiti Sains Malaysia pada tahun 2009. Dia mempunyai pengalaman yang luas dalam bidang psikiatri dan merupakan supervisor juga kepada master student yang sedang menjalani master program lah untuk psikiatri. Tanpa melengahkan masa, saya menjemput Dr. Firdaus Abdul Ghani untuk menyampaikan ceramah beliau. Dengan segala hormatnya, dipersilakan.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam kesihatan mental kepada semua. Ya. Terima kasih pada Dr. Anwar selaku pengerusi majlis untuk CPG Refresher kita pada hari ini. Saya bukan wakil kepada Dr. Firdaus, ya. Saya memang Dr. Firdaus sebab mungkin orang-orang peserta daripada Pahang Tengah mungkin tahu Dr. Firdaus Khoshiasi perempuan, tapi mungkin kalau Pahang Timur ataupun Pahang Barat kan mungkin menantikan doktor psikiatri yang handsome, kacak dan bergaya. Jadi satu kekeliruan ya yang biasa berlaku. Jadi hari ini kita akan bercerita sedikit tentang CPG MDD ya. Dan ini adalah second edition, edisi kedua untuk CPG kita. Edisi pertama ya menarik ya, saya nak share sedikit some facts about CPG. Dalam dunia psikiatri, CPG pertama yang dihasilkan adalah CPG MDD, iaitu pada tahun 2007. Dan saya alhamdulillah diberi peluang untuk sama-sama menjadi kumpulan penulis bagi CPG yang kedua yang diterbitkan pada tahun 2019. Jadi pada asalnya kita bercita-cita untuk menghasilkan CPG tersebut lengkap dalam masa 1 tahun sebab kita kata ini cuma satu revision, tetapi sebenarnya masih lagi memerlukan 2 tahun. 2 tahun merupakan satu tempoh purata satu CPG disiapkan ya. Jadi kenapa sampai 2 tahun juga ialah kerana terlalu banyak perkembangan daripada segi ubatan, daripada physical treatments dan juga psikoterapi sepanjang 10 tahun. Jadi itu yang menyebabkan kami masih lagi mengambil masa 2 tahun seolah-olah macam kita buat CPG baru. Jadi saya mungkin nak sentuh sedikit perbezaan antara CPG pertama dengan CPG kedua. Apa beza dia? Pertama sekali ialah kalau kita lihat untuk CPG yang kedua lebih banyak kita terapkan pendekatan psikososial dan juga psikoterapi ya. Kalau sebelum ni lebih banyak cerita tentang CBT, tetapi untuk CPG yang kedua second edition banyak kita cerita tentang third wave CBT dan juga kaedah psikoterapi yang lain. Itu satu. Yang kedua, dari aspek special population, CPG pertama cuma menyentuh tentang geriatric population. Tetapi CPG kita yang kedua, kita juga menyentuh tentang pregnancy and postpartum, perinatal population dan juga kumpulan yang berisiko untuk mendapatkan depression yang kita selalu lihat di primary care, iaitu people with chronic medical illness. Dan daripada segi treatment, ya, apa yang kita lihat untuk CPG terkini, kita turut menyentuh tentang rawatan intravenous ketamine bagi acute phase of treatment dan juga extranasal ketamine bagi treatment non-responders ataupun treatment resistance. Okay, jadi tanpa melengahkan masa, mungkin saya boleh share dulu slide ya, sebab hari ni satu challenge untuk kita siapkan dalam masa 2 jam ya, untuk satu kursus ya, selalunya CPG MDD training ni mengambil masa 2 hari ya untuk kita habiskan, tapi saya akan cuba dengan kuasa luar biasa saya untuk cakap dengan sangat laju ya, insyaAllah. Okey, tetapi jika ada apa-apa persoalan, ada apa-apa kemusykilan, bolehlah terus bertanya di ruangan chat ya. Okey, saya harap para peserta boleh lihat ya slide saya. Okey, jadi hari ni sebab saya selalunya kalau pergi kursus ataupun webinar kan, mesti tertanya-tanya berapa banyaklah agaknya slide kita ya. Ini ada 100 slide ya untuk saya habiskan dalam masa 2 jam, tak termasuk slide tajuk dan slide terima kasih. Jadi 98 slide. Okey, jadi apa kandungan kita pada hari ini? Kita akan bercerita tentang screening. Untuk mereka-mereka yang duduk di primary care, ya, klinik kesihatan, screening is very, very important. Then we look into assessment. Okey, sebelum tu saya nak minta izin juga untuk menggunakan 2 bahasa kerana saya lihat peserta kita pada hari ini juga termasuk paramedics. Ya. Jadi mohon maaf jika saya menggunakan bahasa Malaysia diselang-seli juga dengan bahasa Inggeris ya, sebab I want it to benefit everyone. Jadi semua orang boleh dapat manfaat daripada perkongsian kita pada hari ini ya. Okey, dan the third content ya, konten ketiga kita akan berkongsi tentang collaborative care model, seterusnya psychosocial and psychotherapy intervention. Yang ini ya, dan saya kata berbeza dengan CPG kita yang pertama, banyak ruang yang kita kongsi tentang rawatan psikososial and psychotherapy. Dan ini sebenarnya yang banyak pesakit kita cari. Ya, sebab most of them, terutama orang yang pertama kali dapatkan rawatan psikiatri, mereka agak kurang cenderung untuk memilih farmakoterapi. Tetapi memang ada kategori pesakit di mana kita memang boleh gunakan psychosocial and psychotherapy without pharmacological involvement ya. Dan seterusnya a big chunk of my presentation will be on pharmacotherapy. Bila kita menyentuh aspek pharmacotherapy, kita akan bercerita tentang acute, maintenance and also next step ataupun treatment resistant depression. Pada masa kini banyak literature ataupun banyak kita panggil ya kertas kerja yang tidak menggunakan terma treatment resistant depression. Mereka banyak menggunakan pakai treatment non-responder ataupun the next step. Jadi kalau anda melihat ataupun mencari paper tentang treatment resistant yang terkini, mungkin perlu lihat tentang the next step ataupun treatment non-responder. Ya, okey. Dan kita akan bercerita tentang physical treatments diikuti dengan complementary and alternative treatments. Ini juga sentiasa pesakit kita bertanyakan, selain daripada ubat, selain daripada psikoterapi, boleh tak saya makan vitamin misalnya? Boleh tak saya ambil herba-herba? Jadi kita akan share ya apa yang kita jumpa ya, termasuklah tentang acupuncture, ya, exercise, yoga, semua ini ya. Dan seterusnya kita akan bercerita tentang special populations ya. These 3 special populations include perinatal, elderly and those with chronic medical illness. Dan last but not least, kita akan bercerita mengenai monitoring and follow up ya. Okay, how high is the prevalence of depression ya? Saya kira ramai agak familiar ya, mereka yang di psikiatri bercakap tentang kesihatan mental akan guna pakai prevalence yang telah digunakan, yang dijumpai oleh National Morbidity Health Survey 2019, di mana mereka mengatakan kira-kira 500,000 penduduk Malaysia mengalami gangguan kemurungan ya. Jadi about 2.3% ya. But from the literature that we search, these are the findings ya. Kita melihatkan bahawa global prevalence of MDD ya adalah 4.7%. Tetapi perlu diingatkan ini adalah perangkaan sebelum berlakunya COVID ya. Selepas berlakunya pandemik COVID, banyak kita lihat peningkatan kepada jumlah pesakit yang datang bukan sahaja untuk kemurungan tetapi juga disebabkan oleh anxiety ya. Saya kira siapa-siapa yang bekerja di klinik kesihatan juga mungkin dapat melihat peningkatan ini, ya, bukan sahaja kita yang bekerja di psikiatri tetapi mereka di klinik kesihatan, ya. Saya rasa mungkin dapat lihat the same trending of patients coming in to seek treatment, both anxiety and depression, ya, because COVID is not only medical phenomenon but is also economic phenomenon. Dia menyebabkan orang hilang kerja, dia menyebabkan ramai orang yang terpaksa mencari sumber lain untuk meneruskan mata pencarian misalnya, ya. Banyak disebabkan oleh faktor sosioekonomik ini menyebabkan ramai yang menderita kemurungan, ya. Jadi kita lihat tentang prevalence of MDD in Malaysia, ya. Dia apabila kita melihat prevalence ini, dia akan berbeza mengikut populasi yang kita lihat, ya. Kalau kita lihat di general population, it is between 8 to 12%. Average estimation is about 10%, ya. Untuk di primary care, kalau kita lihat maybe up to 14.4%. Mengapa lebih tinggi berbanding general population? So kita perlu ingat yang mereka yang pergi ke primary care adalah mereka yang mengalami chronic medical illness, diabetic, hypertension, ya. These are the kind of people which actually have high risk of developing depression, dan kita memang akan sentuh ini secara spesifik dalam slide-slide yang berikutnya, ya. Dan elderly, ya. Kalau kita lihat dua studi berbeza menunjukkan prevalence yang berbeza. Ada yang mengatakan 6.3% and can be up to 18% in general population, ya. As we know, elderly, the prevalence of depression is actually higher than the normal adult population. Cuma kadang-kala kita tidak detect. Dan apabila mereka datang ke primary care, the complaints is not normally on complaints of low mood, but normally of somatic complaints. Jadi nanti dalam kita punya slide tentang elderly, kita akan senaraikan what are the symptoms that you need to be aware of, yang mungkin menyatakan bahawa pesakit ini sebenarnya mengalami kemurungan, ya. Can be as simple as constipation, ya. And last but not least, women, as we know, they have twice the likelihood of developing depression. Ini adalah global findings, not only in Malaysia, tetapi seperti yang kita ketahui, untuk kemurungan kadarnya adalah lebih tinggi 2 kali ganda untuk wanita. Jadi wanita-wanita di luar sana kena berhati-hati, ya. Ada kena risiko tu lebih tinggi, kena jaga diri, kena ada self care, kena ada coping skill yang bagus, ya. Okey. Jadi kita menyentuh tentang screening, ya. Ramai apabila kita lihat, ya, tentang banyak kesedaran tentang kesihatan mental kebelakangan ini, ya. Akhir-akhir ini banyak orang bercerita tentang kesihatan mental. Jadi ramai orang kata dia nak buat screening untuk depression. Tetapi sebenarnya jika kita nak buat universal screening, maksudnya kita nak screen semua orang, ia adalah tidak cost efektif, ya. Dan based on kita punya review dalam CPG kita, there is insufficient evidence to perform screening for depression in the general population. So maksudnya di sini, kalau nak buat screening, kita perlu fokus kepada golongan yang berisiko, ya. Jadi siapakah golongan yang berisiko? Ini adalah senarai mereka yang mempunyai risiko yang tinggi untuk mendapat kemurungan ataupun depression, ya. Those with family history, especially first degree relative, ya. Seperti yang kita ketahui, berbanding dengan psychotic disorder, mereka yang mengalami mood disorder, the genetic inheritance lebih tinggi, ya, untuk mood disorder, ya. Kalau kita ada ahli keluarga yang ada mood disorder, kebarangkalian untuk kita dapat mood disorder lebih tinggi berbanding untuk dapat psikosis bila kita ada keluarga yang ada psychotic disorder. Itu based on genetic inheritance, ya. Those with chronic disease. Sebab tu kita sarankan di primary care untuk menyaring mereka-mereka yang mempunyai chronic diseases, ya. Nanti ada 5 CMI yang kita suggest untuk kita saring dalam CPG kita. Those with obesity, those with chronic pain, backache, headache, these are sometimes things that we miss out, ya, because it can be existing condition ataupun it is a somatic complaint, ya. Jadi ia boleh jadi disebabkan oleh back pain yang berpanjangan menyebabkan mereka depressed sebab ada impairment of function, ataupun worsening of back pain ataupun chronic pain disebabkan oleh kemurungan yang mereka ada, ya. Kita tahu kan serotonin yang juga berperanan dalam depression juga terlibat dalam pain pathway. Jadi kalau siapa-siapa yang buat master, memang saya kira agak familiar tentang pain pathway. Sebab tu psikiatris belajar juga tentang pain pathway berkait rapat dengan serotonin, ya. Impoverished home environment, ya, those with low social economic status, financial constraint. Ini yang saya cakap tadi, lepas pandemik banyak, ya, yang datang untuk kemurungan because those with low socio-economic status, financial difficulties, they are at risk of developing depression. Also those with experiencing major life changes. Apa major life changes ni? So ramai orang dia kata mungkin major life changes is, for example, berpindah ke tempat baru. Tetapi ada juga life changes dalam hidup kita yang menggembirakan tetapi juga carry certain risk of stress. Contohnya getting married, for example, or even getting a promotion, naik pangkat pun comes with certain level of stress, ya. And we should also screen people who is pregnant and postpartum period, ya. And those who is socially isolated, people with multiple vague symptoms. Orang yang datang kepada kita dengan non-specific symptom, ya. Hari ni sakit kepala, sakit bahu, pain, abdominal pain, ya, yang tidak spesifik, ya, banyak, ya, yang datang dengan yang biasa kita lihat sama ada headache ataupun abdominal pain ataupun back pain. These are the common somatic symptoms presented by our patients who apparently suffer from depression, ya. Those with sleeping disturbance, ya. Sebab orang tidak akan tiba-tiba ada masalah tidur. Jadi kalau katalah ada pesakit yang datang kepada kita mengadu susah nak tidur, ya. Jadi perlu korek sikit cerita, ya. Ada tak symptoms of depression? Ada tak recent stressor? Ya, ataupun anxiety can also cause sleep disturbances, ya. Even psychotic disorder also may cause sleep disturbances. So those especially elderly, quite common for them to come to you complain of saya susah nak tidur, ya. Explore, jangan terus bagi benzodiazepine, ya. Nanti ada risk of dependence sebab kita tidak treat the root cause, ya. Seterusnya mereka yang mengambil substance, alcohol, illicit drugs. Mengapa? Bukan saja substance, alcohol, illicit drugs can cause mood disorders or mood symptoms, but ada setengah orang mereka mengambil substance sebagai satu cara untuk merawat kemurungan, self-medicated, ya. Those with loss of interest and sexual activity, and of course you also should screen elderly, ya. So kalau kita nampak dekat sini adalah special population nanti yang kita sarankan untuk kita buat screen, ya. Nanti kita akan share tentang those elderly, postpartum, perinatal, ya, and also chronic medical illness. So dia ada dalam category of people that we need to screen. Okay, jadi kalau kita nak screen, ya, kalau kita lihat kepada beban kerja mereka di primary care adalah agak tinggi, ya. Pesakit yang datang hypertension, diabetes, tak termasuk mereka yang datang walk in untuk primary complaints of physical health, kan. Ramai yang datang dan mungkin beban kerja ni agak tinggi. Jadi kalau kita nak sarankan satu medium untuk mereka screen, kita perlu satu medium yang user friendly, yang mudah, yang orang tidak akan rasa hesitant untuk buat, ya. Dan recommendation melalui CPG adalah menggunakan woolly questions, ya. Dan macam saya sebut tadi, may be considered in people at risk, not to all patient attending primary care, ya. People at risk because they are considered to be higher risk of getting depression, and as we know, ya, the level of detection is actually quite good with woolly question. Apa itu woolly question? Mungkin soalan seterusnya nak tanya, apa itu woolly question? Okay. Woolly question ni ada dua soalan sahaja. Jadi agak mudah untuk mereka di primary care untuk bertanyakan soalan ini. Ya, kalau 2 soalan ni mungkin ambil masa tak sampai pun 1 minit. Okey, apa dia kandungan dalam woolly questions? Ya, dalam sebulan yang lepas, adakah anda terganggu oleh masalah berikut? Pertama, adakah anda merasa murung, sedih atau tiada harapan? Jawapan dia cuma ya ataupun tidak. Yang kedua, kita tanya kurang minat atau keseronokan dalam melakukan kerja-kerja. So, ini adalah 2 questions dalam woolly. Ya. Kalau mereka jawab ya kepada salah satu, ya, kepada soalan woolly ini, maka you should proceed with further history taking to elicit whether or not they have depression. Okay, tapi kita screen dulu menggunakan 2 soalan yang tertera di layar ini. Ya, okay, sangat efektif kalau kita lihat dia punya sensitivity dan specificity dia juga adalah tinggi. Jadi dia agak accurate. Ya, walaupun kita lihat, oh agak senang ya dia punya soalan ni. Jadi bukan alasan kita tak tanya kepada pesakit kita. Okay, alright. Dan kita lihat kepada assessment. Apabila kita screen patient dan kita dapati mereka mengalami gejala suggestive of depression, ya, suggestive. Apa yang kita perlu tanya, ya? Sebab dalam kita menentukan jenis rawatan, 2 perkara ini penting, ya, sebagai basis dalam perawatan psikiatri. Satu, assessment of diagnosis, whether or not this is depression or not. Itu satu. Kedua, what is the level of severity? 2 ni. Determine diagnosis, determine the severity. Sebab based on the severity, dia akan menentukan apakah rawatan yang boleh kita berikan kepada pesakit. Okay? Jadi, dalam kita mendiagnosakan MDD, seperti yang biasa kita gunakan, menggunakan DSM-5, ya, dan perlu memenuhi, ya, total number of symptoms criteria, dan kita perlu menentukan severity and extent of functional disability. Ya, kalau kita diagnose depression, mereka perlu ada low mood and hedonia. Ini adalah 2 yang kita panggil sebagai mandatory, ya, diikuti oleh simptom-simptom yang lain tu seperti loss of weight, loss of appetite, poor concentration, hopelessness, suicidality, kan. Jadi total number of symptoms criteria must fulfill the criteria of MDD, ya. Yang kedua, kita perlu tentukan severity and extent of functional disability, ya. Sebab apa yang membezakan antara kesihatan mental ataupun penyakit mental adalah function, ya. Kita mungkin ada rasa susah hati, tetapi kita masih boleh bekerja, ya, dan perasaan susah hati itu mungkin datang sekali-sekala, ya. Jadi itu tidak memenuhi masalah penyakit mental, tetapi sekiranya it is prolonged, it is persistent, ya, dan menyebabkan ketidakfungsian dalam tugas harian kita, maka the likelihood that it is a mental disorder, it is likely that this is depression. And how do you determine? So kita akan berguna pakai kaedah history taking, mental state examination, physical examination and investigation where indicated, ya. So dalam history taking, yang penting tentukan dia memenuhi semua kriteria untuk depression. Dan untuk mental state examination, apa yang perlu anda lihat, ya, untuk orang yang mengalami kemurungan, biasanya mereka avoid eye contact, not very forthcoming, sometimes tearful during interview, and the amount of speech is usually limited. These are the things that you can give an idea, probably this patient suffer from depression, ya. Physical examination, look for goiter. Look for other symptoms or signs that suggest that this could be some organicity. Ya, organicity, tengok patient tu, oh ada stroke misalnya, this could be post-stroke depression. So physical examination is also important. And investigations, ya, walaupun kita tulis investigation where indicated, tetapi apa yang kita sarankan untuk dilakukan sebagai baseline investigations adalah seperti FBC, ya, RP, LFT, especially when you want to start treatment, ya, and thyroid function, ya, because some of the symptoms, ya, of hypo or hyperthyroidism can be irritability or low mood symptoms. So you might miss this, okay? Jadi ini recommendation kita, ya, untuk assessment, ya, bukan saja untuk assess the diagnosis, ya, but also to assess the severity of major depression, because this will help you to determine the mode of treatment. Okay, alright. Saya tak go through dengan detail setiap symptoms tu kerana kita agak well versed, ya, dengan symptoms criteria of DSM-5, ya. And what I want to do is that we will sail through all the important details dalam CPG ni, dan saya akan pinpointkan apa yang perlu anda tahu sebelum kita pergi kepada conclusionnya. Nanti di akhir presentation saya akan simpulkan what are the things that you need to know, ya, before we end, ya. Okey, bagaimana pula tentang suicide risk? Seperti yang kita ketahui, kemurungan major depression is associated with suicide, ya. Dan suicide ni esok kita akan ada 2 lecture yang lebih detail mengenai suicide risk assessment yang akan disampaikan oleh Dr. Umi dan Dr. Miharbi kalau tak silap saya. Tetapi saya suka nak ingatkan, kalau patient datang dengan symptoms of depression, ya, tak boleh tidak kena tanya tentang suicide. Kena tanya, ada tak rasa nak bunuh diri? Kena, ya. Kalau master student dapat case depression, tak tanya suicide, boleh fail. Ya, sebab ini dimasuk dalam kita punya risk assessment, ya. Potential harm to self, potential harm to others. So suicide is mandatory to be asked when patient present to you with depressive symptoms, ya. And dalam CPG ini kita menyarankan supaya suicide risk assessment tool should only be used to complement a detailed clinical assessment, ya, and a structured follow-up management plan while building good therapeutic alliance with the patients. Which means that tak semestinya semua patient kita kena assess menggunakan tools. Kita punya clinical assessment is good enough. But if you want to do a tool for assessment, what we recommend is probably the most common one is the back suicide intent scale. So this will be an objective assessment. Tetapi the mainstay of assessment is still your detailed clinical assessment. Okay. Seterusnya, kita lihat tentang risk factors for suicide. Apakah risk factors for suicide, ya? Selain daripada yang sering kita guna pakai adalah sad person, ya. Saya rasa kebanyakan petugas kesihatan agak familiar with the sad person scale yang juga digunakan dalam guidelines of suicide risk management in hospitals, ya. Tetapi yang ini kita berkongsi tentang apa yang telah review dalam our previous CPG, 2007. Risk factors adalah termasuk loss of relationship, financial or occupational difficulties, patient with poor social support, past suicide attempt. Ini sangat penting, ya. Dalam kebanyakan kajian, a lot of study mengatakan prediktor yang paling tepat, significant predictor untuk suicide adalah previous attempt. Kalau orang tu ada previous attempt, kena hati-hati because this is actually a significant predictor for them to commit suicide, ya. Family history of suicide, ya. Saya ingat waktu saya master dulu, saya suka baca tentang genetics of suicide, ya. Saya come across to one of our Nobel Prize winner, ya, Ernest Hemingway. So kalau mungkin tuan-tuan puan-puan ada masa, boleh Google tentang Ernest Hemingway, Nobel Prize writer, penulis tersohor, ya, yang suffer from depression. and he committed suicide. Interestingly, his father and also grandfather also committed suicide, and they come from a very well distinguished family. So from then, they feel that whether or not there is a link between genetics and suicide. But we have actually seen patients with family history who committed suicide. Ramai mengatakan it's not only genetic, tetapi juga mungkin ada elemen modeling juga. Jadi something that we can discuss. Okay. Then alcohol abuse and dependence. Kalau orang tu ambil substance, ya, dia akan menyebabkan rasa hesitant dia untuk mencederakan diri tu kurang. Sebab tu banyak, ya, bila kita buat kaji selidik. Saya ingat masa kita buat tahun 2014, kita buat multi-center kajian tentang profiles of deliberate self-harm. Kita tanya tentang usage of substance and alcohol prior to self-harm. Ya, agak quite a number memang ambil alkohol supaya mereka tidak teragak-agak untuk mencederakan diri. Ya, bukan senang, ya, kita nak cederakan diri kita. So when you take alcohol, your hesitancy tu akan berkurangan. Dia menyebabkan dia lebih berani untuk bertindak. Ya, those with other medical comorbidities, ya, suicidal ideation. Ni berbeza, ya, suicide ideation and attempt. Sebab tu kalau kita refer case, kalau katalah dapat referral daripada KK ataupun daripada district hospital, kita tanya in detail, is this suicidal ideation? Does patient has suicidal plans? Do they have any suicidal attempt or not? Berbeza setiap satu, ya. Sebab suicidal ideation, maybe they have thoughts ataupun idea of committing suicide, but they don't have plans. Maka dia punya severity tu kurang berbanding patient yang ada suicidal ideation dan dia ada plans. Ini lagi kita kena lagi aware, ya, red alert dah, ya. Dan satu lagi, dia ada suicidal ideation dan ada plan dan dia juga pernah ada previous attempt. Ini tak boleh tidak, memang kena admit, ya. Biasanya kalau ada plans tu memang kita akan kata okay, advice for admission, ya, sebab dah ada plans tu, ya. Okay, severity of depression, ya, those with especially with very severe depression, ya. Kita tahu untuk depression kita ada mild, ya, dan kita ada moderate to severe, mild, moderate and severe. So patient yang depression yang severe biasanya mereka ada suicidality, mereka ada psychotic symptoms, ya. Okay, those with psychomotor agitation, those with low self-esteem and feeling of hopelessness. Salah satu cara di mana kita nak assess whether or not patient ni ada hopelessness adalah kita tanya plan dia, ya. Kadang-kadang kita tanya ketika pesakit, kita jumpa pesakit tu, kita tanya lepas ni apa plan, apa nak buat lagi, ya. Kalau dia kata ada plans, dia lepas ni nak cari kerja, lepas ni dia nak pergi buat satu hobi yang baru misalnya, kan, then it's good, because that shows that they don't have this feeling of hopelessness. Biasanya orang yang ada feeling of hopelessness, bila tanya dia, entahlah doktor, saya tak fikir pun lagi. Yang itu kena sangat hati-hati, because they don't have any plans for their future, ya. Itu yang kita kena berjaga-jaga. Okay. Seperti mana CPG yang sebelum ni, tadi saya lihat Dr. Azida juga ada bercerita tentang kriteria for referral, ya, kepada psychiatric services. Jadi untuk rakan-rakan kita di klinik kesihatan ataupun di hospital daerah, saya lihat ada daripada Muazzam, ya, Jerantut, ya. Ini adalah kriteria yang penting. Walau bagaimanapun saya suka nak ingatkan, ya, kalau anda ada difficulty tentang apa-apa pun boleh saja call the nearest psychiatric facility. Tak semestinya, ya, kena fulfill all these criteria baru call, sebab patient perlu dapatkan rawatan yang cepat, ya. The faster they get treatment, ya, the better their prognosis will be. If you not sure, call psychiatrist. Doktor, saya rasa dia ada gejala kemurungan, ya. Apa perlu saya buat? Sometimes kalau you tunggu untuk sampai ke tarikh TCA, kesian dekat patient. Sebab bila you call psychiatric services, kita mungkin boleh advise, boleh tak start dulu dengan antidepressant. Boleh tak ambil dulu darah-darah yang basic. Ya. So, sementara tunggu temu janji kita. Dan bila kita start dengan low dose medication ni, bila dia sampai kepada kita pada temu janji, kita dah boleh optimize dia punya dos perlahan-lahan dan kita boleh tengok, okey, dia boleh tolerate. Ya. Okey, jadi yang kita paparkan di layar ini adalah indication for referral to psychiatric services. If you're not sure of the diagnosis, if the patient attempted suicide, tapi saya nak ingatkan juga kalau datang dekat hospital district kan, patient tu overdose, patient tu kelar tangan ataupun patient tu selalunya kelar tangan kena tengok juga severity kan. Ataupun kalau patient tu minum paraquat, janganlah terus refer kepada psikiatri semata-mata. Refer juga to the respective team. Ya. Kalau overdose, kalau makan paraquat, kena refer to medical first. Ya. And we will see the patient when they reach the hospital to assess the risk. Ya. You need to call the respective team. Jangan call psikiatri sahaja. Banyak juga yang kita terima, ada kadang-kadang complicated cases, patient pregnant, ingested herbicide, only refer to psychiatry. Tak boleh ya, kita kena tahu where do you need to prioritize. Ya. What is more fatal here. Ya. Tapi bukan kata psikiatrik tak akan datang, psikiatrik akan datang. We will manage the patient accordingly. Ya. Sama-sama serentak, but you need to refer to respective team. Those with active suicidal ideas, those who fail of treatment. Katalah saya lihat ada beberapa daerah yang ada FMS, bagus mereka start patient on antidepressant. Ya. Sertraline, fluvoxamine, these are readily available in the KK. And bila kita tengok dia dah optimize dah dan refer kat kita bila dia kata patient not responding to treatment. Yeah. Advice on further treatment ataupun to get second opinion. Or when patient has clinical deterioration or a recurrent episode within 1 year. And also when patient has psychotic symptoms. Kalau patient major depression with psychotic symptoms, treatment dia biasanya kita akan juga tambah antipsychotic. Yang ini saya akan sentuh dalam segmen pharmacotherapy. Tetapi kenapa kena refer pada psychiatric? Kerana kita perlu assessment juga the content of the voices. Whether it's commanding, is it dangerous? Sebab kadang-kala untuk patient yang ada major depression with psychotic features, biasanya lah kandungan suaranya adalah jenis second person type. Kita bimbang jika kandungan tu menyuruh dia, contohnya membunuh diri, terjun bangunan dan sebagainya. Ya. Dan sebenarnya bila patient ada psychotic symptom, it indicates the severity of depression. Ya. Kalau kita tengok dulu punya DSM-4, memang ada specifier major depression with psychotic features severe. Ya. Maksudnya kalau severe baru ada depression, baru ada psychotic features. Tetapi yang terbaru, dia tak kira severity, they may have psychotic symptoms. Tetapi dalam clinical practice, what we normally see is that the likelihood of getting psychotic symptoms is when they are actually on the severe end. Patient with severe agitation and also self-neglect. Patient yang refuse to eat, refuse to do self-hygiene, kena refer kepada kita. Okay. Jadi kita lihat tentang admission. Di kalangan mereka yang mengalami kemurungan, siapakah yang patut kita admit dan apakah indicationnya? Okay. Seboleh-bolehnya untuk patient depression, kita cuba rawat as outpatient unless they are at risk of harming self, ataupun risk of harming others. They have psychotic symptoms, inability to care for self. They have criteria ni, kita akan advise mereka untuk admit ke dalam ward. Sama ada secara voluntary ataupun involuntary. Ya, jadi voluntary ni lebih mudah, sign borang satu. Ya, patient boleh sign, kita admit secara sukarela ke ward, ataupun kadang-kadang bila patient yang refuse, kita cuba dapatkan keluarga untuk sign borang 3. Kita kata tak boleh bagi patient balik. Kadang-kadang patient ni dia suicidal tapi dia refuse admission. So you get either the family members or the police, ya. Buat laporan polis, POL 57, bagi tahu bahawa pesakit ni berisiko untuk mencederakan diri ataupun mencederakan orang lain, ya. Dan kita admitkan dia ke ward psychiatry. Okey. Okey. Yang ini cuma ada 3 slide tentang collaborative care model. This was not apa tu kita panggil touch during the previous CPG, tetapi ini adalah way to go. Kalau kita lihat CPG yang terkini, yang baru-baru ni, tak kisahlah dalam psychiatry ataupun dalam medical ataupun dalam domain yang lain, mereka banyak menyentuh tentang collaborative care model kerana kita perlu work together with other things, ya, especially for us in psychiatry, ya, kita perlu work together with the primary care setting. Kalau siapa yang mungkin ada di kalangan master student, ya, tengah buat community ke apa ke, mereka akan tengok one of the syllabus is integration with primary care. This is the way to go. Kebanyakan pesakit kita berada di primary care, ya, dan kita kalau kita lihat, ya, kita punya human resource di psychiatry, ya, kalau kita tengok hospital yang ada resident psychiatrist lebih kurang 60 sahaja, ya, tetapi kita ada 1000 lebih klinik-klinik kesihatan. Jadi kita kena mendapatkan bantuan daripada rakan-rakan kita di klinik kesihatan untuk sama-sama, ya, merawat pesakit yang mengalami kemurungan, ya, and they should be the one to be able to screen, to be able to initiate early treatment and also for continuation of care, ya. Boleh rujuk kat kita. Bila patient stabilize, kita pulang balik ke klinik kesihatan dan mereka boleh continue with follow up and treatment, ya. So ini yang kepentingan collaborative care model, and we aim in achieving recovery. Terutamanya dekat Pahang kan, masalah kita adalah logistik, jauh-jauh, ya. Macam kami dekat Temerloh, kami cover Jengka, Jerantuk, Bera dan Maran, dan kita lihat patient duduk jauh-jauh, Fedah dan sebagainya kan. Nak datang ke hospital mahal. Kalau katalah daripada Bera, Purun sana nak datang ke Hosyas, bayar sewa kereta RM100. Jadi macam mana, ya? Acute treatment kita rawat di Hosyas, lepas mereka stable kita try to cooperate with KK, ya, so that they can continue the treatment of patient in the district. So this is the way to go, whereby kita collaborate with our primary care services, ya. Okay, ini adalah the collaborative care model kita, ya. Termasuklah dalam collaborative care model bukan sahaja the collaboration itself, but also the usage of guidelines, patient education and also scheduled patient follow up, ya. Banyak patient kita kadang-kadang dah well, mereka tidak datang untuk follow up. Tapi di klinik kesihatan mereka ada mekanisme di mana dia ada record pesakit-pesakit, ya. Dia ada buku hijau untuk follow up sakit psychiatry dan dia boleh trace, ya, kalau ada defaulter. Tapi ini yang kita kena kuatkan, kemaskan lagi kerjasama dengan primary care. So, collaborative care may be considered in the acute and continuation phase treatment of major depressive disorder. So, they are the nearest services to the patient. Yeah. So, we should empower them to be able to treat and also to follow up our patient. Ya. Dan suka juga saya nak bagi tahu, ya, waktu kita develop CPG MDD second edition, ya, kita ada 2 FMS yang turut terlibat dalam menulis CPG ini dan kita dapatkan feedback dan input daripada mereka untuk bahagian seperti screening, ya, untuk bahagian untuk referral, sebab kita nak dapatkan input daripada user, mereka sebagai user, kan, bukan sahaja kita sebagai psychiatrist. So what you see here is not only the work of psychiatrists but also the work of family medicine specialists, psychologists and also pharmacists. Kalau kita lihat bahagian pharmacotherapy, bahagian monitoring and follow up, banyak contribution daripada pharmacists, ya. Okay. Next we go into the psychosocial intervention and psychotherapy for MDD. Okay. How are you going to choose what type of psychosocial interventions? Yeah. So, ataupun kita kata what are the interventions that you want to offer? It depends on what is your patient preference and attitude, the therapist competence. Terapis ni ada kebolehan ke untuk melakukan psikoterapi? Biasanya untuk psikoterapi, dia perlu train and certified psikoterapis. Kita banyak jenis psikoterapi, nanti saya akan sharekan senarainya. The availability of therapy. Untuk hospital yang mempunyai psikologis, mungkin tidak menjadi masalah kerana psikologis boleh menjalankan pelbagai jenis psikoterapi. Bagaimana pula mereka di KK ataupun bagaimana mula di health district, ya. So kebanyakan KK, kebanyakan health hospital mereka ada counselor. Jadi ada jenis-jenis psikoterapi ataupun psychosocial intervention seperti psychoeducation dan sebagainya boleh dijalankan, masih boleh dijalankan di tempat-tempat yang tiada psikoterapis. Cuma kalau kita nak deliver high-end psikoterapi masih perlukan psikologis ataupun train psychiatrist, ya. Sebab saya perlu perjelaskan juga untuk mereka yang bukan berada dalam bidang psikiatri, walaupun pakar-pakar psikiatri ditrain untuk melakukan CBT, psychodynamic, ya, sewaktu master, tetapi kalau kita nak mengakui bahawa kita expert, tidak, ya, kerana perlu ada training dan juga proper certification. Ya, dan kekangan kita di hospital kerajaan adalah masa. Ya, contohnya kalau CBT dia banyak sesi yang perlu kita buat. Ya, jadi untuk kita yang di tempat-tempat hospital kerajaan, workload yang agak tinggi dan masa yang suntuk, jadi mungkin kita tidak boleh nak bagi CBT yang kita panggil proper CBT. Mungkin kita boleh buat brief CBT. Ya, bergantung kepada your human resources, apa availability of therapy yang ada, ya, and also depends on therapeutic alliance between you and your patients, ya. Ada setengah patient, sebab apa kita sebut juga tentang patient preference, ya, kerana ada juga patient dia tak nak pun psychotherapy or psychosocial intervention. Dia kata saya nak ubat sahaja, doktor. Jadi that's why these are the things that you need to consider. When you want to choose the treatment option selain daripada the severity of depression. Ya, sebab kita tahu untuk mild depression kita boleh get away without starting treatment. Kita boleh just deliver psychosocial and psychotherapy intervention. Ya, tetapi in certain cases when patient kata dia nak rawatan, ubatan, you should also consider. Yang ini kita akan sentuh dengan lebih lanjut dalam bahagian yang lain, ya. Okey. Apakah jenis-jenis psychosocial intervention for MDD, ya? The first one is psychoeducation. This is the most basic psychosocial intervention that you can give for your patients. Semua orang boleh bagi psychoeducation. Tapi you need to know what are the contents of psychoeducation that you need to give, ya. Yang paling mudah, ya, jangan lupa cerita dekat patient ialah satu, apakah penyakit yang dia ada, ya. Ini adalah depression. Okey. Kedua, apa rawatan yang you bagi? Ubat, ya. Bila kata bagi rawatan, kena juga cerita jangka masa berapa lama you akan guna rawatan ni, ya. Dan juga side effects of medication, ya. And also, apa yang kita selalu cerita dalam psychoeducation is the cause of illness, ya. And also your plans, ya. I'm going to start you on treatment. This medication is called sertraline. Kena ceritalah, ya. Tetapi awas kena gunakan bahasa-bahasa yang mudah difahami oleh pesakit kita, ya. Dan kena address patient punya concern, ya. Apa concern dia? Kena tanya. Ada apa-apa lagi yang perlu diperjelaskan ataupun nak tahu, ya. Sebab if patient has doubts about your treatment, they would not take the medication or will not follow your treatment regime. Okay. Yang kedua adalah counselling ataupun setengah-setengah paper mereka menggunakan istilah non-directive supportive therapy. ia juga sebenarnya merujuk kepada counselling, ya. Peer intervention, exercise, relaxation and also psycho-spiritual intervention. Menariknya, exercise has been found to be very effective as an adjunct treatment. Bukan kata treatment on its own, can be used as an adjunct treatment to treat MDD. Tetapi bukan sebarang exercise. At least 3 times a week, 45 minutes each time. Ya, so boleh prescribe dekat patient exercise ya. Exercise 3 kali seminggu, sekurang-kurangnya 40 minit. It has been found by numerous papers, numerous studies to be effective in treatment of depression. Yeah, it increases your cerebral perfusion, it increases your endorphins. Yeah, so ini is one of the things that you can advise your patients. Yeah, to help them dealing with their depression. Yeah, especially those who are not very keen for kita panggil only pharmacotherapy. Tapi sebenarnya untuk kita menjalankan rawatan kepada pesakit kita, ya, kita dah move away from just focusing on pharmacotherapy. Sekarang ni perawatan kita tak boleh tidak mesti integrate the full biopsychosocial spiritual approach. Ya. So kadang-kadang bila kita bercakap dengan patient, kita nampak inclination dia lebih kepada spiritual. Tapi you still kena emphasize the importance of medication. Tetapi mungkin you boleh address. Dan bila kita nampak dia punya inclination towards spiritual, kita kata okay, spiritual, these are the things that you can do. Dia pun rasa seronok sebab kita tak dismiss apa yang dia incline. Ya? Kalau kita tengok patient tu lebih pada psikoterapi. And dia punya tahap kemurungan tu adalah agak teruk dan kita rasa tak boleh just psychotherapy alone. Tak apa, dia kata okay, saya boleh bagi psikoterapi tetapi we feel that medication is also needed. Ya, jadi jangan dismiss, dapatkan patient punya feedback, ya, and you focus on what are the things that needed to be tailored to your patient. Okay? Alright, so next kita move kepada recommendation dalam aspek biopsychosocial intervention. Bila kita nak bagi recommendation yang boleh diguna pakai oleh semua, termasuk di primary care, the least thing that you can do at your level is to give psycho-education. So that's why it is a recommendation. Sebab tu kadang-kadang bila kita tengok CPG kan, ada list of intervention. But when they recommend, they probably recommend 1 or 2. Because when you recommend, it has to be one, it is the most established. Dan yang kedua, effective. Yang ketiga, it is practical to be delivered at every settings. Ya. So untuk recommendation bagi psychosocial intervention adalah psychoeducation should be offered early and continuously throughout the management of major depressive disorder. Very important. Ya, should educate your patients. Ya. What is the illness, what is the severity, how long should they be on treatment, what are the medication given, what are the medication side effects, and what are the things that they can do apart from taking medication. Always manage patient holistically. So this is the take-home messages for the psychosocial intervention. It will depend on the patient preference and attitude, therapist competence, therapeutic alliance, and also the availability of intervention. Okay, so itulah yang saya sebut tadi, psychoeducation. Mesti bagi. So dia datang dengan complete package. You see patient yang ada major depression, you diagnose this is depression, dia dah assess severity. You nak bagi ubat ke, you tak bagi ubat ke, kan? Kena juga bagi psychoeducation. Kadang-kadang kita ada jumpa pesakit dah berapa bulan ataupun berapa tahun on treatment, mereka tak begitu aware tentang penyakit mereka ataupun rawatan yang diberikan. Okay, we move on to the psychotherapy for MDD. So kalau kita lihat ke belakangan ini, intervention psychotherapy merupakan satu intervention yang sangat-sangat popular. Sangat popular. Bila kita lihat banyak juga, saya rasa sangat teruja juga ya, sebab sekarang ni kita ada peluang untuk belajar banyak jenis psikoterapi ya secara online, dan banyak juga rakan-rakan kita yang pergi kepada different types of psychotherapy training. Dulu-dulu mungkin when I first came to practice back in 2009 ya, masa mula-mula jadi psychiatrist ya, kita memang banyak focusing on pharmacotherapy ya, ubat ya. Tetapi kebelakangan ini ya, saya rasa 5-6 tahun kebelakangan ini, bila kita dah mula integrate psikoterapi dalam rawatan pesakit, kita lihat ya pesakit dapat recover dengan lebih cepat with both combination of pharmacotherapy plus psychotherapy rather than when you give pharmacotherapy alone ya. So ini yang kita tengok even in papers ya, mereka melihat bahawa when you give psychotherapy for patient, it improve their recovery, it reduces the psychological distress ya. And how does it works? One of the thing is that through the therapeutic relationship between the therapist and also the patient. Next we go into what are the types ya. Okay, sebelum kita pergi pada types ya, saya nak sebut juga di kat sini ya, sebab tadi bila kita lihat tentang psychosocial intervention ya, kita dah melihat kepada kriteria-kriteria yang boleh ya. What are the types of psychosocial intervention, itu satu kita tengok tadi. Siapa yang kita boleh bagi psychosocial intervention ya, depends on kita panggil tadi patient preference, availability of treatment dan sebagainya. Sama juga dalam psychotherapy ya, because you need someone who is competent, you need to see whether or not there is a certified practitioner when you offer psychotherapy ya. Dan kalau kita lihat kat sini, walaupun kita fokus on psychotherapy, psychoeducation is also an important element of treatment ya. And when you deliver certain types of psychotherapy, it has to be a very, kita panggil comprehensive therapy. Maksudnya must follow the manual. Kalau kita deliver CBT, it has to be fully CBT. Bukan saja sikit-sikit kan. Kadang-kadang if you're not able to do complete CBT ya, mungkin kita tak boleh panggil itu sebagai CBT. Mungkin kalau kita boleh ajar patient identify negative thoughts and challenge saja, tapi you tak buat the full CBT, then probably you can just put there identify ataupun educate patient on identification of negative thoughts and challenging the negative thoughts. Instead of you kata I did CBT for this patient ya. No doubt you did some element of psychotherapy, but to call this as CBT, it has to be fulfilling the true concept of CBT ya. And for every psychotherapy they have time limitation ya. Dia banyak ya, kalau nak buat psikoterapi ni kena tentukan bahawa orang yang nak terima, pesakit nak terima psikoterapi tu mesti psychologically inclined ya. Dia ada boleh establish boundaries ya, dan dia ada time limitation. Kena bagi tahu semua ya, bahawa mungkin kita akan melakukan berapa sesi, sesi ni akan berlangsung selama berapa lama. So these are the thing that you have to tell the patient when you want to conduct psychotherapy. Okay, and similarly these are the things that also has been touched when I talk about psychosocial intervention. What are the types of psychotherapy? Depends on preference, nature of depression and its complexity ya. Kalau patient banyak negative thoughts, mungkin you perlu integrate CPT. Kalau dia banyak dynamic punya influences, mungkin perlu buat psychodynamic ya. Kalau dia banyak kita panggil masalah tentang konflik kan. So kena tengok what are the types of patient punya issues tu ya. So itu yang kita kena tengok. Nak ajar problem solving, conflict resolution depends on the patient's punya needs ya. Therapeutic alliance, availability of trained therapists and also availability of therapy. So these are the things that you need to consider before delivering psychotherapy. Okay, right. So this is the CPG punya recommendation untuk acute phase of treatment ya, untuk psychotherapy in mild to moderate major depressive disorder ya. Ini adalah senarai psikoterapi that should be offered based, tu penting tu tengok tu, based on resource availability ya. Walaupun kita ada senaraikan 3, 4, 5 jenis psikoterapi, tetapi anda juga perlu lihat ya, kita tulis kat situ is not restricted and you can also use other form of psychotherapy ya. So kalau kita tengok ya, what are the types of psychotherapy that should be offered in mild to moderate MDD? Cognitive behavior therapy, interpersonal therapy, problem solving therapy, behavioral therapy, and also internet-based CBT. Banyak kalau kita punya patient ya, yang depression ni banyak golongan muda, they are quite tech savvy, boleh introduce kepada internet-based CBT. So they can do at their own time at home. So I think you can find this list through the internet. Yeah. So it's very practical. Okay. Alright. So in acute phase, yeah, sebab kalau kita lihat kepada depression ni, phase dia, fasa yang dia ada ialah acute phase and also maintenance phase. Tadi kita dah lihat kepada mild. Ya, kalau acute, mild, the first line of treatment is psychosocial and psychotherapy. Boleh with or without pharmacotherapy. Ya, so boleh kalau katakan untuk mild tu just psychosocial and psychotherapy sahaja. Tetapi kalau patient acute phase berada dalam kategori moderate to severe, the recommendation is combination of both pharmacotherapy and psychotherapy. Not pharmacotherapy alone ya, ingat ya. So untuk moderate to severe, the best is a combination of both pharmaco and psychotherapy. Okay. So with regards to psychosocial and psychotherapy interventions ya, these are the things that we can conclude. For mild to moderate psychotherapy, moderate to severe, combination of psychotherapy and pharmacotherapy, and for maintenance and continuation, you still maintain with both combination of psychotherapy and pharmacotherapy. Okay. Okay, ini adalah tajuk kita yang agak penting dan juga will take a big chunk of our presentation for today. We are going to talk about pharmacotherapy. Okay, so untuk farmakoterapi kita akan bahagikan mengikut fasa supaya senang untuk kita faham ya. So kalau kita tengok masa kita assess patient tadi, kita dah assess severity kan. Sebab apa penting assess severity? Sebab kita nak tengok apa type of treatment that we want to give kan. So kita dah tengok tadi, kalau mild boleh je bagi psychosocial psychotherapy ya, psychosocial intervention ataupun psychotherapy sahaja. Tetapi moderate to severe, you have to combine pharmaco and psychotherapy ya. Dan kalau kita lihat kat sini untuk pharmacotherapy, dia ada bahagikan juga ya kepada severity ya. Untuk acute phase, mild to moderate, moderate to severe, then we move on to continuation and maintenance phase before we move on to the treatment of patient with MDD with psychotic features. Okay. Ini saya rasa ramai terutama mereka yang buat master ataupun MRCP side ya, tahu ya, mungkin termimpi-mimpi Kufer curve. Kalau belajar tentang depression, belajar tentang phases of depression, ini tak boleh tidak kena tahu. So kan kita sebut tadi tentang acute, continuation and maintenance. Ini adalah kriteria ataupun apa kita panggil ini, yang kita guna pakai ya untuk kita kategorikan sebagai acute and also continuation and maintenance, Kufer curve ya. Dan menariknya Profesor Kufer masih lagi hidup dan dia merupakan kita punya external reviewer bagi CPG MDD second edition. Jadi kita bukan sahaja dapatkan permission daripada Profesor Kufer ni untuk menggunakan Kufer curve nak letak dalam kita punya buku CPG, tetapi kalau lihat dalam senarai external reviewer, he is one of our external reviewer. Ya. Okay, so bila kita sebut tentang acute, normally it refers to duration of less than 12 weeks. Kalau kita tengok RCT ya, kalau kita tengok banyak apa kita panggil kajian perawatan farmakoterapi, bila dia merujuk kepada acute phase, normally it is less than 12 weeks of treatment. This is the time frame. Ya. Beyond that, ya, ia adalah continuation and maintenance. Sebab tu biasanya kita akan optimize ubat kita kan, optimize within 6 to 12 weeks. Ada setengah paper 6 to 8 weeks, you nak optimize dulu. Then you proceed ya, beyond 12 weeks is for continuation and also maintenance phase. Okay, so these are the thing about what I love about Kupfer curve. Sebab apa? Dia membolehkan kita faham dan kita boleh ajar patient juga untuk faham tentang fasa-fasa dalam kemurungan. Fasa acute ya, dalam masa 12 minggu, kalau katalah kita start rawatan, pesakit menunjukkan respons ya, maka itu adalah satu respons, belum lagi remission ya, baru tunjuk dia ada tindak balas yang baik, response to treatment terhadap rawatan, belum capai kepada remission. Kalau patient belum sampai kepada remission dan dia dapat gejala penyakit tu semula, maka kita panggil sebagai relapse ya. Even kalau patient tu dah capai remission tetapi dapat gejala kemurungan yang berulang, masih dikategorikan sebagai relapse ya. Bila kita gunakan istilah recurrence, it is when patient has achieved recovery ya, barulah kita pakaikan istilah recurrence apabila patient mengalami gejala yang berulang ya. Jadi ini ya, terutama mereka yang ambil master, MRCP, this is one of the kita panggil diagram that you should know ya. Okay, so ini adalah algoritma untuk rawatan major depressive disorder. Saya suka sangat diagram ni kerana dia menjelaskan kita bagaimana untuk merawat pesakit dengan mudah ya. Kita tengok ni, kita dah faham dah ya. Contohnya ya, tadi kan kita dah bahagi dua kepada fasa acute dan also continuation and maintenance. Acute less than 12 weeks kan. Jadi apa aim kita dalam bila fasa acute, kita mesti nak achieve remission. Tetapi dalam fasa continuation, kita nak prevent relapse, recurrence and development of chronicity. Okay, so dalam fasa acute, mild to moderate kan, kita ulang balik supaya ingat sampai bila-bila, boleh guna pakai psychosocial intervention plus psychotherapy with or without pharmacotherapy ya. Untuk moderate to severe, must use the combination of pharmacotherapy, psychotherapy and also psychosocial intervention with or without ECT. ECT ni nanti kita akan cerita dengan lebih lanjut apa indication untuk ECT ya. Untuk yang kategori ketiga, psychotic features ya, you have to start pharmacotherapy. Tak jalan dek kalau psychotherapy sahaja untuk patient yang ada psychosis ya, sebab most of the time patient yang ada psychotic features are those with severe depression ya. And not only the combination ya, pharmacotherapy, psychosocial intervention, sometimes we also commence ECT for this type of patient. With regards to continuation, you still use the combination of other pharmaco plus psychosocial or psychotherapy plus psychosocial intervention depending on patient punya severity. Saya selalu juga merujuk kepada index episode. Kalau katalah index episode ni kita rujuk kepada episod pertama pesakit ni sakit ya. Kalau agak teruk sampai suicidal, I'll be very careful to wean off the antidepressant. Ya, okay. So in acute phase, ya, aim of pharmacotherapy is to achieve remission between 8 to 12 weeks. Ya, sebab tu kalau patient yang baru datang jumpa kita start rawatan kan, kita selalunya akan bagi TCA, temu janji every 1 week, every 2 weeks. Ya, average ya, saya rasa kebanyakan hospital yang ada resident psychiatrist mereka akan bagi 2 weeks ya. Tapi ada certain patient yang kita bagi weekly. Depends ya. Kadang-kadang mungkin those who are in health ataupun medical field yang perlu frequent MC, frequent review, kadang-kadang 1 week. Tetapi on average ya, most patient we give 2 weeks ya. Every 2 weekly, because this is the chance for you to optimize the treatment fast ya. So kalau katalah kita nak achieve remission between 8 to 12 weeks, at least 4 kali review dah sempat dah naikkan sertraline ataupun escitalopram to the good dose ya, to the therapeutic dose ya, to the optimal dose. So ini yang penting ya. Kita sekarang ni bukan apa ya, banyak orang tak sedar bahawa masa tu sangat penting. If you suffer from depression, to stay in that episode of depression, not being able to enjoy life ya, 1 minggu pun rasa lama kan. The quality of life is very poor. So you aim to optimize the medication fast ya. Okay, kalau nampak tak response kan, cepat-cepat ya, kita nak sama ada kita perlu switch ataupun kita combine. Sebab apa? Kita kena tengok the quality of life of our patients ya. So early improvement, siapa yang kita categoriskan sebagai early improvement are those who has shown more than 20 to 30% improvement from baseline depression scores at 2 to 4 weeks. Yeah? And kalau patient yang ada early improvement, it actually shows they have good response and remission at 6 to 12 weeks. Jadi maksudnya kat sini, kalau patient kita ada menunjukkan early improvement ya, dalam masa 2 hingga 4 minggu, the likelihood of them to achieve response and remission at 6 to 12 weeks is higher. Ya, okay. Okay. So, bila kita lihat tentang ni, apa tu tadi saya dah ceritakan, mild to moderate, the first line kita boleh consider untuk bagi psychosocial psychological intervention, tetapi in certain cases you can also start them on pharmacotherapy, on medication ya. Siapa ya, walaupun kita kata mild, tadi pun dalam kita punya algoritma pun kita kata psychosocial plus psychotherapy with or without pharmacotherapy kan. Tetapi untuk mild ataupun mild to moderate ni, kadang-kala kita boleh juga bagi ubat pharmacotherapy untuk cases-cases seperti mereka yang ada past history of moderate to severe depression. If patient prefer to be on medication, they say they don't want to be on psychotherapy. I prefer to take medication. Susahlah nak datang tiap-tiap minggu untuk CBT misalnya kan. So dia kata I prefer to be on medication. Okay, so you can consider to put them on medication right away. Yeah. Previous response to antidepressant. Maksudnya previously they had an episode which recover well with antidepressant. So you should consider. And though we do not put here, normally we will start on the medication that patient improves on. Kalau dulu dia makan sertraline dia okey, tak payahlah nak tukar ubat lain yang lebih hi-fi kan. Maksudnya dia responds well with sertraline ya. Lack of response to non-pharmacotherapy interventions ya. Okay, so always remember ya that macam saya sebut tadi, normally what we normally do is to give close monitoring and follow within 2 weeks duration. Okay. Okay. Untuk mereka yang moderate to severe, the mainstay of treatment is medication. Yeah. And various class of antidepressants are available. Kalau kita lihat ya, sekarang ini banyak sangat jenis-jenis antidepressant. Kita ada SSRI group, SNRI, kita ada NASA. Ya. SSRI ni banyak ya. Paling common yang ada juga dekat KK adalah seperti sertraline, kita ada fluvoxamine ya. Lain-lain yang ada setengahnya ada ya, tapi tak semua KK ada adalah fluoxetine ya, Prozac ya. Okey, escitalopram dahulunya cuma ada di hospital, tetapi baru-baru ini telah diletakkan bawah kategori B bersama-sama olanzapine antipsychotic ya, dah letak bawah list B. So it should be available in KK soon ya, escitalopram. Saya banyak guna kalau SSRI, escitalopram dan juga sertraline kerana dia list drug-drug interaction and also quite safe when you give for those with multiple comorbids ya. SNRI, kita ada duloxetine, kita ada venlafaxine, ya. NASA, kita ada mirtazapine, Remeron, ya. Very sedative, it helps to patient to sleep well, ya. Dan kita ada the older generation medication, ya. Tricyclic antidepressant, kita ada MAWI, monoamine oxidase inhibitor, kita ada ini kan kita ada yang apa kita panggil RIMA juga yang reversible seperti moclobemide, ya. Melatonergic agent seperti agomelantin, dan kita juga ada noradrenaline reuptake inhibitor dan juga multimodal antidepressant. Ini satu-satu kita akan cerita secara kita panggil apa ya, sepintas lalu kerana banyak ya, dan kita kena cover dalam masa 2 jam. Saya akan fokus kepada antidepressant yang banyak diguna pakai secara amnya di KK ya, ataupun di hospital district. Kerana kalau kita nak tengok kepada high end punya antidepressant, tak semua tempat ada, dan most of the psychiatrists are quite well versed with the usage and also the administration of this medication. Okay, alright. And also for moderate to severe MDD, not only that antidepressant can be given, there are other agents which have shown emerging evidence in special condition related to depression. Ya. So emerging evidence ni sekarang ni kita ada tentang ketamine dan juga esketamine. Ya. Dan saya akan ceritakan lebih lanjut dalam slide-slide berikutnya kerana berbeza ya usage of IV ketamine and also intranasal ketamine. Okay, right. So this is again the recommendation. I hope all of you remember because this is the thing that I keep on repeating. For patient with moderate to severe major depression disorder, combination of pharmacotherapy and psychotherapy should be offered. Okay, alright. So kalau kita lihat tadi pelbagai jenis antidepressant yang ada, kan? So how do you choose the type of antidepressant? So these are the list of things that you should consider when you want to start antidepressant. Pertama adalah efficacy and tolerability, patient profile and comorbidities. Sebab tu tadi saya sebut kalau patient yang banyak comorbids kan, selalunya kita akan pilih ubat yang least drug-drug interaction seperti sertraline dan juga escitalopram. Dia adalah SSRI. Concomitant medications and drug-drug interactions. Particularly ya, ramai macam saya tahu dekat KK banyak yang banyak ada adalah fluvoxamine. Tetapi luvox kena careful sebab dia act on, dia ada 2D6 enzymes punya action, dia banyak drug-drug interaction. It's not a clean drug. So kalau you punya pesakit ada banyak komorbid, please do not use fluvoxamine. Ya. Saya dekat hospital ada juga guna fluvoxamine, tetapi biasanya kita bagi untuk patients yang ada masalah tidur sebab dia quite sedating ya, dan patient yang tidak ada underlying gastritis. Sebab among the SSRI, kita tahu secara umumnya SSRI memang ada gastrointestinal side effects ya, but among the SSRI one of the high risk of gastritis is actually fluvoxamine. So kalau ada underlying gastritis tu, I would try not to use fluvoxamine. You also should consider the cost and availability. Tak bolehlah semua patient kita nak start on agomelantin ataupun voltioxetine misalnya, kerana ubat-ubatan ini adalah mahal ya, dan it should not be your first line. Walaupun nanti as we go through the CPG, dia kata tidak ada first line treatment. Ini adalah salah satu perbezaan antara CPG first edition dengan CPG second edition. So kalau mungkin master student kalau keluar soalan what are the differences between the first edition CPG of major depressive disorder and second edition, this is actually one of the difference di mana kita tidak ada letak first line treatment berbanding CPG first edition memang mengatakan bahawa first line treatment adalah SSRI. Okay, then the list thing that you should also consider as one of the factor when you want to start patient medication is patient's preference, ya. But I think patient preference ni sebab sekarang ni kita banyak menggunakan shared decision making. Apabila kita membuat apa-apa keputusan terutamanya melibatkan ubat, ya. Kita sekarang ni banyak menggunakan kaedah SDM, shared decision making. So kita kena bagi tahu dengan pesakit, ya, these are the types of medication available, these are the side effects, ya. What are the things that you are keen of, what are the things that you're not keen of, and then you capai mutual consensus, ya. That is the ideal practice lah, ya. Okay. Most second generation antidepressant, ya, sebab walaupun kita tak biasa guna as first generation or second generation, tak macam antipsychotic, ya, tetapi bila kita sebut second generation, normally we refer to the newer antidepressant such as SSRI, SNRI and the following listed lah. Bila kita kata first generation tu normally refer to TCA and also MAUI, ya. So macam mana pun, ya, bila kita nak start patient on medication, ya, you should start with the second generation. Walaupun kita tak guna as first line or second line, ya, but in this CPG, what we normally recommend is you start patient with the newer generations regardless of what type, ya. Depends on the patient profile, ya. Kenapa kita recommend bagi TCA and MAUI later? Bukan sebab dia tidak efektif, tetapi kerana side effects-nya lebih teruk, ya. Sebab tu kalau you baca paper-paper tentang antidepressant, ya, Cipriani apa dan sebagainya, kan, dia banyak mengatakan bahawa semua antidepressant ni adalah efektif, kan. Tetapi apa yang membezakan adalah side effects profile. Okay. Okay, ini kita dah sebut tadi, ya. Depends on efficacy, tolerability, patient profile, and you should consider the newer antidepressant and should leave the older generations as a later option, ya. Dan saya juga perlu ingatkan, ya, TCA ni antara side effects yang paling kita bimbang, ya, ialah cardiotoxic side effects. Kalau patient ni mempunyai risiko untuk overdose, please do not give them on TCA, amitriptyline, protoidin dan sebagainya, kerana it is highly cardiotoxic, ya. Please consider, ya, the other types of medication, ya. Okay. Okay, these are the list of medications which is available in the health ministry. Okay. Apart from antidepressant, there are also medication that we commonly use in treatment of depression as an adjunct therapy, yeah, such as benzodiazepine, non-benzodiazepine hypnotics, and also we have what we categorize as emerging pharmacotherapy intervention, which is the usage of psychostimulant. Psychostimulant ni apa? Adalah seperti Ritalin, ya, methylphenidate, ya, dan juga ketamine. Okay. Jadi, daripada tajuk farmakoterapi tadi, ya, kita lihat bahawa all antidepressants, ya, actually, ya, are effective, ya, more effective than placebo, of course, ya. Daripada segi based on this study, ya, ini adalah based on one network meta-analysis. This is actually referring to papers by Cipriani, ya. All antidepressant were more effective than placebo. Yang kedua, agomelantin, amitriptyline, escitalopram, mirtazapine, paroxetine, venlafaxine, and vortioxetine. They find it is more effective than other antidepressant, whereas fluoxetine, fluvoxamine, reboxetine, and trazodone were the least effective drugs. This is based on the paper by Cipriani. And for acceptability, ya, so acceptability ni adalah tolerability, ya. Dia kata agomelantin, citalopram, escitalopram, fluoxetine, sertraline, and vortioxetine were more tolerable than other antidepressants, ya. Okey, so kalau kita tengok list yang bawah tu banyaknya ubat-ubat lama TCA sebab tu dia macam saya sebut dia banyak side effects and less tolerable compared to newer generation antidepressant. Okay, so with regards to recommendation of pharmacotherapy, this is the recommendation. When patients suffer from moderate to severe major depressive disorder, you can choose any one of the second generation antidepressant. Bolehlah nak pilih apa. Nak bagi SSRI, nak bagi SNRI, noradrenergic and specific serotonin antidepressant ni NASA, metonic agonist, multimodal serotonin, ataupun kita nak guna noradrenaline dopamine reuptake inhibitor. So kalau peringkat klinik kesihatan yang ada adalah SSRI, boleh start patient on sertraline ke, nak start patient on fluvoxamine ke, kecuali yang banyak komorbid, patient ada gastritis jangan start fluvoxamine, startlah sertraline, okay. Okay, what about benzodiazepine? Kebanyakan patient yang ada depression, mereka juga mengalami masalah susah tidur. Jadi it's quite common for us to give benzodiazepine as an adjunct. And also not only they have difficulty in sleeping, a lot of our patients who suffer from depression also has some elements of anxiety and also agitation. So quite common for us to start benzodiazepine. Boleh ke tak kita bagi? Boleh. In fact, is one of the recommendation here. You can use as an adjunct. Jangan bagi benzodiazepine saja. Setengah orang patient tu tak boleh tidur, memang ada susah hati, bagi Xanax saja, alprazolam ataupun lorazepam. Jangan. Nanti sebab you tak treat dia punya root cause, patient will be dependent on the benzodiazepine. Lagi satu, biasanya apa yang kita lihat, when you give benzodiazepine during the early stage of starting antidepressant, it helps with the jitteriness. Sebab apa? Bila kita start patient on medication, even with SSRI, SNRI dan sebagainya, bila kita start medication, patient akan alami apa kita panggil sebagai serotonin surge. Tahap serotonin dalam otaknya akan meningkat dan dia akan menyebabkan pesakit ada rasa jittery, resah, rasa tak selesa, kan? Bila kita bagi concomitant benzodiazepine ketika early phase of treatment tu, dia membantu mengurangkan rasa jitteriness tu. And also helps with sleep. Okay? So kadang-kadang patient diingatkan, tak sesuai lah ubat ni. Sedangkan yang dia rasa tak selesa, dia rasa resah is because of the serotonin surge. Okay? And always remember not to give for long term. So in our recommendation, we would suggest to avoid prescribing for more than 2 to 4 weeks due to risk of dependency. Kalau katalah perlu bagi regular, biasanya kalau di Hoshas, apa yang biasa kami buat, mungkin bagi for 3 days. Kita bagi on night for 3 days, suruh pesakit ambil pada masa yang sama untuk 3 malam, kemudian bila perlu. Just enough for them to regulate their sleep, untuk atur balik tidur mereka, supaya mereka tidak terlalu bergantung dengan benzodiazepine. Banyak patient dia suka benzodiazepine sebab you feel the calming effect tu. Sedangkan macam antidepressant ni akan ambil masa seminggu, 2 minggu baru nampak kesan, kan? Jadi a lot of patient dia rasa alamak bila makan Xanax, lorazepam calm, dia suka. So itu yang kadang-kadang you will have problem if you teach patient to be on long term benzodiazepine. Okay? Okay. So kalau di KK, saya rasa yang paling common adalah alprazolam dan juga diazepam. Certain tempat, kalau ada visiting psychiatrist, contohnya kat KK Maran, KK Padang Luas, mereka juga ada lorazepam, mereka juga ada non-benzodiazepine hipnotik seperti zolpidem. So tak semua KK ada. Okay? Sebab tu kalau nak rujuk pesakit-pesakit untuk continuation of follow up, perlu tahu what types of medication available in their center. Itu penting ya. Sebab tu kita perlu integrate kita punya servis ni. So everybody knows what each facility offer. So that pesakit kita tak ada masalah. Okay. Jadi bila kita bercerita tentang non-benzodiazepine hypnotics, ia adalah merujuk kepada a group of selective GABA. Gamma aminobutyric acid agonist tu adalah GABA. Dulu masa kita belajar medical, masa belajar medicine, basic science kan, kita belajar tentang inhibitory, excitatory kan, apa kita panggil tu, semua ni lah kan. Jadi GABA ni inhibitory kan, punya ada inhibitory punya mechanism. Okay, so untuk ubatan jenis non-benzodiazepine yang ada di pasaran kita di Malaysia adalah zolpidem ataupun namanya adalah Stilnox ya, Stilnox. Kita tidak ada esopiclone ya. It is useful for short-term treatment of sleep disturbance in patient and can be used as adjunctive therapy with antidepressant. Sama macam benzodiazepine, you can use it as an adjunctive therapy to help patient sleep. And one of the advantage of giving non-benzodiazepine hypnotics is the risk of dependence is actually lower than when you give patient benzodiazepine group of hypnotics. Okay? Okay. Boleh lagi ke ni? Dah panjang dah ni. Ya? Okay. Sikit lagi ya. Dah mengah juga dah cakap-cakap ni. Okay. Harap-harap boleh terima lagi ya. Kita habis pukul 4 insya-Allah. Sekarang 3:30, ada setengah jam lagi nak habiskan, nak speed ya. Okey, kita pergi kepada psikostimulan. Psikostimulan ni Ritalin ya, methylphenidate. Selalunya kita guna untuk siapa? Kita guna untuk pesakit-pesakit yang mempunyai ADHD. Okey. So ada juga praktis di mana mereka bagi psikostimulan Ritalin ini kepada pesakit yang mempunyai kemurungan. Ini sebab tu kita review juga tentang effectiveness of psikostimulan, and this is what we found ya. Ini based on Cochrane database systematic review. Okay, bila kita review paper ya, antara paper yang paling established di mana dia ada collection of high quality papers adalah Cochrane. Sebab tu banyak kalau tengok bahagian rujukan tu, kita banyak merujuk kepada Cochrane database systematic review ya. Dan kebanyakan paper yang dikumpulkan dalam Cochrane database systematic review ni, setiap satu paper dia terdiri daripada good quality primary papers. Itu yang pentingnya. Jadi kalau kita quote Cochrane ni, kita akan rasa macam okey, dia ada good evidence base ya. Cerita sikit ya. Okey, kenapa kita lebih banyak gunakan Cochrane ya. So no difference bila kita guna psikostimulan in reducing depressive symptom when used as adjunctive treatment to antidepressant compared with placebo. So dia kata kalau kita bagi psikostimulan kepada patient yang ada depression, sama je ya. Sama ada kita bagi on top with antidepressant ataupun kita compare dengan placebo, sama je. There is no difference. However, dia kata more effective in terms of response. Compared to, this is based on one paper by McIntyre. Dia kata adalah ya, risk, dia kata bukan risk, kata in terms of response dia ada improvement compared to placebo. Tetapi dalam paper ni, sebab tu kita tanda ya, ada risk of bias ya. Generally we do not recommend usage of psychostimulant. Itu je lah yang mudahnya ya. So ini yang kita nak simpulkan. With regards to usage of psychostimulant, there is insufficient evidence to suggest the use of psychostimulant. Sebab Cochrane kata no difference dengan placebo. Tetapi paper by McIntyre kata adalah sedikit improvement compared to placebo. But for that paper there is risk of bias. Jadi kita kena take with a pinch of salt. Okay. What about ketamine? Ketamine Saya rasa dekat Pahang kita memang tak ada ya bagi intravenous ketamine. Saya difahamkan it is available in university setting macam HUKM dia ada bagi ketamine. Dan penggunaan IV ketamine ni biasanya kita reserve kepada acute phase for patient with high suicidality. Biasanya ya, sebab kita nak cepat patient baik, tetapi perlu ingat ya, bila kita bagi ketamine, dia punya efek tu tidak berpanjangan. Patient improve but the effect is not sustainable. Sebab tu kalau kita tengok dekat sini dia kata dia when you use IV ketamine ada significant greater improvement both response and remission rate compared with placebo within 24 hours. 72 hours and 1 week, but not at 2 weeks of administration. So, maksudnya di sini, for short term, dia ada great improvement. But the effect or the improvement is not sustainable beyond 2 weeks of administration. Effect dia cepat dan tidak berpanjangan. Sebab tu kalau untuk IV ketamine, mereka selalu guna untuk acute phase dan juga it's not alone bukan on its own. It has to be along with other types of antidepressant Dan the side effect of IV ketamine can be categorized into common, less common and major groups So these are the list of side effects So the common one lah yang biasanya kita tengok lah anxiety, agitation, euphoria, boleh dapat juga delusion or unusual thought, panic or empathy. Dia banyak induce apa kita panggil anxiety type of symptoms or even panic Less common one, feeling of detachment emotional blunting psychosis. Sebab tak kita tahu kan ketamine ni they use for kita panggil sedative agent untuk anesthesia kan kita bagi ketamine. Kalau siapa yang biasa kerja dekat ED, sometimes dia bagi ketamine ataupun propofol juga untuk patient untuk apa kita panggil manual reduction tu So ia memang well known to have some sort of psychotic punya experience based on dia punya glutamate punya receptor punya effect So, major side effect include neurological side effect seperti cystitis, hepatic side effect, craving or dependence, and also cognitive changes. So, kalau kita ni at the moment we do not provide the services of giving IV ketamine. Okay, so it can be considered for short term in acute phase for patient with moderate to severe major depressive disorder. From what I heard, in HUKM normally they reserve for patient who is acutely suicidal Okay. Kita nak move on kita nak move on kepada continuation and maintenance phase. Berapa lamakah should patient be on medication? Kadang patient tanya, berapa lamakah saya patut ambil ubat ni? Saya dah sihat dah doktor. Berapa lamakah patut saya sambung makan ubat? So jawapannya ialah between 6 to 9 months after remission. Okay, so keyword dekat sini after remission, bukan after starting treatment. Kena careful Kita tahu acute phase tadi less than 12 weeks kan, dalam masa acute tu kita try optimize patient. Kalau dalam masa 12 minggu tu patient improve, capai remission, then you start with dia punya continuation and maintenance phase. So when you should consider to stop medication, usually at the time between 6 to 9 months after patient achieve remission. And you cannot, kena sebut cannot ni, stop medication abruptly. Kena gradual and very slow titration of antidepressant. So even after 6 to 9 months tu, after remission, when you want to stop the medication for patient, you should go slow. And always ask patient to come and you review the symptoms. Okay? Consider maintenance treatment for more than 2 years if there is high relapse and recurrence. So untuk pesakit-pesakit yang mempunyai risiko yang tinggi untuk relapse ataupun recurrence, then you should consider duration of more than 2 years. Okay, so Siapakah yang mempunyai risiko of relapse and recurrence? Those yang ada frequent or recurrent episode, those with severe episode, severe psychosis, severe impairment, suicidality, those with chronic episode, when there is presence of comorbid psychiatric or other medical condition, when there is presence of residual symptoms, and also difficult to treat episode. Ini yang saya cakap tadi Kalau index episode yang awal-awal yang pertama tu very severe, very difficult to treat, I would be very careful when I want to reduce or consider discontinuation of treatment. So itu yang kadang-kadang kita memang akan ambil masa yang lama untuk decide whether you need to off or not. Sometimes patient kita maintain dia on the lowest effective dose. Bukanlah kata totally off. Okay. So, kan kita tadi bila kita tengok tentang segmen farmakoterapi kan, menyarankan untuk menggunakan second generation antidepressants before you consider the older ones kan. And when we talk about second generation, with regards to continuation and maintenance phase, it is more effective than placebo in preventing relapse over 8 months and preventing recurrence over 16 months. And there is no significant, and as to no significant difference in adverse events between antidepressant and placebo during the continuation maintenance phase treatment of NDD. Okay, so ini kena ulang balik supaya semua ingat berapa lama you should continue medication for patient is antidepressant 6 to 9 months after remission or at least 2 years if there is high risk of relapse and recurrent. Okay, ini kena ingat Okay, so bila kita sebut tentang continuation and maintenance kan, saya dah sebut tadi 6 to 9 months ataupun more than 2 years kalau patient ada high risk of relapse, then you titrate slowly before you discontinue the medication. In certain cases, you still need to continue with the lowest effective dose kan. But among the patient yang discontinue medication, apakah gejala-gejala yang biasanya kita lihat? This is what we call discontinuation syndrome or discontinuation symptoms. Common discontinuation symptom in SSRI similar to like flu, flu-like symptom, insomnia, nausea, imbalance, sensory disturbance, and hyperarousal. So that's why you should do it slowly. It could be misunderstood as symptoms of relapse, and more closely associated with antidepressants of shorter half-life. So you should do it gradually unless there is urgency. When we see urgency, maksudnya ada intolerable side effects. Side effects yang teruk, patient develop hypersensitivity misalnya, you kena probably just off the medication because there is urgency. Okay. Alright. What about patient with major depression with psychotic features ataupun MDD with psychosis? Previously, there are two different school of thoughts. Ada yang kata because depression is the main illness and psychotic arise based on the depression, you should focus on treating depression. But apa yang kita lihat based on our review is that the combination of both antidepressant and antipsychotic is actually much better. Has better outcome than when you treat with antidepressant alone. So sekarang ni what we recommend is that when patient presented to you dengan major depression with psychotic features, you should start them with both antidepressant and also antipsychotic. Kenapa zaman dulu dia takut nak start antipsychotic? Sebab kita tahu antipsychotic it blocks the dopamine receptor. Kan? So kalau untuk depression, they may already have low dopamine. So dia kata may worsen or ada antagonistic effect between antidepressant and also antipsychotic. antipsykotik kan. So antipsykotik yang newer generation bukan je dopamin, dia block juga serotonin. Sedangkan antidepresan ni kita punya tujuan kita naikkan adalah ataupun kita start adalah untuk naikkan serotonin kan. Bagi pula antipsykotik yang block the serotonin receptor kan. So that was the previous argumentation lah. But based on systematic review, based on studies, it has been found that both combination of antidepressant and antipsychotic should be considered in cases of MDD with psychotic features. Okay. What about next step treatment or treatment resistant depression? Bila patient tidak respon pada ubat kita, kenapa? Kita kena fikir sama ada diagnosis kita betul ataupun tidak. Adakah ini psychotic depression? Ya, kita treat sebab dia datang dengan psikosis saja. Kita treat the patient with antipsychotic sebab itu yang sangat prominent. Sedangkan probably patient tu ada depression. Bila kita dapat cerita baru tahu it is preceded by mood. Ya, tapi at the height of the illness, dia present dengan kita dengan florid psychotic symptom that we probably misdiagnose as psychotic disorder. Adakah disebabkan oleh organic condition? Rupanya patient ada hypothyroid ya. Sebab tu bagilah antidepresan macam-macam pun tak jalan ya. Bila start dengan dengan ubat thyroid baru dia okey ya. Comorbid psychiatric disorder. Terutamanya a bit challenging sekarang, kita banyak ada patient with personality disorder. So patient with personality disorder with depression kan sometimes a bit difficult to treat compared to those without underlying personality issues ya. Adverse psychosocial factor apa maksudnya? Maksudnya dia ada stresor yang berpanjangan, poor social support, financial difficulties kan. Benda ni tidak diaddress ya. And the stressor is always there. Maka proses recovery dia adalah sukar ya. And ini paling penting ya. Sebenarnya kalau patient tu tak improve, the first thing that you should ask is whether or not patient is taking medication, compliance ya. Kita duduklah naikkan ubat kan, tak jalan juga dah naik tinggi, ataupun lepas ni tukar pula ubat mahal, rupa-rupanya pesakit tak makan. So buat pill count, get the history from the family to see or not with patient has been adherence to our medication. Okay, so this is our strategies bila kita nak rawat patient who is poor response ataupun treatment resistance ya. You pertama kali kena optimize ubat. Kalau tak boleh juga ya, lepas optimize selalunya kita bagi masa to reach the standard maximum dose 6 to 12 weeks ya. Kita switch to other class of antidepressant ya. Switch ya, change to other antidepressant. Sometimes in certain practice they can also switch within the same class ya. Tetapi what is more common is they switch to a different class. You can also consider combination and finally augmentation ya. Okay. Oh, saya tengok dah 3:47. Okay, saya akan go a bit fast after this ya. Optimization of antidepressant should be considered in patient who show inadequate response. If fails, refer to psychiatrist for switching, combination and augmentation option. Okay, so when we talk about treatment-resistant depression, yeah, it's defined as failure to respond to 2 or more antidepressant. Adequate dose, adequate duration, yeah, given sequentially. When you talk about adequate duration, at least 4 weeks. Adequate dose comparable to 150 mg of imipramine. Itu boleh rujuk dekat Moxley ya kalau nak tengok the dose equivalent ya. Tapi the use of this criteria has been debated ya, because the definition does not take into account adjunctive strategies and differentiate partial responder with non-responder. So kalau katalah masa student MRCP trainee, kalau nak tengok tentang treatment resistant depression punya criteria, you can probably look into taste and rush punya classification. Ini quite common to be used. Okay, so this is the strategies yang kita sebut tadi. Sama ada you switch, you combine, augmentation. Ataupun kalau tak boleh juga, you should also consider concurrent psychotherapy or add-on physical treatment ya. Okey, kalau kita sebut tentang augmentation ya, dia ada jenis-jenis ubat. Bila kata combine, Bila sebut combine, dia beza dengan augment. Combine adalah when you campurkan, gunakan dua ubat daripada kategori yang sama. Antidepresan campur antidepresan, maka dia adalah combination. Kalau you gunakan antidepresan campur pula antipsychotic ataupun campur mood stabilizer, itu adalah dinamakan sebagai augmentation. Jadi antara ubat yang biasa kita augment untuk treatment resistant ataupun non-responder is antipsychotic. Normally antipsychotic yang ada mood stabilizing punya propensities, ya. Dia ada apa kita panggil mood improvement punya qualities, ya. Lithium, ya. Anti-epileptic agent, and the most recent one is esketamine. Ini baru kita berikan secara intranasal. So this is very new, and it has been in the blue book. Cuma I think in KKM kita tak gunakan secara meluas lagi. Ya, so this is the treatment apa kita panggil strategies which I have been mentioning repeatedly. You switch, you combine, or you augment. Ya. Okay, so I skip this because we need to go through a lot more after this. I'm going to talk about physical treatment. Bila kita bercakap tentang physical treatment, dia ada 3 jenis physical treatment yang kita review dalam CPG kita, iaitu ECT, RTMS, Repetitive Transmagnetic Stimulation, dan juga TDCS, Transcranial Direct Current Stimulation. Ya. Okey, tetapi terus saya nak pendekkan cerita, yang paling efektif adalah ECT. So tak perlu nak beli RTMS ataupun TDCS. Kalau ada ECT, it's very good already because this is the most established and most efficacious in treating depression. And the following are the list of patients that you do ECT. Ya. People who are at risk of harming self, ya, and also harming others, ya, kita buat ECT. Acute suicidal ideation, ada very severe impairment, psychotic features, catatonic features, refusal to eat, unable to tolerate medication, ya. So these are among the things that you would consider to do ECT. Okay, so ECT is considered when there is life-threatening condition, moderate to severe symptom, and also treatment-resistant depression. Okay, so as I showed just now, when you talk about physical treatment, ya, ECT lah, tak payah dah nak tengok yang lain. Ya. So I just skip about RTMS, TDCS. I've already given the conclusion, ya, which is ECT is the most established physical treatment, more effective than RTMS and also TDCS. Ya. Patient with history of treatment resistant, ya, particularly had poorer response to TDCS. Okay, so ini tajuk yang banyak orang kata tidak penting, tetapi banyak pesakit bertanya tentang complementary and alternative medicine and also other treatment. So I can just go briefly on what are the recommendation. Ya. So ada satu herbal ni, nama dia St. John's wort. It is found to be effective, tetapi it is not being recommended kerana apa? Kerana kita tidak tahu what is the appropriate dose. We do not know the drug interactions. So we cannot recommend something which is not really established. In terms of efficacy, yes. Banyak study kata it is efficacious. Tetapi what is the dose? Sebab tak ada RCTs yang proper. Ya? Sebab tu it is not being recommended because of issues of appropriate dose, variation in nature of preparation, and also you might have serious drug interactions. Ya? Sebab tu kalau patient dah ambil antidepressant, dia ambil pula St. John's wort, boleh dapat serotonin syndrome. Ya? So be careful about St. John's wort. What about acupuncture, omega-3, folate? So these 3, there is not enough evidence to support the effectiveness and safety. Okay? So complementary and alternative medicine are yet to be established. So what you can recommend for a patient, continue to take antidepressant. Yeah? There is limited evidence on other treatments in MDD. Okay, we're going to move to special population. Ada 3 special population kita nak cover. Perinatal population, CMI, chronic medical illness, geriatric. Okay, so we go first to the perinatal population. As you know, perinatal population ni ada higher risk untuk dapat depression, ya. So dia kata prevalence dia about around 1 in 10, ya. Ramai tu, 1 daripada 10. Okay, so bila nak buat screening? Tadi kalau kita tengok for general population untuk MDD, kita kata boleh guna Woolley questions, ya, untuk screen. Untuk perinatal population, boleh juga guna Woolley ataupun boleh guna PHQ. Ya, boleh guna, ya, PHQ2, ya, 2 question, ya. Tetapi untuk perinatal population sedikit berbeza di mana kita suggest untuk 2 stage screening. Kalau katalah patient answer yes to any of Woolley ataupun PHQ, kita suggest untuk mereka proceed with EPDS, ya. Ya. Sebab tu untuk perinatal screening kita panggil 2 stage screening. First stage you can use PHQ2 or Woolley. Second stage is using EPDS or PHQ9. And if it is positive, then you proceed with psychiatric assessment. Okay, when to screen? Antenatal within 4 weeks of booking, postnatal 6 to 12 weeks after birth. Ya, so kalau antenatal lepas kata within 4 weeks of booking tu, bila nak repeat? At least once in 3rd trimester or any time in pregnancy if clinically indicated. Untuk postnatal kan selalunya after 6 weeks memang ada visit kan postnatally, at least once in the first postnatal year at any time if it is clinically indicated. I hope it's clear. It's a bit different. Adalah 2 stage screening and these are the time frame when you should screen. Okay. Okay. So kita skip sikit yang ini about antidepressant, ya. Bila kita nak start medication kepada pesakit yang pregnant, ya, kita kena tengok dia punya risk berbanding benefit, ya, risk versus benefit, ya. So due to small absolute risk in most cases and uncertainty of whether effects due to medication, depression itself or other confounding factors. Sebab tu kita kena bukan saja educate patient, kena document juga that we have educate the patient on the risk and benefit of starting medication. It's not that medication is not safe, tetapi itulah yang kita sebut tadi. When there is something that happened to the baby or to the mother, we cannot be sure whether it is effect of medication, depression itself or other confounding factors. Yeah. Okay, so when you want to prescribe medication in perinatal, these are the things that should take into consideration. Yeah. Kalau patient memang ada psychiatric history and indication for antidepressant medication, ada current psychiatric symptom, previous attempts of tapering medication, availability of alternative treatment options such as psychotherapy and the presence of social support. So these should be taken into account before you start patient on medication. Yeah. So we move into the recommendation. So for perinatal population, mild to moderate psychotherapy, interpersonal psychotherapy, CBT should be considered as initial treatment. Psychosocial intervention, peer support, non-directive counseling is also considered. But for severe perinatal depression, pharmacotherapy intervention should be considered. And when you consider medication, pharmacotherapy, SSRI is the preferred choice. Ya, so kalau kena start patient yang mengandung ataupun lepas bersalin medication, kita recommend to use SSRI. Once medication has become effective, psychotherapy may be recommended as an adjunct. This is only reserved for severe depression. Okay. Okay, this is actually the conclusion of what I have mentioned. Yeah. Okay, we move to the elderly. Depression in elderly is quite high, and based on the study, it shows that the prevalence varies between the areas that is being surveyed. Kalau dekat Klang Valley, about 20.9%, and is higher actually in rural area among the Malay elderly. diagnose still using the ICD or DSM criteria, but remember that in diagnosing MDD in elderly, symptom can overlap with major neurocognitive disorder or neurological disorder. Kadang-kadang dia datang dengan dementia kan. Jadi itu yang kita kena tengok. Is this purely mood disorder or could this be a manifestation of dementia itself? It presented with more agitation, banyak somatic symptom, GI complaint, hypochondriasis than younger adult. So this is what makes it a bit different daripada the adult population. Ya. Dia banyak complain. Ya. Kalau pergi KK, sakit kepala, sakit perut, sakit belakang, ya. Non-specific somatic complaints. Ya. So when you come across elderly who comes to your clinic, who comes to your center, the following symptom may suggest the presence of MDD. Kalau dia ada psychomotor retardation, poor concentration, constipation, poor perceived health, prominent anxiety symptoms, having cognitive deficit, and the thing that I always emphasize when I talk about elderly, prominent somatic symptoms. Explore more on the mood component when you come across this type of patients at your setting. Okay? Assessment sama je macam kita assess general adults, but need to take into account, you need to rule out organicity, yeah. Jadi appropriate lab investigation is done when necessary. Okay, so again, there is no evidence on targeted screening. However, healthcare provider may screen them for depression if they present with symptom mentioned above. Boleh guna GDS, Geriatric Depression Scale ataupun Woolley question. Ya. So untuk elderly, psychotherapy should be offered. Recommendation kalau nak start antidepressant, kena start with caution and kena lihat juga tolerability and presence of comorbidity. Most of the time kita akan start patient dengan medication yang ada least drug-drug interaction sebab banyak elderly ni dia banyak comorbid. Okay, what about ECT? ECT may be offered in elderly with major depressive disorder after assessment of possible comorbid. Sebenarnya in clinical practice jarang juga sebenarnya kita bagi ECT in elderly, but you can go based on case to case basis ya. Okay, so these are the key messages. We move on to the last group which is under special population before we move on to the last part of monitoring and follow up ya. Last ni ya, sebelum ni. Untuk special population punya group ya. Ini adalah chronic medical illness. Kerana apa? Kerana depression and chronic medical illness selalu bergabung ya, common. It has bidirectional relationship. You dapat depression, boleh worsen you punya chronic medical illness ataupun chronic medical illness menyebabkan you menjadi depressed ya. Adverse health risk behavior, psychobiological changes in depression increase the risk of chronic medical illness ya. Ini yang kita sebut tadi and vice versa. Okay, so dalam CPG, these are the types of common chronic medical illness where we would recommend for the healthcare providers to screen. Those with diabetic, those with coronary heart disease, cancer patient, end-stage kidney problem, and also post-stroke. Yeah? Common for patient to develop post-stroke depression. Yeah? And most of the time, as we mentioned before, when it occurs, especially for patient with chronic medical illness, there would be some overlapping of somatic symptoms. Yeah? For example, you may have difficulty to differentiate whether the feeling of fatigue, appetite changes, reduced appetite, or sleep disturbance, is it because of depression or because of the medical illness? So there can be a overlap of somatic symptoms. There is an agreement of 5 non-somatic DSM-4 criteria. Ini the previous DSM, dia kata dia ada consensus that for this type of patient, they may have the presence of low mood, loss of interest, guilt, worthlessness, impaired concentration, indecisiveness, and suicidal ideation. Yeah? So in diagnosing MDD in patient with chronic medical illness, emphasis must be given to the non-somatic criteria. Yeah? Sebab kadang-kadang kalau kita nak fokus on somatic criteria, kita tak tahu ini simptom penyakit dia ke, penyakit yang fizikal ataupun sebab depression. Jadi kita boleh fokus kepada non-somatic criteria macam yang kita sebut tadi. Okay. So untuk chronic medical illness, screening should be done to patient with chronic medical illness with related functional impairment. Okay. Psychosocial intervention and psychotherapy should be considered. If pharmacotherapy is required, consider antidepressant with the least drug-drug interaction. So kalau kita perasan untuk tiga special population ni, perinatal, elderly and CMI, the choice of antidepressant are the antidepressant with the least drug-drug interaction. The least apa kita panggil dia punya apa dipanggil ialah kalau sebab apa drug interaction lah kan, sebab banyak patient ni dia ada comorbids and also we want to minimize the side effects. Okay, so this is the fourth slide before I conclude my presentation. Lepas ni ada 4 sahaja slide sebelum kita berjaya mencapai 100 slide semua sekali. Kita akan bercerita mengenai ongoing monitoring during treatment of MDD. Patient kita dah start on antidepressant, apa yang patut kita monitor? Okay, so kalau kita tengok dia bergantung kepada jenis antidepressant yang kita beri kepada pesakit. Untuk patient yang kita start on Masa, MAWI, TCA, kita should monitor for body mass index and waist circumference. Sebab apa? Ubat-ubat ni kalau tengok ubat-ubat yang sedatif ni, dia banyak action on histaminergic receptor. Dia menyebabkan selera makan kita pun naik So berat badan berpotensi naik Jadi untuk patient yang kita bagi Nasa, TCA, MAWI, kena ada monitoring of BMI and waist circumference at baseline and 6 monthly. Untuk patient yang ada venlafaxine, TCA and MAWI, ni sebabkan oleh dia punya action on noradrenergic punya receptor. Dia boleh ada elevation of blood pressure. So, kita kena monitor patient punya blood pressure at baseline, significant dose increase, 3 to 6 monthly after stabilization. Tetapi ada komen juga kat situ, closer monitoring of MAWI in first week until tolerance occur. Tapi saya rasa kita tak perlu risau Kita memang tak ada MAWI, kita tak bagi dekat pesakit kita sekarang ni. Untuk pesakit yang ada TCA, tadi ingat kan saya cakap kalau patient ni ada risk of overdose ke apa, jangan bagi TCA sebab dia highly cardiotoxic. Sebab tu kalau patient yang ada TCA, you kena monitor untuk ECG for QT prolongation. Walau bagaimanapun untuk patient yang kita nak start on SSRI dengan SNRI, is also recommended to do at baseline untuk ECG. Tapi kalau kita tengok untuk TCA, dia punya monitoring tu bukan saja kat baseline. Baseline after initial dose titration and any change of dose. Lagi apa kita panggil komprehensif dia punya monitoring. So kalau kita tengok dekat situ kat comments tu, kita boleh fokus kepada siapa yang kita perlu fokus kepada the group of targeted population. Untuk TCA, individual over 45 years of age with cardiovascular disorder. Kalau untuk SNRI, SSRI for individual with cardiovascular risk, which means it's not for everyone. Sebab tu kadang-kadang ada kata, tak pernah buat ECG pun patient saya. Kata, kalau you nak buat, you kena tengok kepada patient punya CV risk. Ada tak CV risk, cardiovascular risk? Kalau ada, maka you perlu buat at baseline. Okay, what about liver function? Untuk liver function, satu ubat ni kena buat, iaitu agomelantin. Agomelantin ni melatonergic punya medication. Kena monitor very closely, baseline 3 months, bukan 3 months, weeks. 3 weeks, 6 weeks, 12 weeks and 24 weeks. Berapa tu? Minggu ketiga, minggu ke-6, 3 bulan dan 6 bulan. Sebab saya selalu lebih senang ingat macam ni. 3 minggu, 6 minggu, 3 bulan, 6 bulan. Sebab kadang-kadang nak ingat 3, 6, 12, 24 ni agak mencabar kan. So how do I remember? is you do at baseline, you do at 3 and 6 weeks, you do at 6 and you do at 3 and 6 months. 3-6, ingat macam tu. After initiation of dosage, after dosage increment, or when clinically indicated. And you should discontinue the usage of agomelantin if the level of transaminase exceed 3 times upper limit of normal. Okay. The next one is electrolytes. Siapa yang kita nak kena monitor electrolytes? The patient yang kita bagi SSRI, mirtazapine, SSNRI dan juga TCA. Bila nak monitor? At baseline and at 1 month after treatment initiation or clinically indicated. So, kalau tengok dekat sini, nak monitor bila kita nak start medication. Sebab tu saya kata tadi kan, awal-awal patient yang kita nak start medication buat CRP. Then you can repeat after 1 month. Subsequently, cuma apabila it is clinically indicated. But there is a difference if you are giving it to elderly. Kerana untuk elderly, dia berisiko untuk develop, more likely to develop hyponatremia, especially in elderly. Ataupun mereka yang memang ada existing hyponatremia. So, the frequency of monitoring should be more frequent compared to what has been put in the table. Need to monitor together with urine, serum osmolality, since SSRI can induce hypovolemic hyponatremia. So, kadang-kadang bila patient ada hyponatremia dengan SSRI, so we change to other class of antidepressant like Masa. This is what we can do. Okay, so ini adalah other types of monitoring for patient yang on mirtazapine dan mianserin. They recommend to do full blood count if clinically indicated to detect blood dyscrasia. So this is not a routine monitoring, only if clinically indicated. And also bone mineral density for patient on SSRI for clinically indicated high risk group of patient with osteoporosis. So nanti saya akan letakkan senarai pesakit yang mempunyai risiko tinggi untuk dapat osteoporosis. Sebab you should not do it as a routine monitoring. Only for this type of patient. Untuk kita buat bone mineral density, advanced age, oriental, Caucasian, female, premature, menopausal, lebih kurang pada 45 tahun telah menopause, you should consider family history of osteoporotic fracture first degree, personal history of fracture, low calcium, sedentary lifestyle, cigarette smoking, when they have excessive alcohol intake, excessive caffeine intake, low body weight, when they have estrogen deficiency, impaired vision, and recurrent fall. So, where do we get the list? This is actually from the CPG management of osteoporosis. So, bukan untuk semua, cuma untuk those with high risk. You send for bone mineral density. So, this is the indication. Okay, so the take-home message is monitoring and follow-up is an important aspect in management of MDD, especially in elderly and in high-risk group as mentioned above. So it is not meant for everyone. Some of the group is when it is clinically indicated. Some you do when they are in the high-risk groups. Okay, so that's the end of our presentation for today. So let me see the time. Actually, I have exceeded 12 minutes. I'm really sorry because there's a very comprehensive, what do you call that, review on the CPG of MDD. So I apologize if I've taken more time than what is being allocated. Tetapi saya mengharapkan sedikit sebanyak perkongsian saya pada hari ini mendapat manfaat. So seperti yang saya janjikan tadi, saya akan buat sedikit kesimpulan sekurang-kurangnya kalau dalam masa 2 jam ni terlampau banyak untuk digest. Ingat apa yang saya nak cakap ini dalam 2 minit terakhir ni. Pertama, bila kita buat screening untuk major depressive disorder, only for high risk group. Dia tidak cost effective untuk you screen semua orang, ya, bukan universal screening. High risk group, people with chronic medical illness, perinatal population misalnya, ya, elderly population especially with somatic complaints. These are the types of group that you should consider screening. When you do assessment, not only assess the diagnosis, ya, tetapi also assess severity. Kenapa perlu assess severity? Sebab kita nak tentukan level ataupun mode of treatment. Kalau mild, kita boleh bagi psikoterapi, ya, ataupun psychosocial intervention without pharmacotherapy, kecuali kepada beberapa grup yang kita sebutkan tadi, ya. Untuk moderate to severe, tak boleh tidak kena start pharmacotherapy plus psychotherapy. Combination of both pharmacotherapy dan psychotherapy untuk moderate to severe depression adalah yang terbaik, ya. Okay, so when you talk about psychotherapy intervention, psychosocial intervention, ya, banyak jenis kita ada, tetapi depends on patient preference, bukan je patient preference, tetapi availability of service yang you ada, ya. Untuk pharmacotherapy, semua second generation antidepressant adalah efektif, ya. Kita tidak ada first line dah sekarang berbanding dengan CPG yang lama. So, gunakan apa-apa jenis second generation antidepressant yang ada, SSRI, SNRI, Masa, boleh, ya. Dan kalau nak guna TCA ataupun MAWI, it should be later, much later, because of the side effects of medication. It's not because of efficacy, but because of side effects of medication. Yeah. So, physical treatment among the three, yang paling efektif adalah ECT. Ya, kalau orang tanya untuk major depression, apa paling bagus untuk physical treatment? Adalah ECT. Ya. RTMS, TDCS didapati kurang berkesan untuk merawat major depressive disorder. Untuk complementary and supplementary medicine, kita ada evidence untuk St. John's wort, tetapi kita tidak recommend kerana kita tidak tahu dia appropriate dose, kita tak tahu dia punya drug-drug interaction, kita tak tahu dia punya side effects, ya, yang betul-betul, dan dia ada risiko untuk Sjögren's syndrome kalau kita combine dengan antidepressant. Okay, itu untuk complementary. Dan untuk special population, all special population, be it perinatal ke, elderly ke, ataupun chronic medical illness, when you want to consider antidepressant, consider the antidepressant with the least drug-drug interaction. And for monitoring and follow-up, it is based on types of medication you want to give patient, and normally the monitoring will depend on the high-risk groups and also the targeted population, bukan buat untuk semua orang, ya. Okey, so saya rasa itu sahaja daripada saya berkenaan dengan CPG MDD Depression Second Edition. Jadi saya serahkan semula kepada pengerusi majlis, Dr. Anwar. Silakan.
Okay, terima kasih Dr. Firdaus di atas ceramah yang sangat komprehensif yang telah disampaikan. Kita ada soalan Dr. Daripada audiens. Pertama daripada Dr. Azrina, dia tanya how to use non-benzodiazepine, example zolpidem in MDD patient, especially patient with sleeping problem. Is it similar to benzodiazepine?
Okay, so macam saya sebut tadi kan, bila nak gunakan non-benzodiazepine group ni, zolpidem ni, kita tak guna alone, kita guna as an adjunct treatment, ya. Dan dia dos ya untuk adult yang biasa standard dose adalah 10 mg. Tetapi untuk mereka yang kurang, apa kita panggil, bukan kurang, lebih daripada 65 ya, kita would recommend to start at 5 mg. 5 mg, ya. Dan bila kita nak start, even this is non-benzodiazepine dan juga low risk of dependence compared to benzodiazepine, sebenarnya kita juga melihat in clinical practice ada kebergantungan juga kepada zolpidem ini. Jadi apa yang kita boleh recommend, it is actually quite similar when you want to prescribe. One is an adjunct with antidepressant, never as kita panggil alone, especially sebab patient ada mood symptoms kan. So kena treat the root cause, ya. As an adjunct with antidepressant, use as a short term start with a lower dose first. Ya, walaupun dalam kebanyakan recommendation ataupun dalam buku-buku panduan farmakoterapi, mereka kata the usual standard dose for adult is 10 mg. From clinical practice, what we normally give is 5 mg first. Tengok sebab kebanyakan study yang dibuat di luar negeri adalah on Caucasian population, ya, orang putih kan. Kita Asian, body mass kita kurang ataupun rendah. Kadang-kala apa yang kita lihat, even with 5 mg, even though most would recommend 5 mg is for more than 65 years and above, what we normally do, you just start with 5 mg and see if patient can sleep, rather than start at the usual standard dose of 10 mg. Yeah, and depends on what is the patient sleep disturbance punya severity. Ya, kalau katalah kita tanya patient, if the sleep disturbance is not very bad, advise dulu dengan sleep hygiene, dengan terus start ubat. Sebab kadang-kadang sebenarnya bila kita start ubat ni, saya selalu pesan dekat trainee saya, kadang-kadang kita ni adalah terapi kepada terapis, ubat kepada kita kan. Sebab kita tak start lah, patient tak boleh tidur kan. Kita tak berapa sabar kan. Tapi sebenarnya tengok dulu, ada tak patient especially elderly kan, ada tak tidur waktu siang kan. Most of the time they sleep during daytime. You need to emphasize on the proper sleep hygiene. Need to emphasize on that. Ya, explore further. Kenapa tak boleh tidur? Ada tak tidur waktu siang ke tak? Ya, ada tak ambil caffeine ke tak? Do they sleep at a usual time on the daily practice? Kan? Maksudnya kalau tidur, kita ajar dia. Hari ni tidur pukul 10, esok pukul 10, regulate time of sleeping. Yeah. So the usage is similar to benzodiazepine. That is what the question was. Do it as less risk of dependence. We still use with caution. Yeah. So still use with caution and avoid long-term medication, apa kita panggil, administration. And particularly, even this is non-benzodiazepine, for elderly population, careful ya bila bagi benzodiazepine ke ubat tidur hipnotics yang bukan non-benzodiazepine. Elderly ni, especially male kan, bila malam dia suka pergi toilet, satu sebab diabetik, satu sebab prostate punya problem kan, dia ada frekuensi kan. Kalau mengantuk ke apa, boleh jatuh risiko of fall. Ya, so kalau perlu use, ini terkeluar sikit tajuk. Kalau perlu use, preferably non-benzodiazepine, zopidem, ataupun nak guna benzodiazepine, use the short acting. Sebab kalau guna yang long acting, patient punya drowsiness, dia punya sedation is much longer. Ya, so there is risk of fall. Kalau fall in elderly will increase morbidity kan. Patient kalau elderly jatuh boleh dapat neck or femur fracture lah, collis fracture dan macam-macam lagi. So sebab tu when giving medication is not only thinking about symptoms related to the psychiatric manifestation, also consider about the consequences on physical aspect. Itu penting sebab tu kita treat holistically. Kita treat semua sekali, kena fikir semua sekali. Okay? I hope that answer the question. Okay?
Saya rasa jawapan yang Dr. Firdaus berikan telah menjawab soalan daripada peserta. So, saya mengucapkan ribuan terima kasih kepada Dr. Firdaus Al-Ghani.
Satu soalan je, Dr. Anwar.
Ya, satu je Dr.
Saya berkubar-kubar nak jawab banyak lagi je.
Sebab dia dalam chat ni dia kata very comprehensive. So,
ya ke?
faham.
Alhamdulillah. Okey lah, faham Dah menggunakan rate kuasa luar biasa, cakap dengan sangat laju untuk habiskan 100 slide dalam masa 2 jam ni.
Alhamdulillah.
Alhamdulillah.
Terima kasih sekali lagi Dr. Firdaus di atas ceramah yang sangat komprehensif. Kita harapkan semua peserta yang mengikuti kursus pada hari ini dapat mengutip ilmu yang dicurahkan oleh penceramah-penceramah kita dalam topik yang kita kata common lah, skizofrenia, bipolar and also major depressive disorder, agar dapat kita bantu pesakit yang terutamanya di primary care lah, untuk bantu rawatan mereka di sana lah. Dengan itu kita tangguhkan kursus kita pada hari pertama hari ini dengan tasbih kifarah dan surah Al-Mas.
Thank you Dr. Vida.